The next thing that we will study now will be and revise will be aspects related to the EEG in the patient. Whenever you attach EEG electrodes to identify any abnormality in the brain, you will remember that the electrodes which are for the, like, this is the nose of the patient, nasion and inion. So the person's right side and the left side has been shown here. So remember that the electrodes which are left-sided, they are basically given an odd number for representation, and the electrodes which are right-sided are given an even number for representation. If you see the electrodes here, some are having this subscript Z. So this Z is mainly for earthing purposes. This is only to highlight that to prevent any short circuit or artifacts from coming, there are some earthing electrodes, and then obviously we have electrodes like frontoparietal or occipital or temporal electrodes, which would be recording the activity from the various parts of the brain. So once the EEG electrodes have been deployed in the patient, then we'll record the EEG, and the recording of the EEG would be referred to as montage, and we can evaluate the various waves in the EEG of the patient. A normal person, the person would be having aspects with respect to alpha, beta, and gamma. Alpha is 8 to 13 hertz. This is with mind relaxing, eyes closed. People tend to meditate and go into alpha rhythm. But if you open your eyes, you are obviously exposed to the worldly things around you. Then it would be beta rhythm with eyes opened. And it is a gamma rhythm that is 30 to 100 hertz. This is when you are indulging in, for example, a problem solving, like while you are studying right now, your brain discharge would definitely be gamma. That would be accelerating much faster. Once you know the background rhythm in the patient, you always have to see that the frequency is what that matters. So alpha will be relatively slower, beta is faster, and gamma will be even much faster in the patient. So I just symbolically here shown before you a transition from alpha to beta to gamma in a normal individual. Now once a person goes into sleep, when you start sleeping, you will close your eyes, you will go into NREM 1. That is when alpha will come because you're closing your eyes, but don't answer the rhythm of alpha as NREM 1 as I got a query for that, because when you close your eyes, obviously for sleeping, alpha would come, but the main rhythm that is going to come here is theta, that would be having a discharge frequency, because don't go for those symbols also. Now just remember discharge frequency will become lesser, 4 to 7 hertz. Then as you move into NREM stage 2, you would be having is a presence of mu waves or sleep spindles with discharge frequency of 12 to 14 hertz. And as you move into the deepest part of the sleep, that is NREM stage 3, that is where a person will be having delta waves, which would be one of the slowest waves in the EEG, with discharge frequency of 0.5 to 4 hertz in a patient. The waves would be relatively higher in amplitude and would be relatively slower. So the waves which are the slowest and have the highest amplitude are to be remembered as the delta waves. When it comes to EEG, everything that goes down is taken to be positive, and every time if it is a wave going up, it is taken to be negative. That's opposite of normal. I mean, normally up is positive, here downwards is taken to be positive in the patient. Now let's scan a couple of EEGs so that we can evaluate the information. Like in this particular case, whenever you will scan the EEG of the patient, you have to look like this, that the odd numbers are representing the left side, and then the even numbers are representing the right side of the brain of the patient. Why it is important to know that is because if the findings are present both in the left and right side, then it is a diffuse process. Now you can notice the background rhythm in the patient. This is the background rhythm that is coming, and software can tell you the exact frequency of how many waves per second are present. But then if you look at this particular EEG, you will notice the fact that there is a very peculiar deep wave that is coming here in this particular case, which is going down like this. And it is preceded by obviously a negative deflection. So there's a positive deflection downwards, and then it is preceded by 2 negative deflections. The basic point to be understood is that if you are having this wave where you are having a positive deflection downwards and preceded by 2 negative waves, then it is called as triphasic waves. And triphasic waves are totally abnormal. They are encountered in patients of metabolic encephalopathy like hepatic encephalopathy. We can see them coming once again. You can notice that there is a downward deflection which is positive, or I'll use a finer pen. You can see the downward deflection which is positive, which is preceded by 2 negative waves. So this is called as triphasic wave. Why triphasic, guys? Because normally the rhythm would be like this, no? Biphasic, positive, negative, positive, negative. Here you are seeing a positive wave preceded by two big negative waves. And then if I zoom out, you will notice that them to be present in both the left and the right hand side. Like here also, on the right hand side of the brain also, this is coming. So this highlights the process. This highlights the fact that we are talking about a global process. We are talking about a diffuse process which is affecting the left as the right side of the brain of the patient. So the final answer for this EEG would be that there is a diffuse process which is contributing to a metabolic encephalopathy in the patient. The metabolic encephalopathy can obviously be variable. The metabolic encephalopathy can be one, ammonia intoxication, that is hepatic encephalopathy, or it could be urea related, it could be uremic encephalopathy which could have contributed to this, or carbon dioxide narcosis which could have contributed to a presentation like this one. Once you remember the triphasic waves, the next one to be remembered is that when you scan the EEG, this is obviously the odd number superiorly which is representing the left, and then the even number for the right hand side, and you are noticing that there is a presence of high voltage bursts. These high voltage bursts that you are noticing are present in both left as well as the right side. This kind of a presentation can be anticipated in patients who are having GTCS, that is generalized tonic-clonic seizures. But if you look at the EEG which is present inferiorly, you will notice the fact that the left side of the brain is not having any particular abnormality, but the abnormality is located in the right side, in the sense that the patient is having this segment of a high voltage burst seen. So the diagnosis of this particular recording would be given as focal seizures in the patient. These focal seizures are also being noticed in the temporal leads of the patient, that is T4, T6 as you can see. So this usually tells us that the patient could be having a temporal lobe epilepsy, which could be associated with the clonus in a patient, or could be associated with the tonic or clonic manifestations. So the basic point is that the discharge will be occurring in only specific leads. Whereas in the third recording, you will notice the fact that patient is having slowing of the EEG, which is having this spike pattern. So every 1 second, because there is 3 per second spike pattern, and because it is slower than the delta, so it is called a spike and slow wave pattern. This is responsible for obviously absent seizures in a patient. Absent seizures can be triggered by photic stimulation. I mean, bright light can trigger this, or hyperventilation can trigger this. You cannot trigger any kind of seizures in the laboratory, but bright light or photic stimulation, or for that matter of fact hyperventilation, can trigger absence episodes in a patient, and therefore you could be having these manifestations that I have highlighted before you. Then subsequently, you have to remember a EEG pattern which would come in this particular fashion. You will notice that in the EEG there is a background rhythm, and then there is one negative deflection like this, one negative deflection, and this is occurring on a recurrent basis in all the leads. You can see that the right-sided leads in the patient as well as the left-sided leads in the patient are having the same problem. There is a recurrence of these negative waves which are coming up in the EEG again and again and are being repeated periodically. Because of the periodic recurrence, we are going to call it periodic. They pointed, so we're going to call it sharp wave complexes, periodic sharp wave complexes, or PSWC. Is a EEG finding which is very, very classical for patients who are having presence of variant Creutzfeldt-Jakob disease, that is VCJD in a patient. This would be a prion disease which would be contributing to damage to the brain, and therefore the cytoplasm of the neurons is having multiplication of the prion particles in the patient. Then I also want to bring to your notice, you can see that once again I've shown you GTCS, where you can see all the leads of the patient are having a presence of high voltage burst on a regular basis, both left and right sided. But if you scan through the inferior one, you will notice the fact that the patient is having a presence of the clinical discharge that is given in the question is that of a PLED, that is a periodic lateralized epileptiform discharge. Coming to the next slide, I want you to remember a term by the name of Hifz arrhythmia. Hifz arrhythmia, when you read it for the first time, it will look like you are dealing with a question of cardiology, but here it simply means that there is a grossly chaotic pattern in the patient. The highlight of Hifz arrhythmia would be that no pattern can be appreciated. I mean, this is totally a mess that you can notice. There is no frequency, and in fact, the frequency is changing on a second-to-second basis. This is a characteristic feature of infantile spasms, which are also called as West syndrome. Or is also referred in multiple choice questions as salam seizures. That's the only Hindi word in medical literature. There would be myoclonic jerks of the arm of the child for which ACTH injections are used. So Hifz arrhythmia is a grossly chaotic pattern. Whereas if you look at the subsequent one, the patient is having early morning high voltage bursts present in the EEG, again present in all the leads, but at the same time, these bursts are having a very peculiar pattern. That is, the spikes are present and the spikes are also not of the equal size. The spike which is present is not of the equal size, that is highlighted here. So because the spikes are not of the equal size, I'll just erase it so that you can relate to this better. The spikes are not of the equal size. Therefore, the term that we use to describe this pattern is called as 4 to 6 hertz, because about 4 to 6 waves are seen every 1 second. 4 to 6 hertz polyspike pattern, and this is a feature that is very characteristic of juvenile myoclonic epilepsy, which is also called as Jan's syndrome. The patients of myoclonic epilepsy in future will end up with GTCS, so the prognosis of this condition is really bad. Then another term that I want you to remember is that there would almost be a flat isoelectric line like this, and then in between you are getting these waves, which is called as burst suppression pattern. Burst suppression pattern is a feature that is encountered in following conditions, which I want you to remember, at least 3 for today. Coma, hypothermia, and drug intoxication are 3 conditions where burst suppression pattern can be noticed in the patient, where there could be a flat line with few eccentric abnormal bursts seen with no particular frequency, and all the waves would be of different patterns. Let us now summarize what are the EEG findings which are to be remembered by us, especially for the exam perspective. So we will just practice the various EEG patterns that are shown, like in the background rhythm, not a flat isoelectric line, you are noticing a high voltage burst, and this is occurring on every 1 second interval. It is going to recur on every 1 second interval. Then we are going to call it a periodic sharp wave complexes, PSWC. The interval between these complexes will be fixed, that is every 1 second you would be having a high voltage burst. Compare this with what I'm drawing now before you, where you're getting these high voltage bursts, but the distance between them is not equal, versus a flat line coming up with these few bursts or variable amplitude like this. Then the interpretations of the 3 are totally different. The first one will be called as periodic sharp wave complexes, that is PSWC. These periodic sharp wave complexes are a feature of variant Creutzfeldt-Jakob disease. But in the inferior one, you will notice that the distance between these waves is not constant. The distance is obviously changing because of the variation in the distance in this particular case. One, this is called as Rademacher complex. And this is a feature that is seen in patients who are having a condition which is a late neurological feature of complication of measles, that is called as subacute sclerosing panencephalitis, SSPE. The next one is having what is called as burst suppression pattern. This is encountered in patients of coma and drug overdosage. Then if you are having a background rhythm like this, and then you start having spikes of the equal size with the patient staring at your face and the background rhythm getting restored. In all the leads, you are getting waves of the equal size, and then the rhythm is restored in the patient. Then this would definitely be an absent seizure in a patient, where you will notice that the patient would be having a vacant staring spell. But in the background rhythm, if you get these bursts like these of unequal size, and the frequency is 4 to 6 hertz, then that would be juvenile myoclonic epilepsy. If it's all erratic, then the entire erratic pattern is called as hypsrhythmia, which is a feature that is seen with infantile spasms or West syndrome in a patient. There is a pattern in which you will notice relative slowing. Then I've shown a triphasic wave once again before you. Here I'm just using a different ink to highlight the fact that triphasic waves would be pointing inferiorly downwards. They can be a variable amplitude also. Like you might get one that is more broader than the others, and might be bigger in amplitude also. So triphasic waves, which I have now drawn before you, are features that are encountered in patients of hepatic encephalopathy. These are a couple of EEG patterns that you need to remember. I've not drawn for GTCS because I think that's the easiest one to understand. All the leads would be having in focal. There would be limited patterns that would be noticed. The one that I'm not hand drawn here, but I still want you to remember now, is called as PLED. PLED is called as periodic lateralized epileptiform discharge. This periodic lateralized epileptiform discharge is a characteristic feature that is encountered in patients of herpes simplex encephalitis, where you would be having a bloody CSF in the patient and a possibility of amnesia developing as well. These are the terms that they have asked in various years for the various episodes of seizures, so it's a good idea to try and remember and hand draw this with me. And obviously these diagrams that are drawn before you, if you look at them at least once, you will be in a better orientation to remember GTCS, focal versus absence versus PSWC. And then I have also taught you regarding a grossly chaotic pattern versus juvenile myoclonic epilepsy. With the help of this information, let's scan this EEG of the patient, which though is very clear. Hepatic encephalopathy is ruled out because there should be triphasic waves. You cannot see any triphasic waves with a downward deflection occurring, which is very significant. And even if you might say that, okay, doctor, this is a downward deflection, okay, but then it is not preceded by a equal amount of negative waves prior to that. So I would rule that out to be a triphasic wave in the EEG of the patient. Then GTCS would be having high voltage burst in all the leads, so I have ruled that out. Herpes simplex will again be causing only temporal lobe predilection in the patient. Herpes has a predilection for temporal lobe, so therefore most of the time the abnormal discharges would be seen in the temporal leads only. The correct answer to this would be CJD, that is variant Creutzfeldt-Jakob disease, which is a prion disease, and I'll make you revise prion disease in a separate slide, but at the moment it is the EEG patterns which you have to basically remember. These are the names which are to be remembered specifically. A new thing that I've introduced here is that of subacute sclerosing panencephalitis, which is a late neurological feature of measles, and even the presentation of this one is myoclonus. So what are the conditions that are causing myoclonus? Let's revise that also. If myoclonus is given to you in a child less than 1 year of age, it is always a question of infantile spasm. But if myoclonus is given to you at something at 8 years of age in a child who's already had measles, or even if he does not mention measles but says neurodegeneration in a child, it is SSPE, subacute sclerosing panencephalitis. If the age of the child is 10 to 19 years of age and he's having poor performance at school, early morning episodes of involuntary movements in his hands, then it is juvenile myoclonic epilepsy. And if the same question comes at something like 35 years of age, myoclonus with dementia, then myoclonus with dementia is a feature that is seen with VCJD in a patient, that is variant Creutzfeldt-Jakob disease. So these are some of the aspects that I want you to remember, and especially like I told you that in some questions of myoclonus, you will rather notice the fact that age will be very helpful for identifying the presentation of the patient. And then is PLED, periodic lateralized epileptiform discharge, versus PSWC, that is periodic sharp wave complexes. So obviously both of them are different, and for Creutzfeldt-Jakob disease and herpes simplex encephalitis respectively. Okay, after studying regarding the various EEG patterns, let's just quickly revise regarding the various types of seizures, and I'm mentioning regarding the latest classification for the seizure types, which would classify it into focal, generalized, or unknown onset. In focal seizures, there can be two possibilities. One, the patient might lose consciousness, or he might be aware of his surroundings. I mean, earlier the words used were simple partial seizure and complex partial seizure. So for older MCQ, simple partial seizure was where the patient was conscious and aware of his surroundings and used to describe his symptoms. And complex was where the person used to lose his consciousness. But now it is basically focal onset with awareness or impaired awareness instead of using the word complex partial seizure. The manifestations could either be in the form of automatism. What you mean by the word automatism is, I would say, emotional behavior on the part of the patient. Like he might be having continuous smiling and laughing, and along with that he might be doing continuous lip smacking, he's licking his lips with his tongue, or he might be having restless behavior and he might be crying, or he might be uncontrollably giggling and laughing. So automatism is like automatic behavior with lack of control over emotions. Atonic, as the name suggests, will be associated with a fall because the tone of the muscles will increase, and tonic would be opposite of it, where the body will become stiff and then there would be jerky movements with respect to clonus in an individual. So clonus is involuntary jerking of the body. Like he might say that there was an involuntary jerking in one of his hand, or like in the elbow or half side of the face was having uncontrollable jerking movements. Myoclonus would involve only few muscle groups. Like clonus means involuntary movements, but then few muscle groups, if they're having twitching, like in the hand they would be only of the thumb, and maybe it could be involving the big toe of the foot also. So myoclonic seizures are involving only few muscle groups. Not all patients might be having only motor manifestations. Some might be having maybe sensory stimulus, like in temporal lobe epilepsy, there might be olfactory hallucinations in the patient or gustatory hallucinations in the patient, because temporal lobe is related to the sense of smell, and it is related to taste sensation. So patient might complain of metallic taste in the mouth or sour taste in the mouth. So gustatory hallucinations and olfactory hallucinations are seen with temporal lobe epilepsy, which is related to focal only because only one part of the brain is basically involved. Or for that matter of fact, patient might be having a GTCS. One of the common type of seizures that is seen in adult onset is GTCS, and the same presentation of tonus and clonus can also be present in febrile seizures with respect to children. Though children, if I say neonates per se, neonates would be having presence of subtle seizures. That is because children, newborn babies especially, they do not have a fully developed central nervous system, so we don't expect a classical tonus and clonus to be present. So neonates usually do not have complete myelination, and therefore there would be subtle seizures which would be characterized by jitteriness. The common type of seizures when it comes to children, if he says what is the commonest type of seizures in children or commonest epilepsy in children, epilepsy means tendency for having development of seizures. So epilepsy basically implies when it comes to children, the most common type of epilepsy is benign or Rolandic epilepsy. If he says what kind of epilepsy or seizure disorders is seen with neurocysticercosis, then it would be focal seizures in a patient. I'll repeat the information again. Neonates is subtle seizure. If he says what is the most common type of seizure in a child, then it is obviously febrile seizure. For epilepsy word, it is benign Rolandic epilepsy in children, which is the commonest epilepsy in children. So these are three questions from pediatrics that I've covered. And then I wanted to remember obviously the presentation adults, which could be GTCS, or there could be focal seizures with or without presence of loss of awareness in the patient. Now, once these manifestations will evolve in a patient, we will obviously have to give drug treatment. Remember that aura is not a feature of GTCS. Aura may be encountered in focal seizures, or aura can be heard or appreciated in migraine. Aura means that patient could be having visual blurring. That visual blurring of autopsy or scotomas that might be appreciated is not a feature of GTCS, but can be seen in focal or can be seen with migraine. Then the drug of choice for management of atonic seizure, myoclonic seizure, and absence seizure is sodium valproate. Obviously, if it's a smaller child, less than 4 years of age, we don't use valproate, we use ethosuximide. But otherwise, absence seizure in a 10-year-old child, 12-year-old child should be answered as valproate. Smaller child is ethosuximide. For febrile seizure during the episode, it is intranasal midazolam or rectal diazepam. And for prophylaxis, that is oral clobazam. This would be called as intermittent prophylaxis. What I mean by intermittent is that whenever the child is having a presence of febrile episode, whenever he is having fever, we would be giving oral clobazam to prevent the episode from occurring in the patient. Then infantile spasm is also called as West syndrome and is characterized by myoclonic jerks in the child, which would be called as salam seizures, the jerky movement in the arms of the child. This would be treated with ACTH injections. But if he mentions the word neurocutaneous disorder associated tuberous sclerosis, then the answer is given as vigabatrin. Status epilepticus as a term is an outdated one. Currently, the term that they will use will be GCSE. That is generalized convulsive status epilepticus. Then for GCSE in a patient, that is generalized convulsive status epilepticus, if the seizures are continuing for a duration more than 5 minutes, then we will say it is GCSE, for which lorazepam would be given. But if you have given all the standard drugs, like you given phenytoin, fosphenytoin, valproate, then levetiracetam in the patient, and still there is a continuous episode, then we will be giving midazolam to the patient, and we will plan for giving general anesthesia because we need to ensure neuromuscular paralysis in the patient. For GTCS, my reference is the 20th edition of Harrison, page number 3064. I've kept that specifically, that for GTCS, the drugs he has mentioned are obviously valproate is one of the drugs which is used, no doubt, but he has also mentioned regarding lamotrigine and levetiracetam. And then a shocking change that is mentioned in the current episode is, or in the current edition is, that if he says there's a female patient with epilepsy, the drug to be used is levetiracetam and lamotrigine. He's written like this only, first levetiracetam and lamotrigine. So in the previous editions, lamotrigine was the only one that was mentioned, and he was saying that do not use valproate because the incidence of neural tube defects with sodium valproate goes up to as much as 10%, which is one of the most teratogenic drugs, I would say. But instead of lamotrigine in the current edition, he has mentioned levetiracetam. So if given in questions and you have to select between lamotrigine and levetiracetam, you should select levetiracetam followed by lamotrigine in the patient. Reference page number of Harrison I've given, so I don't think so there is any cause of confusion for this one. And yes, the confusion between ethosuximide, valproate, this controversy has been going on, guys. I mean, don't bother much about it. And this would be a list for drugs of choice for epilepsy. If you have any issues with this list, do let me know in the query section, because I would like this to be error-free and I would like this to be a very straightforward answer in your part. So there should be no confusions in your mind. I have taken reference from the textbook which I have quoted, and if you have any alternative references, most welcome, but do not quote any individual per se, just quote the textbook and I'll be very, very glad to assist you with this. The next aspect to be remembered is GCSP score. You would have noticed that the update of Glasgow Coma Scale would be GCSP score, where we are also taking care of the situation of the pupils of the patient. So let's first focus on the pupil part, and then we'll come back to describing what is the GCS score of the patient. You will shine a torch in the eyes of the patient and check for the pupil status, that is, pupils are unreactive to the light of the patient, light which you are shining in the eye of the patient. Now, if you notice that both of the pupils are reacting, then obviously it's a 0. If you notice one pupil is unreactive to light or partially reacting to light, I would say then it is Hutchinson pupil, that would be a score of 1. And in case both the pupils are unreactive to light, that would be a score of 2. And what you're supposed to do is that you are supposed to subtract this number from the GCS. Like, for example, you have calculated the GCS of the patient from V4, V5 and M6, you have calculated the GCS of the patient to be 10. And then you are noticing in the patient. So suppose you have calculated the GCS of the patient by E4, V5 and M6 to be, let me say, a value of 5, and you are noticing that one of the pupils of the patient will be unreacted to light. So the final score of the patient would be in GCS-P. You will have to subtract 1 mark because the one pupil is non-reactive for this, and the final score of the patient will turn out to be 4 in the patient. And in case any element is non-testable, then you will anyway write the word NT behind it. So let's just now look at it in totality. You see, if you go to the bedside of the patient and he opens his eyes spontaneously, it would anyway be 4 marks. But if you go to the bedside, he does not open his eyes spontaneously, you will call out his name. When you call out the name of the patient and he opens his eyes, that is 3 marks. But if he does not open his eyes, you will call out his name twice, and then you will have to deliver pain stimulus to the patient, and patient can open his eyes. To deliver the pain stimulus, you can press on the nail of the patient, you can press on the lunula of the patient. I mean, that rubbing that sternum looks very offensive to the relatives. So he says either you press on the lunula nail of the patient, or for that matter of fact, you can press hard on the supraorbital margin of the patient to deliver the pain stimulus in the patient. And if he opens his eyes to the pain stimulus, it's obviously 2 marks. Or you can be having no response, that is obviously a 1. I personally feel that when you read the MCQ for eye opening, there will absolutely be no issues for you to ever work out. Now let's talk about the verbal response. You went to the bedside of the patient, you started talking to the patient, and he says that, yes, doctor, hospital is a horrible place to be. I don't want to be here. I've been admitted since morning. When will you discharge me? So he is oriented to time. He says since morning. He says, I'm oriented to place because he knows he's in the hospital. So if a person is oriented, he's addressing you as a doctor, he knows that his own name is personal details. So orientation to time, space and person is there. But suppose you went to the bedside of the patient and you notice that the patient is cannot tell you whether it's morning, afternoon or evening. Like you pointed out to him what time is it at the moment, and he's looking here and there. He does not know that what time is it, and then you ask him, where are you? And he cannot even tell that he's in the premises of a hospital. Then you point to a nurse and you say, who's she? And he's just staring at her and says, that's my wife, maybe. So he's calling healthcare worker a family member. That is disorientation to any one of these. If disorientation is to time, if it is to space, or it is to person, then disorientation to any one of these, the score will be 4 marks in the patient. You told the patient, sir, what's your cell phone number? And he's saying something which might be something abusive. Now you asked him a cell phone number and he's giving you abuse, and this person is obviously confused. He's dazed, but he's not answering your question. At least the previous person was trying to answer your question by looking at the nurse and then saying, okay, this person is my wife. This time he's using abusive language. Inappropriate words basically means that the question and the answer are totally diametrically opposite. Whatever he is saying is having no bearing on the question that you have asked to the patient. You ask the patient, what is your cell phone number, sir? Can I call up your relatives? You have been here since morning in the hospital. I mean, I'm giving him leading questions. You are in the hospital. I want to call up your relatives. Tell me your mobile phone number. And he's mumbling something. I could not understand what he's saying, so I called up my doctor colleague and I said, I will repeat my question, and asked my doctor colleague again. In front of my doctor colleague, I asked the patient, what is your cell phone number? I want to call your relatives. You are in the hospital since morning. And he says something that even my doctor colleague cannot understand. That is mumbling by the patient, like sound. So that would be 2 marks. And if it is obviously no orientation, then no verbal response, that would be 1 in the patient. So the difference between inappropriate words and incomprehensible sound is that in inappropriate words, at least he's trying to say something, but in incomprehensible sounds, there is no sounds coming from the part of the patient. Now comes the motor activity, which will be the deciding part in the MCQ for you. So for this, I want you to listen very, very carefully. Obeying command would be like, form a wrist, squeeze my finger, and form a wrist, and try to form a fist. So that's definitely 6 marks if a person can obey commands, or move the thumb of your right hand and move the big toe of your left foot. So if patient is following your commands, that is 6 marks. But if the patient is not able to follow your command, Then what you will do is you will give pain stimulus to the patient. Like in this image, if you see, I'm providing a pain stimulus to the patient, and what he's doing is he's immediately raising his hand and he's trying to push my hand away because it is hurting. I'm pressing here hard, right? So he's trying to raise his arm and push my hand away. That is localizes pain. So this activity of the patient will give 5 marks. That is, he is himself not following my commands, but when I have given a pain stimulus, the patient is at least able to localize the pain. Now compare this with the next diagram, in which when I'm giving pain stimulus to the patient, he is trying to push away my hand, but you can see that he has not been able to reach my hand and push it away. Like there is a slight outward movement of the arm of the patient, slight outward movement, but he is not able to like push my hand away from the site of the stimulus. That would be 4 marks for the patient. That would be called as what we technically called as normal flexion. So the word normal flexion here basically simply means the fact that patient's arm is moving upward, slightly outward, maybe not above the level of the head, but he is trying to at least his brain is registering the pain stimulus. He is trying to push it away, though he is not able to. Now when you compare this with the next activity, you can see that I have given him a pain stimulus, but when I've given him the pain stimulus on both of the supraorbital margins, what is happening here is that he is not trying to move his arm upwards. Rather, you can see the fact that he is trying to move his arm like this. He's trying to move his arm like previous movement was, I'll repeat that again. One is he is able to push my hand away. If I'm pressing here, push my hand away. Second is he's showing a partial flexion, but is not able to push my arm. Another possibility is when I'm giving him pain stimulus, he's doing like this. He's moving his arm rather inward. So the arm is still flexed, but it is an inward movement that is occurring in the patient. This is what is called as abnormal flexion. This would be 3 marks in a patient. And if you are noticing that on pain stimulus there is a presence of extension in the arm of the patient, this extension that I've highlighted before you would be 2 marks, and obviously if there is no movement, that would be 1 in the patient. So that is what I've highlighted here before you. Let's practice this again. Obeys commands, that is forms of fist, is 6 marks. Localizes pain and push your hands away would be 5 marks. Normal flexion is obviously flexion is there and is trying to raise the arm to go to the pain stimulus, never is able to reach the side, that is normal flexion. Abnormal flexion would be he's moving his arm inward, that is abnormal flexion. Then is the extensor response, and then would be nil response in a patient. Whatever value that you will calculate, from that you will have to subtract the pupillary score of the patient, and that would be the final score of the particular individual. And they are usually giving you at least 1 question on GCSP, and NT score means that NT basically means that it cannot be evaluated in the patient. Like for example, if he gives you a scenario of an intubated patient and he says the fact that this intubated patient can follow commands and he is also having spontaneous eye opening, because you have reduced the sedative of this particular patient and you want to extubate him, you have even stopped neuromuscular paralysis drugs in the patient, then patient is having also a presence of spontaneous eye opening. Then the score of this particular patient would be answered by US. For spontaneous eye opening, that would be 4 marks, follows command is 6 marks. So this would be answered as 10 NT. This is the maximum score that is possible in any intubated patient. I repeat my statement again. The maximum score possible in any intubated patient would be a score of 10. So in the exam, because when he will give you a scenario, most of the time the values would be turning out to be less than 10 only. So do practice this parameter. GCSP, however, has not been given in Harrison, though it is given in a lot of websites, and some authors have also mentioned about it. But I just want to highlight the fact that at least the GCS part should be very clear before you, because Harrison has not mentioned regarding the validity of the GCSP very significantly. GCS he has highlighted. Any value less than 8 is definition of coma. Any value less than 8 is also an indication for intubation. The reason why I'm saying GCS less than 8 is an indication for intubation is because the person will not be able to secure his airway, and therefore chances of aspiration would be fairly high. So therefore we should definitely intubate at values less than 8 in the patient. Next we'll study regarding brain hemorrhage in a patient. The first and the foremost brain hemorrhage that you can notice here is presence of blood in the sylvian fissure of the patient. You can also notice the presence of blood in the interhemispheric fissure of the patient. In fact, in this image, even the blood is present in the ventricles of the patient. So the topic that we're studying here is subarachnoid hemorrhage. For revision purposes, first and the foremost aspect to be remembered is that subarachnoid hemorrhage can be classified as primary and secondary. If he says what is the leading cause of primary subarachnoid hemorrhage in a patient, then your answer would be given as rupture of a berry aneurysm. Primary would mean that there is an intrinsic weakness which is resulting in a rupture. So it could be rupture of berry aneurysm. It could be rupture of a mycotic aneurysm. Remember, mycotic aneurysm is formed after infective endocarditis process, or for that matter of fact, he can mention regarding Charcot-Bouchard aneurysm. When would you be having a Charcot-Bouchard aneurysm? Then I hope you recall that Charcot-Bouchard aneurysm is a complication of hypertension. The cutoff for hypertension, repeat again, is 140/90 by the current edition of Harrison. So don't go by the AHA update of 130/80. That is like if he specifies, okay, AHA 2017 guidelines, there is no AHA 2019 update. It's 2017 that they've come up with this new information. So hypertension can cause Charcot-Bouchard aneurysm in a patient. If he says secondary subarachnoid hemorrhage, then the leading answer should be given as trauma in the patient. And if he does not specify like primary and secondary, then obviously the leading cause would be trauma followed by the remaining causes. Now, once subarachnoid hemorrhage will occur in a patient, the presentation will be that of very classical thunderclap headache in a patient. Either the patient will say the word that I am having the worst headache of my life, or like in American textbooks, it will be written thunderclap headache. Though Indian patients to say thunderclap is a little unlikely. So worst headache of my life is a phrase that is more apt. These patients will usually also be having warning leaks. What I mean by the word warning leaks is that a few days before the actual berry will rupture in the patient, there could be a possibility that the patient might be having a development of excruciating headache, and this headache can be so severe that he might even develop a vasovagal syncope. So vasovagal syncope can be a presentation of the impending rupture of berry that might occur 24 to 48 hours before the actual berry will burst in the patient. These patients can also be having dyselectrolytemia. The reason for dyselectrolytemia in these patients is that since this is a horribly painful condition, there would be a release of BNP, B-type natriuretic peptide, which would be contributing to natriuresis and salt loss and water loss from the body, and the salt loss can be severe enough to result in hyponatremic seizures to develop in the patient. The reason for seizures in subarachnoid hemorrhage is not the irritation of the brain by the blood, but it is actually the electrolyte imbalance secondary to release of BNP. We have discussed BNP in cardiology section with respect to heart failure, but it is released both from the ventricles of the heart and the ventricles of the brain. So BNP is written in discussion of even subarachnoid hemorrhage. So seizures could occur. So these are the four usual reasons why patients could be presenting to you, and seizures may or may not be given in the question depending on the presentation. Now, to diagnose this condition, you will have to obviously do a quick workup, which will involve going up and doing a CT scan. And the characteristic feature that you will notice on the CT scan of this individual would be a presence of blood in the Sylvian fissure. What is Sylvian fissure? Then Sylvian fissure is the area that would be separating the parietal from the temporal lobe. So blood in the Sylvian fissure is a very characteristic feature that you will encounter. He might even ask you what is the source of blood here. So the major source would be middle cerebral artery. I mean, all of you know the fact that this area of the brain, the major blood vessel supplying is MCA, anteriorly is ACA, and posteriorly would be posterior cerebral artery. So it is MCA territory where Sylvian fissure is present, or if he specifies that there is blood in the interhemispheric fissure of the patient, then in these circumstances, in the interhemispheric fissure part, the answer of yours would be given as anterior cerebral artery. Non-contrast CT scan is best to identify this condition. To trouble you in the MCQ, he might even mention regarding lumbar puncture findings of this patient. You obviously have to be careful while doing a lumbar puncture. You have to do a guarded lumbar puncture. You have to ensure that we have given mannitol, raised ICT should not be there, and then you will obtain a bloody CSF in the patient when neutrophils will be present in the CSF, maybe because the blood could be containing neutrophils, but that is not a feature of obviously meningitis, because there the neutrophils would be in very large amount. Here occasional neutrophils can be seen, or he will obviously bloody CSF will have all the blood cells that would be present. In this condition, if the lumbar puncture is delayed by 24 hours and you will repeat the lumbar puncture of the patient, then due to the RBC lysis, bilirubin will be produced and the color of CSF will now have a yellowish tinge, and this yellowish tinge of the CSF is called as xanthochromic CSF. So routine CSF will be bloody if done in first 24 hours, but after 24 hours xanthochromic CSF can be elicited in this particular patient. The third test that I will do after a CT scan and a lumbar puncture in this patient would be to check for electrolytes. I will be doing a serum sodium in this patient. I need to get a baseline serum sodium since hyponatremia could be there. And I will also do ECG in the patient because a lot of these patients can be having so much of catecholamine excess that there could be a possibility that these patients could be developing even MI. Most of the time the MI that will develop in this case would be a non-ST elevation myocardial infarction, and because of the non-ST elevation myocardial infarction developing in this case, there would be a ECG finding of T-wave inversion that would be developing in this particular individual. So T-wave inversion can also be remembered as ECG finding of stroke. In fact, a very surprising MCQ because subarachnoid hemorrhage would also be a variety of stroke only. So one of the ECG finding of stroke to be remembered by you is T-wave inversion. I have taught you T-wave inversion for following situations. It is found in MI, both STEMI and non-ST elevation MI, unstable angina, hypokalemia. So now you know 4 causes of T-wave inversion: MI, unstable angina, hypokalemia, and then stroke also, that is subarachnoid hemorrhage, can also be having these findings. Once I've done a workup of this patient, then I will assimilate all the findings in this person, and I will be evaluating this patient for the following facts. You see, because there is blood in the meninges of the patient, nuchal rigidity will always be there in patients of subarachnoid hemorrhage. If you get a multiple choice question in which thunderclap headache word is not given, only headache with nuchal rigidity is given in the question, because fever is not given, only headache and nuchal rigidity is given. There might be some episodes of vomiting described in the question. Then headache plus nuchal rigidity should be answered not as meningitis, but you should answer it as subarachnoid hemorrhage in the patient. In these patients, why do you get a nuchal rigidity is due to the irritation of the meninges by the blood. So blood in the meninges always contributes to a development of meningeal irritation, obviously, and that will explain the nuchal rigidity of the patient. Usually the cranial nerve that can be involved in these patients is the third nerve palsy. If the berry is located in the vicinity of the, or is present in the posterior communicating artery, then usually third nerve palsy is seen. If the question says what is the most common cranial nerve involved in unruptured berry aneurysm, the answer would be given as the third nerve. And if he says what is the most common cranial nerve involved in ruptured berry aneurysm, then the answer is not sixth nerve. I agree, raised SVT causes sixth nerve involvement, but whether he says unruptured or whether he says ruptured, it is third nerve palsy. Why I'm saying that is because if a unruptured will press on the third, then rupture will again contribute to pressure on the third, and therefore there could be a presentation of a ptosis developing in a patient. So examination findings in a patient of subarachnoid hemorrhage, which I have not said earlier, can be, apart from nuchal rigidity, ptosis and a development of squint can be given in the question. This is because of the third nerve palsy that will develop in this particular patient. Once you have evaluated the patient clinically, let's reveal the findings here. There could be nuchal rigidity present in a patient, there could be ptosis, there could be squint present, and obviously you will check the sensorium of the patient based on the GCS value of the patient. If in any question he is mentioning that there is a presence of a cranial nerve palsy in a patient along with the standard features of headache and nuchal rigidity, that means by Hunt and Hess score, which is for the severity, we will grade it as grade 2. You see, grade 1 is very straightforward. Patient will either be asymptomatic with a mild headache, or there might be a presence of intact aneurysm in the patient, and that had actually just ruptured. So 0 and 1 is very, very subjective, but 2 will definitely be having a severe headache with nuchal rigidity with cranial palsy in a patient. As the patient will deteriorate further, you will notice that the GCS of the patient will begin to fall, so there would be confusion coming up in the patient. Then there will be a development of a hemiplegia developing in a patient, and then posturing developing in a patient. So I think at least if you can remember 2 and 5, the remaining can fit in. That is, for 2 it's a cranial palsy, for 5 it is a decerebrate posturing. In between the two, you just need to remember there is confusion versus a focal deficit. What I mean by focal deficit is hemiparesis starting to develop in the patient. So as the GCS values will fall, WFNS is World Federation Neurological Society, World Federation Neurological Society grading, where they have just taken into consideration GCS of the patient with motor deficit. Motor deficit would mean like arm weakness in a patient or hemiparesis in a patient. So as the GCS will become lower, that means the patient will keep on deteriorating. So you can obviously remember at least 2 statements of mine. That is, Hunt and Hess score 2 would be cranial palsy in a patient where there would be a GCS of 13 to 14 with no motor deficit. Motor deficit implies no hemiplegia or arm weakness in a patient. Once the motor deficit starts appearing in a patient, the patient will start appearing confused, the GCS will become relatively lower, and if there is a hemiplegia, the score would obviously be something in the range of GCS would be 7 to 12, stupor implies less than 8 anyway, and then there would be obviously a decerebrate posturing developing in a patient. Now, even if they don't ask you the grading of the severity, they can definitely ask you regarding the treatment management of this patient and why the patient will die. So one of the leading causes of death in cases of subrecurrent hemorrhage, the question says, why does a patient of subrecurrent hemorrhage die? Then one of the leading causes of death would be answered by you as vasospasm of the surrounding blood vessels. Wherever the rupture has occurred, surrounding area where there's a vasospasm, that is where the death would occur. Yes, bleeding will cause a problem. Rebleeding will also occur in this case. We tell these patients not to do excessive laughing or crying because emotional trauma, if he's crying, there could be a rebleed in the patient. There could obviously be hydrocephalus developing in this patient subsequently. Even MI can occur in these patients. Even electrolyte imbalance of dangerous hyponatremia can cause seizures in the patient. All of these will add up and will contribute to the deterioration. But one of the important causes of deterioration of these patients is vasospasm, which could present as a delayed neurological deterioration. You will notice that the patient had this nuchal rigidity, and after a few days, he is going to deteriorate even further because the surrounding blood vessels are now undergoing a protective spasm. So the sensorium of the patient will become relatively reduced, or there could be focal deficits that would be appearing in the patient. So it's not that this is a one-time event. There is obviously a progressive neurological deterioration occurring once subrecurrent hemorrhage has occurred in an individual. Once you remember that, then is the time for treatment of this patient. So the treatment of choice for subrecurrent hemorrhage, the drug of choice is to be answered as nimodipine. And why nimodipine is the drug of choice is because it will prevent the vasospasm of the surrounding areas. The chances of this particular individual having a rebleed is also very high, and in fact it could be from the same berry or a different berry that could be present in this patient. Let us also quickly revise the questions on berry that have been asked in the various years. One of the recent questions that has been asked on berry aneurysm is from pathology, where they've asked which layer of the blood vessel is involved. So actually the layer of the blood vessel that is involved happens to be the internal elastic lamina. This would be very close to the intima, tunica intima. And due to this weakness with respect to the damage or the, I would say, inbuilt defect in the internal elastic lamina, a berry would develop in the patient like this. There would be a neck, there would be a body of the berry, and the neck is mainly where the internal elastic lamina is deficient, and the tunica medial erosion subsequently also occurs. But the primary defect in the patient is in the internal elastic lamina. Then he has asked you regarding the site, where he has asked 3 aspects. One is asked what is the leading site, that all of you know is the anterior communicating artery, where it meets with the anterior cerebral artery. Now, if it is a big aneurysm, if the size is more than 7 millimeter, 8 millimeter, it can obviously rupture. So most common is anterior communicating artery, but the site where rupture is prone. Then for rupture, the size of the berry also mentioned matters, and the location matters. The rupture prone location is top of the basilar artery. The prerequisite is that the size of the berry should be at least more than 8 millimeter and at the top of the basilar artery, then it's going to rupture. Then he has asked about that where is it rarely located. So I would say that the rare location would be the vertebral artery circulation, whereas the remaining circulations berry is fairly commonly seen. Then he will say that at what site it should be present to result in third nerve palsy in the patient. This would be the posterior communicating artery, where the oculomotor nerve would be traveling anteriorly and it will press on the oculomotor nerve, resulting in the manifestation. Even if it is an unruptured berry or a ruptured berry, these are the nerve usually involved is the third nerve. Conditions which they have asked for third nerve palsy and we can revise are: third nerve palsy is seen with midbrain stroke, that is Weber syndrome, Benedict syndrome, Nathaniel syndrome. The combination of Benedict and Nathaniel. The combination of Benedict and Nathaniel is called as Collard syndrome. This will be having features of both basal ganglia as well as of the cerebellar lesions. Then third nerve palsy is also encountered in diabetes mellitus. But here the MCQ will say third nerve palsy with pupillary sparing. This is 2018 NEET. They have asked third nerve palsy with pupillary sparing. This is a feature that would be encountered in patients who are having diabetic neuropathy. Then another cause for third nerve palsy to be remembered is berry aneurysm rupture. It could be both a ruptured as well as an unruptured one. Then is Miller-Fisher syndrome, which could be having a third nerve palsy in the patient. So these are some details for third nerve palsy or causes of third nerve palsy that are usually asked. And for diabetes, it is always with pupillary sparing, so light reflex would be preserved in the patient. The last two questions on berry to be remembered are unruptured berry, the investigation of choice, which would be a MRA. And if he specifies the word patient is having a ruptured berry, then for ruptured berry, obviously a non-contrast CT scan should be done. If he says what is the treatment of unruptured berry, then we have to discharge the patient pretty early, because nowadays if you tell the patient that I am gonna do a aneurysmal clip procedure, aneurysmal clip procedure is an invasive procedure which patient will have to spend multiple days in the hospital. Everybody wants an early discharge, so endovascular coiling is done where the patient can be discharged the next day or maybe sometimes the same day, where we do a platinum wire deployment in the aneurysm, and this platinum wire will give structural support to the berry and will subsequently cause fibrosis in the wall, and the chances of rupture would be relatively lesser. If it ruptures, then depending on the status of the patient, we'll obviously admit and we will have to start the patient on nimodipine. If it is a possibility that there are multiple berries in a patient, then obviously after stabilization in the later part, we can go in for endovascular coiling in the patient. These are some of the questions on berry that have been asked at various points of time. So you anyway have to remember this information. Now we will revise what are the important causes of headache that are to be asked to you. One, obviously the most common cause of headache is tension headache. Overall primary headache is much more common than secondary. So leading cause of headache is obviously tension, but this is the diagnosis of exclusion. If he says rare cause of primary headache, then it is cluster headache, where the eye patients will be having retroorbital pain. If he specifies the word secondary headache and he says the leading cause is, then it is systemic infection, and the least important cause of secondary infection would be secondary headache would be brain tumor in the patient. So let's quickly revise it. When it comes to primary headache, it is tension headache and then it is cluster headache that are in common, the leading one and the last one. And for secondary headache, the leading one is secondary infection. What I mean by secondary infection could be something as simple as URTI, it could be sinusitis in a patient, any infection condition per se can contribute to headache to develop in an individual. So secondary headache is obviously gonna be related to URTI in a patient. Now, when I say brain tumors are obviously rare, and therefore secondary headache with respect to brain tumor will be having a frontal predisposition, early morning predisposition with obviously features which are gradually developing in a patient. So features of brain tumor can be easily explained by the long-standing history developing in a patient. Unlike when it comes to left-hand side, like migraine, there would be sudden onset headache that could be having half side of the head involvement, and I'll just make you revise the features of migraine as well. But at the moment, remember at least 4 things. The leading cause for primary one, tension. The least common one is cluster headache. For secondary headache is URTI followed by brain tumor. Then I use the phrase thunderclap headache before you. What is thunderclap headache? The headache that peaks within 60 seconds of onset. I mean, right now headache begins and then it's excruciating that the person is holding his head between his hands. That is what you call as a thunderclap headache in a patient. The important causes for these would be subarachnoid hemorrhage, ICH, intracranial hypotension, and raised intracranial pressure. What is intracranial hypotension? You know, normal pressure in the brain is 10 to 20 millimeter of mercury. If the pressure of the brain turns out to be on the lower side, what is a condition called as CSF leak. Then again, if the pressure is less, the brain will be displaced from its original position. The tractional force on the dura will again cause headache in a patient. Intracranial hypotension can develop in those patients who are having dural ectasias. Due to dural ectasias, there would be pockets formed in which the CSF can accumulate, and because of the pockets of the CSF, the total volume or space available for CSF will increase. Now I'm saying a concept of physics. If the volume is more, the pressure would go down, and the tractional force on the dura, because dura mater is the one that is innervated by the trigeminal nerve endings, that tractional force will result in development of manifestations of headache in the patient. So it is not only a subarachnoid hemorrhage that will contribute to thunderclap headache, even intracranial hypotension and raised ICT can contribute to the same. Then other causes that should be remembered are even cervical artery dissection. A tear in the cervical artery maybe could be an extension of the aortic dissection. Cerebral venous thrombosis. So I'm writing alphabet C here, that is cervical artery, and then cerebral venous thrombosis can contribute to it. Migraine and cluster headache, yeah, I mean they may or may not present as a thunderclap headache. They are conditions where the headache can peak very soon. And then would be pituitary apoplexy. Apoplexy would mean bleeding in the pituitary. This could be due to trauma. This could be due to hypertension. This could be due to sickle cell anemia. It could be due to aneurysm in the patient. So bleeding in the pituitary can also present as a presentation of sudden onset thunderclap headache. I'm not saying pituitary infarction, we're not talking about Sheehan syndrome, though the complication of this can be Sheehan, but I'm talking about immediate bleed. In Sheehan, remember, it's infarction. Here I'm talking about bleeding. So the causes for thunderclap headache are the ones which are mentioned here. It was asked as a all except kind of an MCQ, and remember that in ischemic stroke we will not have a thunderclap headache, because in ischemic stroke we don't have a raised SAT. Raised SAT is usually a feature that is encountered most of the time in hemorrhagic stroke in a patient. So if these are given and acute ischemic stroke is given, then acute ischemic stroke we usually don't have a headache. At least initial presentation headache is not there. It's mostly a focal deficit that would be experienced by an individual. So these are causes of thunderclap headache, which are obviously taken from a neuro textbook, and because they've asked, thunderclap headache can be a presentation of migraine also, it can be cluster headache also. This is easily rememberable. I mean, this would not cause an error, but the remaining ones, that is like obviously subarachnoid hemorrhage, you know, that is intracranial hypotension, raised SAT, cervical artery dissection, cerebral venous thrombosis, and then pituitary bleed can be explaining development of thunderclap headache. When would you suggest in the MCQ that there is something wrong grossly if the headache of the patient is worsened by change of position? That indicates the fact that the patient is having a brain hemorrhage, and obviously post lumbar puncture also the same situation will occur. So positional changes in headache is something that is a cause of worry. Intracranial hemorrhage is one of the possibility. Headache that is provoked by Valsalva maneuver. Valsalva maneuver would be that you will ask the patient to breathe out and you will pinch his nostrils, and there is a headache worsening in the patient. That again indicates a CNS malformation in a patient. That could be like a Arnold-Chiari malformation, where there's a small posterior fossa, the fourth ventricle is compressed with the cerebral tonsils. Sudden severe headache we've already discussed. Then onset of headache after 50 years. Yes, this could be possibility of brain neoplasm with papilledema, obviously raised ICT. If there is focal signs present in a patient, then it is hemorrhagic stroke. I repeat my findings here. Headache with arm weakness. This points towards possibility of not ischemic but presence of mainly a brain hemorrhage, because brain hemorrhage would contribute to raise ICT very fast, and therefore there would be headache developing in a patient. But in ischemic stroke, blood vessel is blocked. You see, in ischemic stroke, later on there can be a malignant cerebral edema. But at the moment, the initial presentation will not be of headache. It will only be a motor deficit in a patient. Sudden onset aphasia, sudden onset facial asymmetry, sudden onset arm weakness in a patient. That's the usual presentation that you get with AIS. Especially if a question is associated with systemic symptoms, if there is weight loss, there's fever, there's myalgia, there's temporal headache, then giant cell arteritis is obviously to be considered in a patient. And if there is a headache, very severe one, after a delivery, then after delivery a very rare diagnosis would be postpartum preeclampsia that could explain the headache of an individual. The basic point is, guys, if there's a positional aspect to the headache of a patient, if it is after 50 years of age, Valsalva maneuver, neurological features that are present like arm weakness with headache, you should think in terms of brain hemorrhage in a patient. So these are a couple of red flags which tells you the fact that there is a possible secondary cause to the headache in a patient, and obviously these are important pointers from the clinical domain as well. I will make you revise the Arnold-Chiari malformation part here only. Like if this is the representation of the lateral ventricle, this is the area where the CSF would be produced. Then the connection between the lateral and the third ventricle will be through an opening that is called as foramen Monro. The connection between the third and the fourth ventricle would be called as aqueduct of Sylvius. Then this would be obviously the Luschka. This is the medial one, that is Magendie. So what I'm saying is that the CSF will follow this path, would emerge out from Luschka Magendie, then will accumulate in the basal cisterns, and then would be reabsorbed in the subarachnoid space of the patient. This is the usual site from where the CSF of the patient will be reabsorbed. Now what I am saying is that if there is a herniation of the cerebellar tonsils, these tonsils are congenitally pressing on the fourth ventricle, then you can see that the pressure by these ventricles, then you can see that the pressure by the cerebellar tonsils on the fourth ventricle of the patient will compress the fourth ventricle, and therefore the proximal system will tend to get dilated, and this will present with obstructive hydrocephalus in a patient, and usually this would be a congenital malformation that would be present. So this diagram here represents Arnold-Chiari malformation type 2 mainly, where there is an obstructive hydrocephalus developing in a patient. Remember, Arnold-Chiari malformation type 1, I'll write down separately. Arnold-Chiari malformation type 1 is related to syringomelia, in which there will be a patchy loss of pain and temperature in the body. Arnold-Chiari malformation is of 4 varieties, that is 1, 2, 3, 4. 3 and 4 are not compatible with life. 2 is gonna cause obstructive hydrocephalus, and 1 is gonna be related to syringomelia, and this is gonna cause a painless burn in the patient, like in the hand of the patient painless burn could be present, or non-healing ulcers in the hand could be present. So these are aspects for headache that you need to remember, along with some red flags that I've highlighted. Especially if the question is gonna describe these clinical domains, then you should be able to pick it up. For giant cell arteritis, I just wanna say the fact that giant cell arteritis, though I'll discuss this later, is a very characteristic feature would be temporal headache. It would obviously be a geriatric age group patient, an old patient who would be having this presentation. And when it comes to malformations in the brain, they can definitely contribute to headache again in the patient. So these are a quick revision of the aspects for headache. Pound criteria also we can revise once again. Pound criteria for migraine. 4 out of 5 should be present for diagnosis of migraine, at least 5 attacks per year. P would stand for that the attacks would be pulsating in nature. O would mean it would be a one-day illness in the patient. One-day illness, I would imply, would be like the attack will start and will disappear by itself within most of the time 24-hour period. The attacks will mostly be unilateral. There would be presence of nausea, not vomiting all the time, but nausea sensation could be there to sight of food, smell of food, and disabling in character. What I mean disabling is that person is not able to go to office, work on a laptop, focus on a computer, household tasks, etc. would not be possible in the patient. So pound criteria are useful for identification of migraine. 4 out of 5 should be present in a patient and at least 5 attacks per year. And you know that you are dealing with a case of migraine. For management of an acute attack of migraine, if it is a mild attack, you will be giving to the patient NSAID, but if it is gonna be a severe attack, then you can give sumatriptan or you can give rizatriptan to the patient. These molecules like sumatriptan, rizatriptan, especially the nasal spray preparation which nowadays available, is highly effective. If they ask you to select one, then rizatriptan is a good idea. Sumatriptan can also be used. It is just that rizatriptan is having a much more faster onset of a relief of pain. That is why it is preferred by a lot of physicians. Once you manage an attack for prophylaxis of migraine, the molecule to be used would be propranolol, though you might have to add gabapentin, pregabalin, because the headache in these patients would be pretty bothersome from the perspective of recurrence that could be contributing to the morbidity part of the disease, where the person will be having many such attacks on a recurrent basis, and therefore quality of life gets compromised. Okay, the next topic that I will make you revise would be called as AIS, that is called as acute ischemic stroke. In this particular non-contrast CT scan that you can see, there is a very clear-cut hypodensity that is visualized. This hypodensity is present in the MCA territory of the patient. This hypodensity will obviously take some time to appear. So if he says that what is the preferred imaging modality for patients of acute ischemic stroke, the answer would be given as diffusion weighted MRI. Because lots of time we do not have access to diffusion weighted MRI, we will have to rely on a CT scan. The problem with the NCCT head would be that the findings will take at least 3 to 4 hours to appear, sometimes even longer. This was a large infarct, so it showed up early. But if it was a relatively smaller infarct, it may not have showed up so early. So we would be in a blind, and therefore even if CT scan is normal, we will have to treat a patient who is having features of acute ischemic stroke. Just for the sake of record, I'm writing findings of a large infarct usually appear after 3 and sometimes can be appearing as late as 6 to 8 hours, and by that time we might cross the window period. That is why I said that even if the CT head of the patient is normal and if the clinical features are present in a patient, we still have to thrombolize the person. The clinical presentation that could be given to you, where he might describe a hypertensive patient. He might say that this person is also a big time cigarette smoker, and then he has had a sudden onset manifestation of aphasia. He might describe that this person was enjoying dinner with his family and he was talking and suddenly he lost his voice. The family was very surprised because his face was looking very funny. So maybe his grandchildren thought he's like, let me say 65 years of age. His grandchildren at the dining table thought that it is funny that the grandfather is making funny faces because there was a sagging of muscles of one side, facial asymmetry. And then his son said, okay, dad, take a glass of water. Now somebody offers you a glass of water, you will try to at least raise your arm to take a glass of water. And there was also a right arm weakness in this old man, which has contributed to obviously alarm in the family, and they've rushed him to the hospital. Now, because these neurological features are developing in the patient, and you will notice that in stroke, the symptoms will usually become more severe as the time will progress. In transient ischemic attack, you will usually notice, and this is a point given in Harrison, that though the cutoff for TIA is 24 hours, he has mentioned the fact that most TIAs usually start improving within the first hour itself. So if a person says, I had this weakness, and then the weakness is at least lesser, it is still present, but it is lesser, that could be a TIA. But if it is worsened to the level that, let me say initially the power was 3/5, now it is 1/5, then usually after 1 hour, or usually in the first hour only, there will be a deterioration of the symptoms of the patient. All these symptoms will even worsen, that facial asymmetry becomes more pronounced, right arm or facial asymmetry was not there and now might become pronounced. So deterioration of symptoms with worsening would definitely be a feature, whereas in TIA symptoms will improve. Why this is important is that in a TIA, if he says, what will you do first? You obviously have to give aspirin to the patient. But if he says, what will you do in a patient of acute ischemic stroke, then the first thing to be done in acute ischemic stroke is thrombolysis in the patient, and aspirin is given after 24 hours of thrombolysis. So in this particular case, I have admitted this person. I have noticed that he is having a focal neurological deficit, like Babinski sign can be elicited, arm weakness can be elicited, deep tendon reflexes in the patient are turning out to be brisk. And by listening to the history, I obviously know this is going to be mostly a left MCA territory infarct in the patient. So I will now do a CT scan, which may or not show the findings. Like suppose even if the CT scan is normal, because patient came within first hour only. Then in those circumstances, I will make decision to thrombolize the patient. The upper limit of thrombolysis is 4.5 hours. That is the window period that you know. Earlier the window period was 3 hours, but now the window period has been revised to approximately 4.5 hours. After 4.5 hours, most of the time we will be going in for a mechanical extraction of the embolus, that is called as MERCY. But I wanted to remember, especially for the first 4.5 hours, it is thrombolysis to be done. And aspirin is the first thing in management of TIA, whereas thrombolysis is the first thing in management of a AIS in a patient. Now going forwards, I'll add one more slide to this one. When it comes to a transient ischemic attack, whether somebody will or will not develop a stroke, then the cutoff for development of TIA is 24 hours. That is, within 24 hours the symptoms will resolve and imaging will be perfectly normal. But deterioration of TIA or conversion of TIA into stroke usually occurs over the next 48 hours. So there are two values I want you to remember. 4.5 hours is the window period for treatment of acute ischemic stroke. TIA cutoff is 24 hours, but deterioration usually occurs over the next 48 hours. Highest chances of stroke are in the first 48 hours. It is here that you will be using the ABCD score. That is age, blood pressure, clinical features, then duration of symptoms, and presence or absence of diabetes mellitus, which are used to calculate whether person will or will not develop stroke. Age, blood pressure, clinical feature, D2, because there is going to be duration of symptoms considered and diabetes mellitus also taken into consideration. So chances of stroke can be calculated, and then therefore you will start the patient on aspirin. Initially you will give a loading dose of 300 milligram, and subsequently you will downgrade to 75 milligrams of aspirin to the patient. Clopidogrel also will be given a loading dose of 300 milligram initially, but then you will downgrade to 75 milligram of baby tablet on a daily basis. So patients who are having TIA, the first thing to be done is obviously start the patient on aspirin. If required, simultaneously statins if there is concomitant cardiovascular or heart disease risk factors like obesity present in a patient and diabetes present in a patient. Statins anyway have to be given. Vitamin B6 and B9 and B12 for homocystinemia. And you might have to start the patient on oral anti-clotting drugs like rivaroxaban if there is a determination of embolic nature of the cause of TIA, like he was detected with atrial fibrillation, there are multiple clots in the left atrial appendage, then oral anti-clotting drugs would be required. On the other hand, if in a question he begins by describing to you or gives you a CT image where straight away hemorrhagic stroke manifestations are given. In hemorrhagic stroke, you would be having thrombolysis being contraindicated. So what would you do in this case is mainly to handle the raised ICT. Assuming that mannitol has been given and this person is having a posturing, then ventriculostomy, and if required, even a hemicraniectomy would be required in this particular patient. So patients of hemorrhagic stroke who would be having a very fast deterioration in their GCS due to the raised ICT would require specific treatment for raised ICT, and they could be also in hypertensive crisis. So to control the blood pressure of this patient is also important. Now, before I describe the hypertensive crisis management, I want to remind you of a formula by the name of cerebral perfusion pressure is a difference of mean arterial pressure minus ICP. If intracranial pressure will rise, then if mean arterial pressure will also rise, then both will counterbalance each other and CPP will be maintained. So if you decrease the blood pressure of any patient of brain hemorrhage, remember that decreasing brain hemorrhage patient blood pressure can be counterproductive also, because then the perfusion of the brain will reduce. So one, he has asked that what will be the value beyond which treatment should be started. So the value of blood pressure beyond which treatment should be started is 220 by 130 millimeter of mercury on admission, because if the blood pressure, let me say, is 160 by 100, and you have decided to control the BP of the patient by giving a parenteral IV drug, the moment you lower the MAP, the CPP will also reduce. So it is cut off for 220 by 130. Then the drug that you will use in stroke will be nicardipine and not sodium nitroprusside, simply because the control is better over every millimeter fall with nicardipine and clavadipine over that of sodium nitroprusside, which can cause a relatively unpredictable sudden fall, and therefore perfusion of the brain would be compromised. So intervention is to be done not at 160, 170, 180. It is to be done at 220 by 130, and nicardipine would be given in this particular scenario. Also remember the fact that when it comes to how much blood pressure will you lower, so you will lower the MAP of the patient by at least 25% over a period of 24 to 48 hours. So sudden lowering of blood pressure will be counterproductive, and it is a gradual lowering of the blood pressure that would be required for patients of hemorrhagic stroke. The third aspect is what I was saying in the previous slide, that is that of AIS, acute ischemic stroke, with a normal CT scan. The patient is in the window period, is a perfect candidate for thrombolysis. In those circumstances, even if the CT scan is normal, we will obviously start thrombolysis in the patient. After 24 hours of thrombolysis, aspirin loading dose would be given, and then we will downgrade to 75 milligram, and that would be continuing for the whole life of the patient. So three aspects are to be remembered. First line intervention for TIA is aspirin. First line intervention for hemorrhagic stroke with brain hemorrhage, which is due to high blood pressure, is nicardipine, with obviously a rider blood pressure should be given more than this much. And first line management for AIS with normal CT scan is re-Douglas in the patient. These are three concepts that I want you to be clear of. Then are indications and contraindications for thrombolysis. So obviously the indications are that there is a clinical diagnosis of stroke in the patient, that is there should be a focal deficit within 4.5 hours and should be definitely visible. CT scan showing no hemorrhage, that's very important. What is the reason why you do a CT scan? Not for diagnosis of ischemic stroke, but to rule out brain hemorrhage, because that's a contraindication to thrombolysis. So CT scan showing no hemorrhage or edema greater than 1/3 of the MCA territory, obviously understandable that cerebral edema could definitely develop in the patient. In ischemic stroke, usually the cerebral edema that will occur will be a malignant cerebral edema that may take some time to appear, and that could be cytotoxic. Age obviously more than 18 years. And when would you not do a thrombolysis in a patient? If sustained blood pressure is more than 185 by 110, despite the treatment of the patient, don't do thrombolysis. He says, hold your guns, give nicardipine, give levetolol, gradually lower the BP of the patient, not suddenly, because if it is sudden lowering, again problems will occur. So if the blood pressure of the patient is more than 185 by 110, then don't do thrombolysis in the patient. I repeat this again. Earlier, I was teaching you the cutoff for 220 by 130 for brain hemorrhage patient, right? That was a hypertensive patient with a brain hemorrhage. Now I'm saying hypertension patient in a ischemic stroke. If hypertension, I mean, your thought process has to be hypertension in a multiple choice question does not mean that it will always be brain hemorrhage. It could be ischemic stroke also. If it is brain hemorrhage in a patient, the intervention is obviously control the blood pressure of the patient. If he says high blood pressure in a patient of ischemic stroke, you have to lower the BP to at least 185 by 110, any higher, and the risk of brain hemorrhage is there. You see, basic role of medical science is first to know harm of the patient. So risk of brain hemorrhage is definitely present in the patient. Since there is a definitive risk of brain hemorrhage, he says try to lower the blood pressure of the patient. Bleeding deaths is understandable. I mean, here I would like to give, however, update for 2019, which is the fact that suppose person is taking warfarin, would you do thrombolysis? You guys tell me, would you do thrombolysis if person is taking warfarin? It would be risky now, because warfarin will also cause increased chances of bleeding. The guidelines are, if a person is on warfarin and the international normalized ratio of the patient is less than 1.7, you can do a thrombolysis. They have determined this cutoff, and this is a update that is given that bleeding diathesis is a contraindication only if the INR, in fact here I should modify, if the INR is more than 1.7, then you cannot do thrombolysis, and if the INR is less than 1.7, then thrombolysis can be done. Because this list is saying contraindication, I'm saying warfarin more than 1.7 don't, and if INR is less than 1.7, do thrombolysis. Recent intracerebral hemorrhage, understandable, it could rebleed again. Major surgery, gastrointestinal bleeding in the previous 21 days. He had hematemesis, he had peptic ulcer, then obviously the bleed from peptic ulcer would be there, or recent MI. So these are some contraindications which are present. Let's revise them. Blood pressure more than 185/110 is a contraindication to thrombolysis. Why? Because the risk of cerebral bleed is there. He says lower the BP either by giving nicardipine or labetalol if available, whatever, and then manage the patient by starting the patient on thrombolysis. In brain hemorrhage, the cutoff to be remembered is 220/130. For ischemic stroke, it is 185/110. That's 1 point. Bleeding tendency is a contraindication, agreed, but only when the INR is more than 1.7. Anything lesser, you can thrombolyze. Previous CNS bleed, logical. I don't think so you would make a mistake. GI bleed, I don't think so you will make a mistake. Major surgery previous 14 days, okay, you can remember, and then recent MI. So two at least you can remember. Major surgery in previous 14 days, recent MI is recent here usually means in the previous 3 months. Then in a patient, because thrombolysis has already been done in the patient, he says that most of the time doing a thrombolysis again in a patient might increase the risk of cerebral hemorrhage in a patient. So these are in fact some contraindications, and I would say that they are not absolute contraindications. They are relative in a sense that suppose somebody had a MI 1 year ago, you would obviously thrombolyze the patient. So left hand side is obviously important, has been asked a couple of times, and this is what I've told you. The symptoms have begun to improve by themselves. CT scan is normal in the patient. Then obviously DAPT, that is aspirin and a clopidogrel should be started in the patient, but do not answer aspirin for the previous two situations where you have to do thrombolysis in one of the cases, and if thrombolysis is done, then giving antiplatelet drug right away is not a good idea. It says withhold for 24 hours, then give. The next thing is a practice of a question which is of recent aims. This is a true or false statement regarding a person who's having right-sided hemiparesis and aphasia since 1 hour. Choice number A says tenecteplase is not started if the CT scan is normal in the patient. This is a false statement because if CT scan is normal, we still have to start thrombolysis in a patient. He's saying not started if CT scan is normal. Why? Because I told you CT scan is done to rule out brain hemorrhage and identify it could be ischemic stroke. So even if CT is normal, you will start thrombolysis. Tenecteplase not started before MRI if CT scan is normal is again a false statement because we do not go in for a MRI after doing a CT scan. Reteplase given when BP is more than 150/80, yes. The cutoff is 185/110. Reteplase given in a patient with patient taking a warfarin with INR of 1.4, this is a correct statement. If the INR was more than 1.7, it would have been a false statement. Antiplatelet therapy is given in acute ischemic stroke. This is a correct statement. We have to give antiplatelet drugs, but obviously after 24 hours of thrombolysis in the patient. First priority in acute ischemic stroke is thrombolysis, and then obviously give antiplatelet drugs. So this was a recent AIMS one that they have asked, and I think after listening to me, this part would have been relatively clear. Okay guys, the next topic that I'll make you practice would be intracranial hemorrhage. You can see very clear hyperdensity in this particular part that would be in the area adjacent to the third ventricle of the patient. So the diagnosis of the patient is intraparenchymal hemorrhage. One of the usual causes for this would be uncontrolled blood pressure. That would be hypertensive crisis is the usual cause for intraparenchymal hemorrhage. If it is not hypertensive crisis, it would obviously be trauma that could be contributing to such a situation, or it could be bleeding diathesis due to warfarin toxicity. He can give you a situation that the patient was prescribed warfarin for, let me say, atrial fibrillation, and the overdosage of warfarin toxicity is causing a IPH. The treatment of choice for warfarin toxicity is PCC, that is prothrombin complex concentrate. Do not answer fresh frozen plasma because FFP per se is frozen, so it will take some time for it to be actually available, and PCC is rather a ready-made clotting factor activation system that will result in control of the bleed that is occurring in this particular case. Now, to evaluate a person of intraparenchymal hemorrhage, we can look at a few anatomical landmarks here, where this area which is adjacent to the lateral ventricle, this would be the caudate nucleus. Then the area that would be adjacent to the caudate nucleus is going to be the thalamus. So this is the thalamus represented here. Then if I go a little laterally, more laterally, this area is where the putamen will be situated. And medial to putamen will be the presence of globus pallidus, interna and externa respectively, and the area that would be bifurcating the two, this is where the internal capsule is located, and traveling through the internal capsule is the corticospinal pathway, and because of the bleed in this area, if the internal capsule is compressed, therefore there would be a development of a contralateral hemiplegia in the patient. So this patient is having a left-sided, this is left, this is right side, this patient is having a left-sided IPH, intraparenchymal hemorrhage, which is either due to any of the causes that I highlighted before you, and if the bleed increases in size, as you can see, it can even contribute to obstructive hydrocephalus in the patient with pressure on the internal capsule as well. Now, in this particular patient, to evaluate the severity of any intracranial bleed, one of the score that is available is called as ICH score. In the ICH score, you obviously have to take into consideration age that matters. Older the patient, more is the problem. In some books it is 75, some books it is 80. That is a slight disparity. Then hematoma volume, obviously, bigger is the bleed, more is the risk. If there is a concomitant IVH, that's obviously an extension of the IPH. Then the location is infratentorial. Infra means down, so the threat to life will be more because chances of brain herniation will be higher, and then lower is the GCS value, more will be the deterioration of the patient. So ICH score is used to evaluate the prognosis of a patient with a brain hemorrhage, where the parameters, the most important one would be the volume of the bleed present and the location of the bleed, because these two parameters will be one of the important parameters that will decide the prognosis of the patient, in a sense that lower is the bleed, more is the chances of brain herniation in a patient. And a CC, a volume of bleed of, let me say, 100 ml as compared to 10 ml or 20 ml would obviously determine the prognosis. Once we have studied the causes of intraparenchymal hemorrhage in a patient, then we need to remember what will be the usual presentation in this case. So most MCQs will present with the contralateral hemiplegia, because internal capsule is the one that could be involved in the patient. Even in these patients, hemi anesthesia can be present, and then the sensorium of the patient will begin to dull out. That is because the higher pressure in the brain or the raised intracranial pressure will cause the GCS values to become significantly lowered in the patient. There would be Babinski sign appearing in the patient. There would be breast DTR. So description of focal neurological deficits will always be given in this particular question. Depending on the cause, the treatment of this particular patient can be started. The investigation choices, obviously, for any cerebral bleed is a NCCT head in the patient. And I can lastly mention that the most common site for brain hemorrhage or intracranial hemorrhage is putamen. The blood vessel that is involved in this case, which is the source of bleeding, will be the lenticulostriate artery. That's one of the big branches of the middle cerebral artery that would be involved in this particular condition. So MCA territory stroke is usually lenticulostriate artery that would be affected in this particular case. Okay, the next slide that we need to basically practice and remember would be CT scans with respect to subdural hemorrhage in a patient. There is a possibility that they can give you a subdural hemorrhage in which the area of the bleed would definitely be white. This is a concavo-convex bleed, that is one, and the concavo-convex bleed that is present here is white in color, though I'm symbolically showing it black, but then it is white in color, so we will say that this is an acute subdural hemorrhage. And then in the one on the right hand side, you can see that the blood has been reabsorbed and now there is a hypodensity present. That would be called as a chronic subdural hemorrhage. People who are either into action sports or like film actors who do their own stunts, or is into sports like boxing, or for that matter of fact, I can say a person who's having fascinating gait, Parkinsonism patient, he or she slipped in the bathroom The main keyword in the question for this one would be gradual onset deficit developing in a patient. This gradual onset deficit is developing because the bleeding is occurring from the bridging veins, that is the cortical bridging veins are the ones which are involved in this case and are bleeding. The manifestations would be relatively slow to develop, and therefore there would be a focal neurological deficit like a arm weakness or a facial asymmetry developing in a patient. For management of this condition, if it is a minor bleed, then conservative management would be sufficient. But if it is going to be a bleed that will contribute to low GCS, then intervention in the form of a decompressive hemicraniectomy might even be required in this condition, where incision over the dura mater will have to be given and the clot is below the dura mater, so that clot will have to be removed so that the pressure on the brain parenchyma can definitely be eased off. Subdural hemorrhage most of the time is an easy pick for most questions, so I don't think so there would be any errors of judgment on your part for this particular one. Then another image that I have actually shown to you, but this time I've shown you a bigger rather version of the same, is again IPH in a patient, that is intraparenchymal hemorrhage. So the bleed can definitely increase and it can cause a mass effect. It can cause a midline shift in the patient, but the ventricular systems can definitely be compressed. And the aspects of ABCD2 score I've already highlighted before you. This is a score that is used to predict the risk of a TIA patient into development of stroke, with the highest chances of stroke being in the next 48 hours, but the TIA individual cutoff for symptoms would be 24 hours. If you look at the next image, you will notice that the patient is having IVH, that is an intraventricular hemorrhage. And why would you be having an intraventricular hemorrhage in an adult? Then your answer would be, it is most of the time an extension of the intraparenchymal hemorrhage in a patient. For case of neonate, one of the causes would be faulty forceps delivery. The forceps have been applied by a OBGY resident who is not very skilled, and therefore in a term baby there could be a development of a intraparenchymal hemorrhage, or extension of IPH can contribute to IVH. In a term baby, obviously, as I said, instrumentation, and preterm children, you don't need even forceps or instrumentation. The brain matrix is so fragile that there could be germinal matrix blood vessels rupturing spontaneously, and there would be a bleed in the patient. IVH, especially for children, they will ask you the investigation of choice, that would be a ultrasound head. Adults is obviously a CT scan, but for children, newborn babies, we do not do a CT head, we rather go in for an ultrasound that would help you identify the fact that the patient is having a intraventricular hemorrhage. Once the blood will clot, in this case, it will result in obstructive hydrocephalus, so ventriculoperitoneal shunting is the only way forward in patients of intraventricular hemorrhage, both for adults as well as children, because there would be obstructive hydrocephalus as a manifestation. So the types of bleed that I have made you practice are intraparenchymal hemorrhage, extradural hemorrhage, subdural hemorrhage, and then would be subarachnoid hemorrhage in a patient. Intraparenchymal hemorrhage will usually be given in a scenario of a very high blood pressure. Extradural hemorrhage will usually be given in a scenario of a biking accident. The guy was driving a bike fast, helmet was off. Subdural hemorrhage would be usually given in a scenario of a fall in the bathroom, a gradual onset symptoms developing in a patient, that would be post, let me say, fall in the washroom. And subarachnoid hemorrhage will obviously be sudden onset, and he will be describing sudden onset headache, worst headache of my life, with presence of nuchal rigidity, with or without third nerve palsy, that may be described in the question. With respect to intraparenchymal hemorrhage, the bleeding will be diffuse in the area of the putamen. In extradural hemorrhage, the bleeding will be biconvex, hyperdensity. Subdural hemorrhage will be concavo-convex. It can be white or it can be black, acute versus chronic. Subdural hemorrhage will be a straight line, maybe with a bifurcation like this. This is bleeding the sylvian fissure. When it comes to the source of bleeding, in IPH, the source of bleeding is MCA, lenticular striate artery. In extradural hemorrhage is middle meningeal artery. In subdural hemorrhage, it is the bridging veins. And in subarachnoid hemorrhage, it is again the middle cerebral artery that is involved in the patient. These are the types of bleed that can usually be encountered, and obviously the pediatric one would be IVH, which in adults is an extension of the intraparenchymal hemorrhage in the patient only. Whenever there is a posturing in the patient, for management of posturing, you might have to go on for emergency maneuvers. For posturing in the patient, one of the emergency maneuvers that might be done would be like burr hole surgery. And site of burr hole surgery is then decided by the site of the Hutchinson pupil. Whenever posturing is given in the question, decision for burr hole surgery might be required. Burr hole surgery site decision is based on the following guidelines. Burr hole surgery is mostly done in patients who are having like a SDH. There is a posturing present in the patient. Then we will have to go in for a burr hole, and the site would be decided by CT scan, obviously. But if CT scan is not given in the options, then it would be the presence of Hutchinson pupil. Hutchinson pupil would be a mid-dilated pupil sluggishly reacting to light due to pressure on the third nerve by the bleed present. And if the information of Hutchinson pupil is not present, then burr on the left side. Why? Because most of the people in the world are right-handed and dominant part of the brain is left. So burr on the left-hand side. So posturing is usually managed by burr hole, though this is a measure that is only to be deployed rarely, but because it's a rare procedure, that is why this is to be remembered. Now, once we've remembered regarding the aspects related to posturing, we will now look at some CNS infections. The first one, which is very characteristic and should be remembered by you, is neurocysticercosis. So two of them that I want you to remember for this particular slide are as follows. In the first one, we'll talk about aspects related to NCC. In fact, if you look at the superior representation, this is the dead larva. This is the representation of the dead larva. This is what is rice grain calcification due to the larva calcifying in the muscles in a patient who's having cysticercosis. These patients would be having lumps or bumps in the skin due to the dead larva. And obviously, if the larva goes in the brain, hatches in the brain, then you could be having this small, I would say, hypodense areas. Though in some of them, you can even see a white dot. This white dot that I have highlighted, I'll erase it now so that you can appreciate that better. The white dot is the scolex of the larva that is developing in the brain parenchyma of the patient. And then obviously, the other images which are given are for comparison and are of a different patient. That is to reveal the fact that even a brain abscess will be much bigger, and even tuberculomas could be a presentation. So I have incorporated multiple scans here with one when we talk about neurocysticercosis is the one which is highlighted here, where multiple ring enhancing lesions are present in the entire brain parenchyma of the patient. Now, for neurocysticercosis, the aspects to be remembered are like this. This disease would usually develop in those people who have consumed vegetables which are grown on fecally contaminated soil. If a person will consume pork which is containing larva, then the end result would be that the person will develop intestinal tapeworms. But if the person will, let me say, consume vegetables which have been grown on fecally contaminated soil and they are containing eggs of cysticercosis, that is Taenia solium, then the ingestion of eggs will result in this person getting eggs moving on from the GI tract, crossing the blood-brain barrier and reaching up to the brain of the patient, causing neurocysticercosis. And some will obviously move on to the muscles of the patient, where they will die. And there would be calcifications that would be developing in the muscles of the patient. Intramuscular calcifications would develop. So neurocysticercosis to develop will usually require vegetables which are grown on fecally contaminated soil and have been not washed properly. Vegetables that I'm talking about here are like, for example, cabbage. Or instead of cabbage, I'm talking about, like, for example, lettuce. So these are two vegetables, leafy vegetables, I would say, used in salads, which would contribute. In neurocysticercosis, the clinical presentation will be that of a low socioeconomic strata person with development of focal seizures. Like this person says that for last 1 week, multiple times twitching of one side of the face or involuntary movement of one hand would be noticed in the patient. So the usual presentation is focal seizures. The second reason why they come to you is because of lumps or bumps in the skin, which is due to the cysticercosis component that I was talking about. In all of these patients, in the workup for neurocysticercosis, if he says what is the preferred imaging modality, then the answer of yours would be given as gadolinium enhanced MRI. A contrast enhanced MRI is the best way to identify this particular case. Why? Because when you do a contrast enhanced MRI, you can demonstrate the damage to the triple B. You can demonstrate the damage to the blood-brain barrier of the patient. You can demonstrate that there would be hypodensities which are going to be black in color. And some of these hypodensities will be having a presence of a white dot, that is the scolex. And around this area, you can also demonstrate the presence of cerebral edema. The cerebral edema can then increase. The cerebral edema component can definitely increase. The larva is now dying. But the cerebral edema component, because the immunity is attacking the larva, will increase, and that is when most patients become symptomatic. And later on, you will notice the fact that this entire area will also get calcified. I don't want to wait for the calcification to appear and diagnose this patient, because that would be very late. I want to pick up the patient when he is either having multiple hypointense lesions with a scolex, that is a central white dot. The cerebral edema in this case will be in gray color. However, if in a question he says what is the first test to be done for this patient, then the first test to be done for neurocysticercosis patients would be lumbar puncture. You will be obtaining CSF, and then the test to be done is not CSF ELISA. It is CSF immunoblot for neurocysticercosis antigen. It is CSF immunoblot for NCC, neurocysticercosis antigen, which is the best test for diagnosis of this patient from the perspective of etiology. And obviously both have to be combined for diagnosis, because diagnostic criteria incorporate both of them. The CSF of this patient on microscope examination might even show presence of eosinophils. Normally we study about eosinophils in the blood, but eosinophils in the CSF are encountered with neurocysticercosis. A X-ray of the bilateral extremities of the patient, especially of the lower limbs of the patient, are good, because you can pick up the rice grain calcification as I showed you, and then you will have to initiate treatment for these particular patients. The main treatment for this patient would be albendazole to kill the worms. But if you straight away give albendazole, the worms will die, and the contents of the worm can cause anaphylactic shock. So first we give dexamethasone. We give dexamethasone round the clock to these patients, like 6 hourly. Then you will reduce the cerebral edema component of the patient and start the patient on albendazole. Albendazole in this condition is to be given 400 mg twice a day for 8 days. And apart from this, because the patient is having seizures, so for focal seizures, we can be giving like carbamazepine to the patient, or for that matter of fact, we can be using lamotrigine in the patient, especially if it is a female patient. Lamotrigine is useful for both focal seizures and GTCS. So management for these patients would be for the following duration. You all know that for patients who are having seizures, the treatment should be given for at least 2 years, and after 2 years, we can initiate withdrawal. If the patient is asymptomatic, then we can do initiate withdrawal by tapering. Sudden withdrawal of anti-epileptic drugs can obviously contribute to rebound epilepsy. So it's always tapering, but they have asked this that over 2 years, the taper of this particular part has to be done. The second sinus infection that I want you to remember after this would be Cryptococcus neoformans. You can once see the Indian preparation. So he will obviously describe you a case of a HIV positive patient, a AIDS positive patient. And second, you can see in the MRI head of this person of Cryptococcus neoformans a soap bubble appearance. This would be a AIDS defining illness, which is by the name of Cryptococcus neoformans. This is a AIDS defining illness which would contribute to development of symptoms of meningitis in the patient. Let us quickly revise the meningitis findings here as well. The question will describe a AIDS positive truck driver, and then we'll say that there is a deterioration of this AIDS positive truck driver in a sense that he is ending up with headache, there is fever, there is nuchal rigidity. Raise ICT causes altered sensorium. Please appreciate that raise ICT contributing to altered sensorium. I mean, meningitis per se is not responsible for development of altered sensorium in the patient. It is raise ICT which is responsible for altered sensorium developing in a patient. This truck driver was also having photophobia, avoidance to light. For approximately, let me say, 2 days, he was having these symptoms and he avoided driving the truck also. And now he has come to you, so you have decided to do a lumbar puncture. In any patient of query meningitis, the first test to be done is obviously a blood culture. So in this case, before I give empirical antibiotic to the patient, which would be ceftriaxone, blood culture has already been drawn in the patient. A CT scan has been done already to rule out the possibility of raised ICT, and if it is present, even mannitol has been given. What I want you to understand is that by reading AIDS positive, do not be under a possibility or under impression that it could only be cryptococcus. Because now when I will be doing lumbar puncture of the patient, I will be sending the CSF of this person for both gram stain as well as for India ink. Even with respect to India ink, remember there could be two possibilities. One could be that the slide will obviously be jet black slide. One is obviously you can see the capsulated organism, that is cryptococcus, that I showed you. But at the same time, if in the paper he gives you a scenario where you can see a capsulated organism, but the capsulated organism is a diplococcus, then we are talking about pneumococcus here. So it is not a guarantee that all MCQs of AIDS positive patients will only be talking about only cryptococcus, because even pneumococcus, which is a diplococcus, can be stained with India ink. Obviously gram stain will obviously stain it, but India ink stain can also be used to identify pneumococcus. Why? Because it is capsulated, and cryptococcus anyway would be capsulated. So the bottom line is that we should not focus only on India ink word and think it is cryptococcus. That's the basic message, because the answers will change dramatically. For pneumococcus, the primary treatment that we give is ceftriaxone. And for cryptococcus, the answer will change over to that of amphotericin B. So before we comment on the diagnosis of the patient, obviously the India ink preparation has to be looked at very carefully if given in the exam. Then another domain that I want to bring to your notice is the fact that in these patients, if it is a fungal meningitis, it will mainly be lymphocytes in the CSF. Whereas when it comes to bacterial meningitis, there would be mainly neutrophils in the CSF, which will mostly be usually at least more than 1000 neutrophils per cubic millimeter. But here it would be like 25 to 50 lymphocytes per cubic millimeter of the CSF of the patient. So if CSF picture is given, then also you should be able to identify and differentiate. CSF culture report will take some time to appear in the patient. Assuming the fact that the question wants an answer as amphotericin B, other informations that could be given in the question apart from lymphocytes would be that the patient's CSF is having normal sugar values. The protein values might be normal to slightly increased. You see, because fungal meningitis would not result in very dramatic features to appear, that is why I've highlighted only lymphocytes with normal sugar values and protein. Then they have asked about a special stain to stain this capsulated organism, that is mucicarmine stain, over and above the India ink that I have shown you. Imaging will also be done in this case. The imaging in this case will be revealing what I showed in the previous slide, a soap bubble appearance. If he says what is the investigational choice for cryptococcal meningitis, the answer would be given as CSF ELISA. Earlier I was teaching you CSF immunoblood for neurocysticercosis antigen. Now I'm teaching you CSF ELISA for cryptococcal antigen, and then obviously amphotericin B would be given for this patient. So these are two aspects for CNS infections that you should be familiar with. Then he can ask you regarding encephalitis, where I have shown two aspects to you. One is obviously the Nipah virus aspect. Nipah virus has been documented to cause development of encephalitis. Though the Indian strain was having also involvement of the lung and was causing ARDS, but the strains that were mainly isolated in Malaysia were mainly having CNS manifestations and were causing encephalitis. In the Indian strain, in fact, both encephalitis and ARDS manifestations were also being seen. Nipah virus is transmitted due to consumption of sap, which is harvested from the coconut tree. So sap which is contaminated, the sap from the coconut tree, you can see the pot on the from where the sap is harvested, which is the pot is rather used to harvest the sap from the coconut tree, and the sap is contaminated with either the saliva or it is contaminated with the feces of the bat, that is Pteropus bat, that is the fruit bat or flying fox as they call it. Either it is consumption of sap, or it could be dates, or it could be fruits, which are again contaminated with the saliva and feces of Pteropus, which could be resulting in this. And then human to human transmission of Nipah virus has also been demonstrated. That is why the nurse who got this infection from a patient last year, she unfortunately died, and that was obviously due to human to human transmission. Nipah virus will result in viral encephalitis in a patient. Initially, they thought that this viral encephalitis is Japanese encephalitis, but then they found that this was mainly seen in those areas where pigs were roaming around more, whereas those communities where pigs are rather, I would say, considered to be impure, and contact with pigs is also impure. I would say the impact of the disease was very less. Actually, this was a very interesting story. You know, what happened was, I'll cut it short. One side is China, other side is Malaysia, and Chinese settlers on the Malaysian side. So they found that these Chinese people, they eat pig and everything. Chinese eat almost everything. So they were having this encephalitis and ARDS, but on the contrary side were Malaysian Muslims who consider pig to be obviously unhygienic, etc. So those people were not having this disease, and rather it is the Chinese who were having, Chinese settlers in Malaysia who were having the disease. So that's what observation of one doctor taught him, that this is not Japanese encephalitis, which they initially thought it was. And then that's where the research started, and they found that this virus was a separate virus which was isolated and then was found to have outbreaks all over in Southeast Asia. There's no treatment for Nipah virus, but because it has been asked, so therefore I have mentioned it. If they ask you what is the investigational choice for Nipah virus infection, it would be RT-PCR. This RT-PCR can be done on the nasal swab and the saliva of the patient. It can also be done on the CSF of the patient. So on the body secretions, if RT-PCR is run, then the Nipah virus can definitely be isolated. Another aspect I want to bring to your notice is, you can see these neutrophils which are having multiple lobes. You can see these neutrophils in the CSF, and then you can see a trophozoite. This trophozoite is of amoeba, a free-floating amoeba by the name of Naegleria. So I'm talking about Naegleria amoeboencephalitis. The organism we are talking about is Naegleria fowleri, which is mainly transmitted by swimming in stagnant rainwater. Like this child is swimming in stagnant rainwater in the pond in the village. So through the nasopharyngeal route, this organism will come into the body of this person and then will definitely cause a fulminant meningoencephalitis in a patient. So this would be a slide showing trophocytes in the CSF of amoebic meningoencephalitis. It was mentioned this is CSF sample of the patient showing multiple neutrophils. You can see some lymphocytes also, and then there is a trophocyte in between on which the arrow is given. So this would be amoebic encephalitis. For management of this condition, the treatment of choice would be intravenous amphotericin B. They have used miltefosine also with varying results, but the main treatment is ampho B. So amphotericin B today has been told to you as the treatment of choice for both Cryptococcus neoformans and amoebic meningoencephalitis caused by Naegleria fowleri. In Cryptococcus, we will be giving amphotericin B for 2 weeks and fluconazole for 8 weeks. Here it is amphotericin B. Along with this, rifampicin is given and fluconazole is given. The total duration of treatment for this particular case would be 4 weeks. The main drugs are ampho B, rifampicin and fluconazole given subsequently for 4 weeks. A new drug which has been advised for this condition is corifungin. This has been put in the orphan drug list now, corifungin. That's a new drug because the results with the amphotericin B are not very good with this, and there are very limited survivors of the disease. So two aspects I want you to remember for sinus infections. The rare ones are amoebic meningoencephalitis, and second is aspect related to the Nipah virus. Both can cause encephalitis, and the Indian variety was also causing development of ARDS in the patient. Okay guys, in the next slide we shall be revising organisms responsible for development of meningitis. We can have a quick look at the organisms responsible for bacterial meningitis, fungal, and then viral meningitis followed by aseptic. So for bacterial meningitis, we'll look at the data age-wise. For neonates, one of the leading organism is Streptococcus agalactiae, which would also be called as group B Streptococcus. This would be a common organism in the female genital tract, which would be responsible for causing neonatal meningitis. But when it comes to India, one of the leading organisms happens to be Klebsiella. E. coli is an older answer, so I would suggest you to answer Klebsiella if asked. And then a rare organism which can contribute to bacterial meningitis in newborn babies and is a hot favorite of our examiners is Listeria. The speciality of this organism would be that this will require special media, that is chromogenic media. So one, you would have read the media used for this is Pelcam. Another aspect to be remembered for this would be the motility. That would be a tumbling motility. Do read about this bacteria very thoroughly from microbiology component as well. Do remember the fact that as a clinician, my interest would however be in the sensitivity of this organism to the antibiotics. And the surprising thing is that this organism is resistant to ceftriaxone and is rather sensitive to ampicillin. Now this is very surprising because normally the organisms responsible for meningitis are sensitive to ceftriaxone and third generation cephalosporins. But in this case, the organisms are rather, this one is resistant to third generation cephalosporin and is sensitive to ampicillin. Then you can be asked regarding the common cause of bacterial meningitis with respect to children. That should be remembered as pneumococcus. Haemophilus influenzae is also an answer, but that would be answer to a multiple choice question where he says that which organism is responsible for development of post-meningitis deafness. So Haemophilus influenzae type B is the one which is responsible for post-meningitis deafness in the patient. Usually we will be doing a BERA test for follow-up for these particular patients. If he says for India or if he says globally, the answer is pneumococcus only for children. And if he says for adults, then the leading cause of bacterial meningitis in adult population should also be answered as pneumococcus. Do remember the fact that when it comes to adults, there can also be episodes of, or there would be Neisseria meningitidis in the choices, but Neisseria meningitidis is mainly responsible for epidemics of meningitis, especially in the winter months in our country. So if he specifies leading cause, it is pneumococcus. This would be also written in MCQ as sporadic cases of meningitis. Sporadic would imply that one case got admitted today, then 2 cases got admitted maybe day after, then 0 cases. So all through the year, all around the year admission will be there. Neisseria meningitis will also require chemoprophylaxis because the doctor or nurse who's handling the secretions of this particular patient or body fluids of this person are definitely exposed to risk of developing either a Waterhouse-Fridson syndrome or probably a sepsis. For chemoprophylaxis, the best antibiotic is ceftriaxone. Do not answer rifampicin as they discuss in PSM. That's what CMDT Harrison says. Then remember the fact for prophylaxis or chemoprophylaxis in these patients for healthcare workers it is ceftriaxone. But if he specifies the word family contact and says that which organism would be responsible, then for family contact we shall be giving ciprofloxacin. And even in a pregnancy scenario, the answer would be given as ceftriaxone. So ceftriaxone is for healthcare workers, the doctor or nurse who's handling the secretions of this patient or body fluids, and also for pregnancy, because we do not give ciprofloxacin in pregnancy. You know that ciprofloxacin or fluoroquinolones are teratogenic. They affect the cartilage development in the child. So it's a good idea to actually use ceftriaxone in those circumstances. Ideally, she should not be there, but if it's like a situation given, then this would be the answer. Now, once we have worked out the common causes of bacterial meningitis, then they usually ask you regarding one, viral meningitis. Viral meningitis per se would be caused by enteroviruses. That is one of the simple MCQs, and you are not supposed to confuse that with viral encephalitis, because for viral encephalitis the global answer would be herpes. It would be HSV1 encephalitis, which is usually responsible for viral encephalitis in a patient in which nuchal rigidity would not be present in the patient. To diagnose herpes simplex 1 encephalitis, you ideally need a PCR, but you don't need to wait for the PCR report to come to start treatment in the patient. Empirical antibiotics can be started. Bloody CSF is a finding in this patient. EEG finding of periodic lateralized epileptiform discharge has been described earlier. That's because this has a predilection to damage the temporal lobe of the patient, and the damage to the temporal lobe ultimately results in manifestations of amnesia or forgetfulness to develop in this patient. This condition will be requiring acyclovir, which can be started empirically. The reason I said was that the PCR report will take some time to come. The best way to confirm the diagnosis is obviously a PCR of the CSF for herpes simplex 1. Now I want you to remember the fact that you can get a question on even aseptic meningitis. Aseptic meningitis could be having various causes. It could be viruses, it could be drugs. One of the important viruses that can cause aseptic meningitis is herpes simplex. One of the important drugs to be remembered is painkillers, that is NSAIDs, ibuprofen, which can be associated with aseptic meningitis in a patient. And then you could be reading regarding what would be recurrent episodes of aseptic meningitis. If they give you a scenario of recurrent episodes of aseptic meningitis in a patient, due to which this patient would be having headache, they would be vomiting, and there would be nuchal rigidity in the patient, there would be features of meningismus, then one of the important causes of recurrent aseptic meningitis could be again due to viruses, that is mainly herpes simplex. Lots of time herpes simplex may not be isolated even on a PCR in this patient, and PCR might take a very long time. Well, what is the difference between aseptic meningitis and a traditional viral meningitis would be that the cell counts in aseptic meningitis will be revealing a presence of pleocytosis, but the proteins in the patient would definitely not be very significantly elevated as we traditionally anticipate in any case of meningitis per se. In recurrent meningitis, which is caused by herpes simplex, one of the terms that is used in Harrison and I want to share on this slide is called as molarate meningitis. In molarate meningitis, molarate cells would be seen. As you can see in the slide, these would be, some of these are lymphocytes and some of these are monocytes. Now, if you look at the monocyte here, the monocyte here is having a very peculiar nucleus. This actually looks like a footprint actually. So, molarate meningitis is responsible for footprint cells. And what are footprint cells? These are basically monocytes only. These monocytes, the nucleus is having this weird appearance like the toes of a person. So, footprint filament cells or mollaret cells are encountered in patients of mollaret meningitis. And what is mollaret meningitis? It is recurrent episodes of aseptic meningitis in a patient. The cause of this is again herpes simplex only. I repeat my statement. If the question is mainly asked to you as viral meningitis, it is enteroviruses to be answered. If he specifies the word mollaret meningitis, then it is herpes simplex. What is it? It is a recurrent episode of aseptic meningitis presenting with meningismus. For viral encephalitis, the usual cause is HSV1, which would be associated with bloody CSF. Causes of bloody CSF that I've taught you are, one is trauma obviously, then can be subrecurrent hemorrhage, then could be herpes simplex, or it could be bleeding diathesis in a patient. That could be like warfarin toxicity that could be associated with bloody CSF developing in a patient. Now, once we remember these aspects that I've highlighted before you for the various organisms, then I also want you to remember that if you read a feature of CSF findings of an individual, that should also prompt you to think in terms of meningitis. One of the important CSF findings which is to be remembered would be that if lymphocytes are increased, there is a lymphocytosis and there is also a significantly increased proteins, then you have to think in terms of tubercular etiology. But if you find that there is a lymphocytosis given in the question with respect to the CSF, and then you notice that the sugar of the CSF is normal, and then you notice that the proteins are elevated but not very highly elevated, you should think in terms of possibility of viral etiology. So tubercular meningitis usually will be having a presence of a straw colored CSF. If that is given, everything will become much more simpler. But when it comes to viral etiology and viral meningitis in a patient, then this would be the picture that would be encountered in the patient. The proteins are elevated because antibodies are definitely being produced, but when we say aseptic meningitis, the proteins can be normal also in the patient. Then if you get everything normal, that is all the cell counts are normal, even the sugar is normal, even the proteins are the only thing that are elevated. I mean, everything is normal, including the color, the proteins of the patient are the only things that are elevated, then that points to Guillain-Barré syndrome. Guillain-Barré syndrome would be albuminocytological dissociation. This is a good point to pick up Guillain-Barré syndrome, the diagnostic criteria which are called as Brighton criteria, and I'll discuss on a separate part of the slide. Then if you read xanthochromic CSF would be having a yellowish tinge to the CSF. This yellow tinge is due to bilirubin. So it is not to be answered as jaundice, but xanthochromic CSF is to be answered for SAH, that is subrecurrent hemorrhage, especially the delayed presentation, that is after 24 hours. In a case of subrecurrent hemorrhage, xanthochromic CSF would be present and would be responsible for this manifestation in the patient. Now, once you remember this baseline data for the CSF findings of the patient and CSF infections, if they ask you regarding brain abscess, then one of the leading causes of brain abscess happens to be anaerobes. Usually the brain abscess can be located in any part of the brain per se, but if it is after CSOM, chronic suppurative otitis media, then mostly the location of the abscess would be the temporal lobe where the abscess can be located. And if it is going to be seen with tetralogy of Fallot, that is the TET spells, in TET spells there is a possibility of ischemic damage to the brain and then the secondary infection there. So usually the location of the brain abscess after a TET spell should be remembered as parietal lobe of the patient, and for treatment of brain abscess we will have to go in for a CT guided aspiration so that we can remove the pus which is present in the abscess, and then subsequently antibiotics will obviously be given for at least 3 weeks for the patient. But the main treatment would be, because abscess will usually form a wall across which the penetration of antibiotics is bad, so as such for brain abscess it would be CT guided aspiration and a definitive management for the patient. Now, once we have taken care of the meningitis part, in fact the only, I would say, add-on point that I've given you is mollaret meningitis, that is recurrent aseptic meningitis, which is caused related to HSV. We go to the next part of our discussion where we will talk about diseases that affect the basal ganglia with respect to copper deposition in the basal ganglia and iron deposition in the basal ganglia. The copper deposition is occurring in the lenticular nucleus of the patient, and is responsible for creation of the face of panda appearance. You know the fact that this giant face of panda appearance that I'm talking about is a feature of Wilson disease. But then I'm talking about iron deposition in the putamen of the patient. Iron deposition in the putamen is primarily responsible for creating a disease that is called as Haloverden-Spott's disease. This is a neurodegenerative disorder. The characteristic feature of this would be that the iron will shine up. Like if I just zoom in, you will notice like the iron will be attracted by the magnet of the magnetic field, so it shines up like the light, like the eyes of a animal. Like in a Discovery television show, you know, when they show wildlife in Africa, in the night when they put on the camera, the eyes of the animal is shining. Similarly here, the eyes of the animal is shining. Eyes in the CT scan, that appearance of the basal ganglia looks like an eye which is shining in the dark. So therefore this appearance is called as eye of the tiger appearance. A very animal inspired sign, I would say. Eye of the tiger appearance is seen with Haloverden-Spott's disease. An alternative name for Haloverden-Spott's disease is neurodegeneration in the brain with iron accumulation. This, I would say, is a differential diagnosis of Wilson disease, where it is rather the lenticular nucleus that is involved versus Haloverden-Spott's, where there is iron deposition in the putamen of the patient. Now we can quickly look at the neurological features for Wilson disease. In Wilson, in the first 10 years of life, obviously there would be damage to the liver in the patient, and there would be subsequently manifestations of neurological importance. If he says what is the most common neurological manifestation in this patient, it would be development of tremors. There would be rigidity and dysarthria developing in the patient. The patient will also become relatively slow, and the voice of the patient will also be relatively unclear. For management of the CNS features of Wilson disease, normally for Wilson disease we obviously use zinc acetate, but for here you will have to use a molecule by the name of tetrathiomolybdate. This is mainly used for management of neurological features. The question's language would be neurological features in Wilson are handled with, that is tetrathiomolybdate in a patient. We do not have any drug of choice for neurodegeneration in the brain with iron accumulation, but that's again an important question that is to be remembered. Since I spoke about basal ganglia in this case, I'll just add up a slide quickly for the basal ganglia in the patient. I want you to remember the fact that whenever you read eye of the tiger appearance, that is always a feature that is encountered in patients who are having neurodegeneration in the brain with iron accumulation. Now look at the way he, in the recent May 2019 AMC twisted the MCQ. The question was given as tigeroid appearance of the brain parenchyma with respect to MRI of the patient. So the tigeroid appearance is with respect to a leukodystrophy. What I mean by leukodystrophy is the disease would be, leuko means white. There is a problem with the white matter of the brain. This problem with the white matter of the brain is a hypomyelination syndrome, and this tigeroid appearance of brain. Why I'm saying tigeroid is like you can see the stripes of the tiger. Similarly, the hypomyelination areas would strike up very clearly. In fact, I can use a different color to highlight that. This tigeroid appearance looks like stripes of the tiger. Even the ventricles in the brain of this patient look relatively dilated. So this tigeroid appearance shows linear hypointensities radiating from the ventricular margins and is a diagnostic of a condition that is called as Pelizaeus-Merzbacher disease. As I was saying, it is a hypomyelination syndrome and has a genetic presentation or genetic cause. The gene for this is PLP gene on chromosome number 22. Now, before I describe the clinical features of this, which would be neurodegenerative only, the basic point is that two aspects are to be remembered. One, I'll repeat again, is eye of the tiger appearance on MRI, that is Haloverden-Spott's or neurodegeneration in the brain with iron accumulation, and tigeroid appearance is Pelizaeus-Merzbacher syndrome. That would be a disease characterized by presence of these hypodensities which are present radiating from the ventricular surface. Now, this will always be having a pediatric presentation. Why I'm saying this is because of the fact that if you are given a MRI head in which you are noticing that it is an adult and the adult is having these hypodensities, which I'll use gray color to represent, and they're radiating like this. These are linear appearances which are radiating from the periventricular area of the patient, like I have shown at the moment. Then these are in adult patient are Dawson fingers, and Dawson fingers are encountered in patients of multiple sclerosis. So I want you to be clear about the fact that whenever they give you periventricular lesions, the periventricular lesion, one of them that is to be remembered is Dawson fingers. And that is a feature in MS, multiple sclerosis, which is a demyelinating disorder. In contrast, the one that I'm talking about at the moment is Pelizaeus-Merzbacher, which will be having a pediatric presentation. Most of the time there would be neurodegeneration and regression of milestones in the patient. There would be nystagmus in the patient, there would be tremors, there would be ataxia in the patient. In this particular case, you will notice that the ventricular, the hypomyelination was in the form of stripes like these, that was radiating from the periphery towards the ventricles of the patient. So like the stripes of a tiger, I would say. This is a tigeroid appearance. This would also be periventricular lesions, but would be having a pediatric presentation. That is Pelizaeus-Merzbacher syndrome or disease. In multiple sclerosis, the traditional presentation will be of an adult with loss of vision in the patient, that is optic neuritis. Whereas in Pelizaeus-Merzbacher disease, it will mostly be a child. And the feature of this particular child, where the manifestations would be that of neurodegeneration, that is regression of milestones. Like this child earlier could walk, but now he cannot walk, he will crawl, and then sometimes will become totally bedridden. There would be nystagmus, there would be ataxia. This truncal ataxia might even cause difficulty in sitting in the child, and all the milestones of the child will gradually begin to regress in the patient. Neurocysticercosis will always have cystic lesions, so that is never a problem, and there would be round hypotense lesions found in MRI. But these are two comparisons that I basically want you to remember. Now, since I was saying I'll talk about basal ganglia. Lots of time questions on basal ganglia have been asked, so a quick revision for basal ganglia related diseases. One, I wanted to remember that one of the manifestations of basal ganglia damage is chorea, another one is ethiotosis, and the third one is hemibellismus. You should be aware of that how these manifestations appear in a patient. So chorea will be found in the hands of the patient. It would be a fast. It would be purposeless, like at the moment if you're noting down the information that I'm saying, then you will notice the fact that there would be one hand of yours is noting and the other hand is stable. But in this case, there would be a purposeless movement, a semi-purposive movement that would be occurring in the hand of the patient. There would be a distal involuntary movement occurring in the hand of the patient, and if it will involve the writing hand, then involvement of the writing hand will result in spoiling of the handwriting of the patient as well. In contrast to chorea, ethiotosis is always relatively slow, and the hand movement would be like this. The hand of the patient, like if you look at my hand, it's like a very slow writhing movement of the hand of the patient. So even for video based questions, they can mention regarding these slow writhing movements. You can in my book or in the app, you can go through the video based section where I posted a couple of videos there of involuntary movements in the patient. That is chorea, ethiotosis, hemibellismus. All three videos are there. Do have a look at them before you sit for the final exam. These would be slow writhing involuntary movements, and these are again distal. So these movements are found in the hands, but hemibellismus is gonna be found in both the hands as well as in the shoulder. It's wide flinging movements of the hands of the patient. So hemibellismus is found both proximally as well as distally. Hemibellismus can be imagined as like you go to a marriage party in India, the way the people start behaving after one or two drinks, and they're dancing on the dance floor, and that's when hemibellismus kind of violent movements can be seen. That's pun intended. The wide flinging movements of the arms or of the legs of the patient is called as hemibellismus. For chorea to occur in a patient, remember the C alphabet. The basal ganglia that would be involved in the patient would be caudate. For athetosis, the basal ganglia to be involved in the patient would be globus pallidus. And for hemibellismus, the basal ganglia to be damaged in the patient would be the subthalamic nucleus of the patient. So these are three, I would say, areas which are damaged to contribute to manifestations. Now, once you have remembered this, then step 2 would be to remember regarding one, Huntington's chorea, and second is Sydenham's chorea. Huntington will always be having an adult presentation. The patient will be usually 50 years of age onwards. Huntington's chorea is a autosomal dominant condition and would be occurring in multiple generations. And if father and son both are having it, then son will be having it more severe than father, and father will be having more severe than grandfather. That is anticipation. Anticipation basically means that in every generation, the disease will become relatively more severe. The disease severity will keep on increasing. The disease will become relatively more severe in Huntington's disease or Huntington's chorea. The gene involved here is Huntington gene. The chromosome that is involved here is chromosome number 4. And when it comes to Sydenham's chorea, that is obviously a manifestation that is encountered with rheumatic fever. So that would obviously be a child. There would be no genetic basis there. And you would be having, in this case, poor school records or poor handwriting developing in the child. I want to make it very clear to you that involuntary movements in the hands of a child may not only be Sydenham's chorea but can also be possibility of Wilson's disease. But if the question begins by saying recurrent sore throats also present in the child, and then also mentions that there is no any liver disease involvement, whereas in Wilson there would be a liver involvement as well, so you will get hints regarding the question which talks about involuntary movements per se with respect to liver involvement and without a liver involvement. Now, Huntington's chorea will present with development of dementia at as early as 50 years of age. That would be pre-senile dementia occurring in a patient. Then there would be obviously chorea. Dementia with chorea is anyway a very characteristic combo of Huntington's chorea. Basal ganglia features like rigidity and bradykinesia, slowness in walking, slowness in talking, slowness in going to bathroom can contribute to poor hygiene, could be a manifestation. In Sydenham's chorea, he will talk about a child with poor school grades because his handwriting is becoming bad. He is not able to draw or sketch or do proper coloring. And then one of the key words would be that he might say the word hung up reflexes, which are a characteristic feature of chorea. Then after hung up reflexes, another feature which is to be remembered for Sydenham's chorea would be pronator sign and darting tongue. The child will be asked to take his tongue out of his mouth. I mean, a normal person like you and me can stick tongue out of the mouth, but in this particular case, you will notice that the tongue will keep on going in and out of the mouth repeatedly. So, darting tongue is again a feature that is very characteristic for Sydenham's chorea. There is no imaging required for Sydenham's chorea, but for Huntington's chorea, when we do a MRI, because this involves the caudate nucleus and that is atrophied, so the lateral ventricles or the lateral horns or the lateral ventricles look bigger. So the word used is boxcar ventricle. This medical condition is characterized by excess of dopamine and deficiency of GABA, which explains the involuntary movements in the patient much better because GABA, the inhibitory transmitter, is less and dopamine is excess. For treatment of Huntington's chorea, we have to give a dopamine depleter. And the dopamine depleter that we shall be giving in the patient is tetrabenazine. This is gonna reduce the levels of dopamine, and we don't give levodopa for this condition. In fact, levodopa is contraindicated in Huntington's chorea primarily because of the fact that in Huntington's chorea, if you give levodopa, it will worsen the patient. For Sydenham's chorea, first we use non-pharmacological intervention in a sense that the disease would be self-limiting in character. But in case obviously in the MCQ he asks you to write the drug, it would be valproate and haloperidol in that order, then would be steroids, and if nothing else is working, then the final way to get rid of the problem would be IVIG, intravenous immunoglobulins, that I've highlighted earlier also, that is for medically refractory chorea in a patient. So the slide is mainly for the basal ganglia involvement in the patient, plus I've taught you two more basal ganglia involvements that are from I would say the image based aspects, that is iron in the basal ganglia and copper in the basal ganglia for Wilson and neurodegeneration in the brain with iron accumulation. Huntington's chorea is treated with tetrabenazine for multiple sclerosis. If he says how do you manage an acute episode, then the first episode of the acute episode is obviously methylprednisolone. But this is not the treatment of choice because you cannot obviously give it lifelong in the patient. If he says in the question how do you prevent, prevention aspect in multiple sclerosis, then for prevention in multiple sclerosis the molecule that you will use in the patient would be beta interferon. This is a immunomodulator drug that will reduce the immunity from attacking the self I would say myelin, and the axonal damage can definitely be neutralized. Glatiramer is another drug which is used for management of this condition, and a drug which is used as a last resort for this condition is natalizumab. Natalizumab is a monoclonal antibody which is used even in inflammatory bowel disease nowadays, but this would definitely help in I would say preventing the deterioration of multiple sclerosis patient as a last resort. Now coming to the next slide, instead of giving you aspects related to basal ganglia, they have in the paper what they've done is that they have just put markings at particular areas and asked you to identify the area. Like for this area, that is area number 3 that I am now marking before you, this is connecting the left and the right cerebral hemisphere, so you have to remember this is corpus callosum. The parts of corpus callosum to be self-studied by you from the anatomical perspective, and then you can see a structure which is separating the ventricles, like this is lateral ventricle, this is the lateral ventricle. So the structure that has been shown here separating the two, this would be about 2 to 2.5 millimeter thick. This is called the septum pellucidum. Then you can obviously identify that the structure which would be adjacent here, this would be the caudate nucleus. And then inferiorly as we go, we would be talking about the thalamus of the patient, or if we go laterally, we will be talking about putamen in the patient. This is the putamen. And medially would be globus pallidus interna and then externa respectively. What I want you to understand is that all the terms that you read in neuroanatomy, you should be able to pinpoint them on a lateral view of the, I would say lateral view or any view in a CT scan in a patient. And this was just an effort to pinpoint, because they can actually give you an image like this and say that which part of the brain would be involved in Huntington's chorea. I'll just give you another demonstration of this so that you can better appreciate my point. You see, if you look at this cut section of the midbrain, then this would be the Edinger-Westphal nucleus, and this would be the oculomotor nerve that would be going anteriorly. Then I've represented before you is the red nucleus, and then after that what I've highlighted here is substantia nigra. Substantia nigra is pigmented, and you all know that nigrostriatal degeneration of this area will result in development of Parkinsonism in a patient. So he can, like for example, put an arrow at this area which has done previously and says what disease will develop due to damage to this part of the brain. Then obviously the answer is very straightforward. It would result in PD, that is Parkinson disease in a patient. Or for that matter of fact, instead of talking about what disease will occur, he might ask you regarding which genes can be contributing to this. So you know that for Parkinson disease, it is PARK1 gene and Parkin gene. There are two of them. One is PARK1, Parkin gene. So PARK gene per se would be located to chromosome 1, and Parkin is literally located to chromosome number 6. So he can ask you chromosomal relations to this, or he can put an arrow at this area and say what is the manifestation. Similarly, if you go posteriorly, I can show you here is the third ventricle, and then what is present here is the nucleus of the fourth nerve. that is the trochlear nerve, which would be crossing over like this. You know that trochlear nerve is the only cranial nerve having a crossed origin, so he can put an arrow here and say what will be the manifestation. That would be superior oblique paralysis, the cheating muscle. I mean, superior oblique is which will help you, like, you know, cheat from somebody's cheat. So looking down like this, right, downwards and laterally. So superior oblique muscle paralysis can contribute to the cheating muscle of the patient getting paralyzed. Then this area is the superior colliculus, and damage to the superior colliculus can result in impairment of the vertical gaze of the patient. Diseases that involve the superior colliculus could be like progressive supranuclear gaze palsy, PSP. The disease present here would be PSP, progressive supranuclear gaze palsy, which can actually contribute to impaired vertical gaze of the patient. So let me say, from this slide I've talked about two diseases: Parkinson disease, progressive supranuclear gaze palsy, and they are affecting the midbrain only, but the area of the midbrain involved are the substantia nigra and superior colliculus respectively. So you should be definitely in a position to identify these anatomical structures. And believe me, septum pellucidum, very simple, that separates the two lateral horns of the ventricles from each other. People were not able to identify. I mean, that is what pressure does to you in the paper. Moving to the next slide, we will revise quickly the aspect of brain tumors. One of them is a pediatric brain tumor, the other one is an adult brain tumor. When it comes to the pediatric brain tumor, it would be originating from the Rathke's pouch. You all know the fact that the benign brain tumor in children, the benign brain tumor in children is the one which is shown here, that is craniopharyngioma. This is at the area of the pituitary only. The other one that I've shown here is a hyperdense lesion on a CT head, which is a benign brain tumor that will exhibit intracranial calcification and is a meningioma. Let us revise the data from both pediatric and adult perspective. If they ask you regarding that, what is overall the most common tumor that is encountered in pediatric age group, then it is obviously blood cancer. But after blood cancer, the second most common tumor that is encountered in children happens to be the brain tumor. Now, the aspect to be remembered is, for brain tumor, he might mention the word malignant brain tumor. Then the most malignant brain tumor when it comes to children is medulloblastoma. Do not answer for malignant brain tumor. The answer is medulloblastoma. Yes, I mean cerebellar astrocytoma is also there, but cerebellar astrocytoma would be a benign brain tumor. Now, for brain tumors, he might, instead of writing the word malignant or benign, he might say the word infratentorial brain tumor in children, which is relatively benign. Then infratentorial benign would be cerebellar astrocytoma. In pathology class, they will use the word pilocytic astrocytoma. Whereas if they use the word supratentorial, then for supratentorial brain tumor that I'm talking about, the answer would be given as craniopharyngioma, the one which is shown in the image. Craniopharyngioma, guys, can show intracranial calcification. That is why it is important and is visible on a CT and even on a MRI head of the patient. In fact, details for craniopharyngioma, I'll use one more slide for that. You see, craniopharyngioma is originating close to the pituitary, so visual deficits will definitely be occurring in the patient. This usually originates from the areas of the Rathke's pouch. For craniopharyngioma, you need to specifically remember the fact that this is visible even on X-ray skull. In fact, the question was, which brain tumor in children is visible on X-ray skull? There was an image-based question in NEET 2018 also, where intracranial calcification was present on X-ray skull in the area of the pituitary close to sella turcica. So visible on X-ray skull. I mean, what my students did was, they drew before me like this. They said they could see the sella turcica, the clinoid process in the lateral view of the skull, and then around this, obviously, they could see multiple calcified spots, and these calcified spots were indicating presence of craniopharyngioma in the patient in the area of the Turkish saddle, that is sella turcica. Craniopharyngioma usually results in child presenting as a short stature, so he will not begin the question by describing straight away headache, vomiting, sixth nerve palsy. He will describe to you a child with short stature. This child will also be having nephrogenic diabetes insipidus due to the tumor causing pressure on the posterior pituitary. So polyuria and polydipsia could be described in the question. Because of this tumor affecting the hypothalamus of the patient, there can also be development of precocious puberty. So he will describe a short kid, polyuria, polydipsia with precocious puberty, and the child has now started having visual deficit. The visual deficit that will develop in the child will be that of bitemporal hemianopia over a course of time. So this clinical history will obviously point towards presence of craniopharyngioma. The diagnosis of this condition is obviously made on a CT head, and this is a cystic tumor. The wall of this is calcified. The surprising thing is it is a cystic tumor, the wall of which is calcified, and inside this we found the liquefied contents inside this tumor are called as a machinery oil appearance. This machinery oil viscosity or machinery oil viscosity is machinery oil viscosity or machinery oil appearance of the contents inside this tumor is the one which is of consideration. Obviously surgical management for this is recommended. Going back to the aspect of meningioma, which is one of the primary brain tumors, I got a query from a couple of doctors saying that pathology book says that one of the most common primary brain tumor is rather glioma. Now I want you to understand that the most common, this is what Harrison is saying, so I have included this plic. It says that meningioma is now the most common primary, not benign versus malignant, we are not talking about, we're just saying which is the commonest primary brain tumor. Then the incidence is given to be 35%, and there is no incidence given in other books supporting this claim. So I want to make it very clear to you the fact that if he says that which is the common brain tumor in children, obviously overall is METS, but we are talking about primary would be answered as meningioma. So let's just write down the data. The overall number one brain tumor that you encounter in adult population should be answered obviously as METS. And where will the METS come from? They will come from lung cancer, so it would be oat cell cancer of the lung where they're coming from. Then another site where they can be coming from can be breast cancer, and then can be malignant melanoma in that decreasing order of prevalence, with oat cell cancer obviously leading the list. But if he says the word primary brain tumor, then you have to remember that for patients who are having a primary brain tumor, the answer would be given as meningioma followed by astrocytoma. Both are given in options, and they've asked this in the paper that primary brain tumor is meningioma followed by astrocytoma. Once you have remembered this information, then we should also remember that what is the investigational choice for brain tumors. So overall, the best investigation for diagnosis of brain tumors in a patient should be answered as MRI, and it should always be answered as gadolinium enhanced MRI. That gadolinium enhanced MRI because you wanna demonstrate the damage to the blood-brain barrier in the patient, and because most of the brain tumors can be associated with a vasogenic cerebral edema. The drug of choice for vasogenic cerebral edema would be answered not as mannitol. I repeat my statement. The drug of choice for vasogenic cerebral edema is not mannitol. The drug of choice for vasogenic cerebral edema should be given as dexamethasone by the patient, by you. This would be again an important question to be remembered. Not cytotoxic. I'm talking about vasogenic cerebral edema. It is Dexona to be used, and brain tumor can be associated with it. In fact, brain tumors can cause seizures also. Why? Because they can contribute to the manifestations of cerebral edema in a patient. So once you have identified the brain tumors in the patient, and gadolinium enhanced MRI is obviously the preferred one, then is the treatment of this, which would be radiotactic or stereotactic radiosurgery, and that stereotactic radiosurgery would help you in identifying the damage with respect to these patients. The treatment would ideally be given as stereotactic radiosurgery, and in case it is metastasis, then cranial irradiation can be used for management of the patients. Okay guys, the next disease that we shall be studying is neuromyelitis optica spectrum disease, and this is a new terminology to differentiate this from multiple sclerosis. In earlier textbooks, they used to write Davick's disease as a word, and this Davick's disease word has now been replaced by the term neuromyelitis optica spectrum disease. So let's have a quick look at what the disease manifests as. And there have been 2 questions consecutively in the AIMS exam on this one. So I think that this is anyway an important topic which is to be remembered. Now, if you look at the name neuromyelitis optica spectrum disease, one of the highlight of this particular disease would be that patient would be having a optic neuritis, which could be sudden in onset and would result in blindness. Since it's an autoimmune disorder, most questions will begin by describing a female patient in the reproductive age group. And initially she might be having problems like color vision is becoming lesser in the patient, contrast differentiation is little difficult for the patient, but following the difficulty in vision with respect to color vision becoming less and contrast being affected, blindness of sudden onset can occur in this person, and that would be very catastrophic. But the good news is that in these patients this blindness will not last permanently. It would be rather having a resolving course over a duration of 1 week. Our objective is obviously to reduce the disability of the patient, so we will have to use steroids in the patient. In this patient, along with optic neuritis, the second feature would be involvement of the spinal cord. That would be transverse myelitis, which is usually written in books or in MCQs as LETM. Now, what I mean by LETM is it is longitudinally extensive transverse myelitis, and what you mean by longitudinally extensive is that it should be having at least involvement of 3 or more spinal cord segments, like for example T3, T4, T5, or like L1, L2, L3. So at least 3 spinal segments are consecutively involved in the patient, due to which neurological features will develop in the patient. What will be the manifestations of transverse myelitis? There could be a development of paraparesis or paraplegia, or in case it is the cervical spine that is involved in the patient, then it could also result in development of quadriplegia. So paraplegia and quadriplegia are anyway related to the disability in this patient, and along with this paralysis, a special very striking feature would be differentiating it from Guillain-Barré syndrome would be the sensory complaints of the patient, where the patient will say that I feel as if somebody has poured acid over my legs, or he will say that I feel as if somebody has tied a wire around my leg, military grade wire, and is then tightening the wire as if trying to cut my body into half. So you will definitely be having very pronounced sensory complaints in transverse myelitis, which would be most of the time described by the patient as lancinating pain or burning pain or tearing pain. So various descriptions by various patients, but sensory complaints are very minimalistic in Guillain-Barré syndrome and are very predominant in this patient. And yes, even bladder and bowel can be involved in the patient. What I mean by bladder and bowel involvement is incontinence could be a manifestation in this patient, whereas in Guillain-Barré syndrome, bladder and bowel is usually spared. So the basic point is, when you read regarding optic neuritis and transverse myelitis simultaneously in a patient, the words that you will use would be neuromyelitis optica. Now, a specialized feature for this particular disease, which is add-on to what we used to read earlier, would be that this disease can involve even the hypothalamus of the patient, where the vomiting center would be located. So area postrema syndrome word can be written. What you understand by the word area postrema syndrome would be that there could be hiccups in a patient, it could be unexplained vomiting in a patient, there could be development of rather continuous vomiting, difficult to manage with the standard drugs in the patient. Then can be involvement of the brainstem in this condition, where again the demyelination will occur. And what I mean by brainstem syndrome is that there could be manifestations of ataxia, there could be diplopia, because cranial nerves are gonna be originating from the brainstem. So what I'm saying is that apart from the involvement of the optic nerve in the patient, do not be surprised if he starts mentioning regarding features of other cranial nerve involvement in this patient, and that is why now the name of the disease is NMOSD, that is a spectrum disease. Now, why is this disease occurring after what really happened? So the reason for this is an autoantibody by the name of anti-aquaporin 4 antibody. This anti-aquaporin 4 antibody is against the water channels in the brain cells, or rather water channels in the blood-brain barrier. The presence of this antibody is important for diagnosis. Even if the antibody is absent and there are only some clinical, because antibody may not be detectable, so clinical features would still make you think in terms of this particular disease. This antibody will be damaging the water channels which are present in the food processes of the astrocytes and is a major diagnostic criteria. For management of this condition, we will have to give methylprednisolone to the patient, which is the drug of choice. It's a quick high dose high potency methylprednisolone followed by a taper. You will stop methylprednisolone not suddenly but taper by giving prednisolone. And the monoclonal antibodies which are being used in this condition now are eculizumab and rituximab. So even azathioprine has been tried but with varying results. So the main management of this condition will be a presence of autoimmunity. For management of this disease, if aggressive treatment is given, then the disability of the patient will be reduced. I mean, patient will not be permanently blind, but the contrast comparison and the vision part from the color vision perspective, ability to differentiate between two colors, that would definitely be affected in this particular patient. Let's revise this data once again. Neuromyelitis optica spectrum disease should be having optic neuritis. There should be acute myelitis, area postrema, brainstem syndrome in a patient. These are the usual features. Then I'll add up to the discussion, which is not very important, I would say, but because it is given, we can read it. One is symptomatic narcolepsy, which can explain the unexplained or rather irresistible desire to sleep. And acute diencephalic syndrome, well, what is it? This is characterized by failure to thrive and development of wasting in an individual in spite of normal caloric intake. So somehow the caloric intake and the appetite center of the patient is normal, but then the metabolism in the body is affected, so the patient will become very thin and emaciated. So the basic point is, if you are having these kind of manifestations in a patient, that is at least one of these core clinical characteristics are present in a patient, and there is a presence of an antibody, that is anti-aquaporin 4 antibody, then we will definitely say that the patient is having a diagnosis of NSMOD, and methylprednisolone will be initiated in the patient. Let us look at how this disease is different from Guillain-Barré syndrome. Guillain-Barré syndrome per se as a disease will not be causing involvement of the optic nerve, but will be causing involvement of the seventh nerve. You all know that the most common cranial nerve involved in Guillain-Barré syndrome is the seventh nerve. The presentation in Guillain-Barré syndrome would be like this. The patient will wake up in the morning with inability to move both his ankle joints. So the early presentation of this patient would be distal areflexia. The paralysis in the legs of the patient will be of the lower motor neuron variety, because there is a demyelination, that too a segmental demyelination or a patchy demyelination occurring in the patient. This segmental demyelination or a patchy demyelination that is occurring in the patient is due to the antibodies which are formed. The name of the antibodies in Guillain-Barré syndrome is by the name of anti-GM1 antibody, which causes this demyelination in the spinal cord and the peripheral nerves of the patient. Now, because of the fact that there would be a distal areflexia and a flaccid paralysis in the patient, when you will compare the paralysis of the left leg with that of the right leg, you will notice that the paralysis will start going from bottom upwards like this. So that's why you read the word ascending symmetrical flaccid paralysis. Symmetrical because the paralysis of the left leg will be equal to that of the right leg of the patient, and it would go from bottom upwards. There is a distal areflexia, lower motor neuron lesion, and a symmetrical flaccid paralysis occurring in the patient. Even there could be involvement of the arms of the patient, there could be diaphragmatic involvement, truncal involvement in the patient. And the worst case scenario is that if the neck gets involved, that is cervical spine gets involved, demyelination, there would be respiratory insufficiency, ventilator dependency, and then in these patients, seventh nerve will also be involved. Bilateral seventh nerve palsy is a feature that is encountered in patients of Guillain-Barré syndrome, whereas in neuromyelitis optica, it is going to be the optic nerve of the patient that would be affected. Medical conditions that can cause bilateral seventh nerve palsy can be sarcoidosis, where the enlarged parotid gland can press on the seventh nerve of the patient. Then apart from sarcoidosis, Melkersson-Rosenthal syndrome, This would be having a bilateral seminal palsy with even fissured tongue. There would be a very appearance of scrotal tongue, I would say, or fissured tongue in a patient. And then apart from Belkerson-Rosenthal, obviously Guillain-Barré syndrome is what we are studying. So this would help you crack all except kind of a question where 3 causes of bilateral seminal paralysis are present in a patient. Now for the workup of this patient, you will be going in for a lumbar puncture. And when you perform the lumbar puncture of this particular patient, you will be getting a finding of albuminocytological dissociation. What that means is that the color of the CSF is normal, pressure is normal, cells are normal, sugar is normal. Everything in the CSF of the patient is perfectly normal, but the proteins in the CSF of the patient would be grossly elevated. So the word is AC dissociation or albuminocytological dissociation. In this condition, you will notice the fact that the sensory complaints of the patient are very minimalistic. That is, patient will not say that somebody is pouring acid over my legs, somebody is trying to cut my legs, or pouring boiling water over my legs. They would just be paresthesias or tingling sensation. Bladder and bowel is paired. In fact, they have given a situation like this, that they said a person is having ascending paralysis, it is symmetrical, it is going up, and then he's mentioned bladder and bowel are not involved in this condition, and he said what is the probable diagnosis of the patient. So your answer would be given as Guillain-Barré syndrome, whereas bladder bowel involvement is a feature of transverse myelitis and can be encountered even in neuromyelitis optica. In these patients, the course of the disease or the progression of the disease would be something in the range of, over 12 hours, you could have a fast progression, and the upper limit of progression will usually be 28 days, that is over 4 weeks, because if the progression goes up to, let me say, instead of 4 weeks, he says 12 weeks, or he says 9 weeks or 10 weeks, whatever, then it is CIDP, chronic inflammatory demyelinating polyneuropathy. So I want you to remember that for GBS, where the drug of choice is again intravenous immunoglobulins, followed by plasmapheresis. We do not answer steroids in this case. We do not answer methylprednisolone for this condition, because this condition is rather segmental demyelination due to the type 4 hypersensitivity reaction, which is better managed with intravenous immunoglobulins. Now, once you have listened to this data, I want you to remember the diagnostic criteria. The diagnostic criteria for Guillain-Barré syndrome are called as Brighton criteria. So let's look at what Harrison says for Brighton criteria. He says patient should be having a bilateral flaccid paralysis of the limbs, as I just explained to you, and it can involve the upper limbs also, so quadriplegia. There would be decreased or absent tendon reflexes in the weak limbs of the patient. So if he says what is the early presentation of GBS, the answer is distal areflexia in a patient. That is, the ankle jerk will be the first one to be lost, then is the knee jerk to be lost in the patient. Monophasic illness basically means that the progression of the disease would be constant, that is between 12 hours to 28 days. The patient will be having the weakness to progress, and then there's a clinical plateau. So it's like this: the symptoms appear, then they continuously stabilize in a patient, and usually the progression of this disease can be as fast as over few hours, and then there would be a plateau followed by obviously the recovery of the patient. When you will be doing a lumbar puncture of the patient, you will be noticing two aspects from the investigation perspective. One is that there would be electrophysiological findings consistent with GBS. What I mean by electrophysiological findings is like if you do nerve conduction velocity would be reduced. To make it sound sophisticated, he might say increased latency period. He will say increased latency period of the H reflex. Increased latency period of the H reflex basically means the time required for the current to go to the spinal cord and back from the spinal cord will be increased. And then is obviously the albuminocytological dissociation in the patient, where the cell count can be slightly elevated or normal, but proteins are obviously elevated in a patient. So if you demonstrate this kind of a presentation, flaccid paraplegia developing over 12 hours to 28 days, bilaterally present albuminocytological dissociation, areflexia obviously present in a patient because lower motor neuron lesion, then you will say patient is having GBS, that is Guillain-Barré syndrome in a patient. So let's just quickly revise these demyelinating aspects that I have highlighted before you, so that we can remember them on a long-term basis. The comparison is between Guillain-Barré syndrome versus transverse myelitis. versus Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome, and last but not the least, neuromyelitis optica with spectrum disease. So these are the 4 diseases that we will have a quick look at before we proceed further. When it comes to Guillain-Barré syndrome, the main features of this would be ascending, flaccid, symmetrical paralysis. The patient will be just zapped. He will say that, doctor, I went to bed just like normal, and when I get up in the morning, I can't have any power in my legs. He thought that he slept in some wrong position that compressed the nerves of the patient. He tried to stand up, he fell flat on his face. And the progression in this guy can be so fast that you could be having a diaphragmatic paralysis developing in a patient. So ventilator dependency can be required in Guillain-Barré syndrome. Then bilateral 7th nerve paralysis can be encountered in the patient. Facial diplegia will be the term that the examiner will use to describe that. Bladder and bowel are usually spared in this condition. Autonomic insufficiency will be seen, like you could be having demyelination of the thoracic part of the spine, which provides sympathomimetic stimulation to the heart. So due to the autonomic insufficiency, there could be bradycardia developing in the patient, there could be hypotension developing in the patient, there could be neurogenic shock developing in the patient. But bladder and bowel will definitely not be involved in this condition. Bladder and bowel will remain perfectly normal in this condition. In contrast, when it comes to transverse myelitis, the paralysis of the patient initially might be appearing the same because there would be spinal shock developing in the patient. Later on, obviously, it will progress as that at the level of the lesion, lower motor, below the level of the lesion, upper motor, but initial presentation is same. And even in this condition, you could be having a diaphragmatic paralysis developing in a patient, but there is no 7th nerve palsy that is documented in this condition. Autonomic insufficiency can also be the same, but bladder and bowel involvement is there in transverse myelitis. Incontinence will be a feature. There could be urinary incontinence or bladder incontinence. In Miller-Fisher syndrome, I want you to remember a triad. The triad goes by the name of OAA. O stands for ophthalmoplegia. And the standard question that will come will be, which cranial nerve is involved in Miller-Fisher syndrome? It will be the oculomotor nerve. A would stand for ataxia, A would stand for areflexia. So the Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome, is characterized by the fact that it starts from a cranial nerve palsy, whereas in GBS it starts from bottom upwards, here it's going from top downwards. NMOSD is a neuromyelitis optica with a spectrum disease, which would be characterized by the presentation of the following findings in the patient. That would be the cranial nerve which is involved in this condition is optic neuritis, which will cause color vision to be reduced, contrast vision to be affected, and then obviously blindness would ensue, but usually there is a recovery. So it's not a permanent blindness, but is obviously nerve-wracking, because if you just can't see, anybody would freak out. The combination of this with LETMS, that is longitudinally extensive transverse myelitis, which spans over 3 spinal cord segments like T3, T4, T5, or anywhere in the spinal cord, is longitudinally extensive transverse myelitis. Then could be area postrema syndrome, where this person would be having recurrent hiccups, recurrent vomiting episodes to developing in an individual. Then could be brainstem syndrome in a patient, that could present as diplopia in the patient. It could be presenting as ataxia in a patient, since the spinocerebellar pathways could be involved in this condition. And for neuromyelitis optica spectrum disease, you could also be having a rare presentation of narcolepsy, undesirable desire to sleep, or diencephalic syndrome. What is diencephalic is development of wasting in the individual. The weight of the person is falling in spite of normal caloric intake. I mean, the patient would be having FTT, that's called as failure to thrive. I mean, a person will say like this, that I eat, but I don't know what's going on in my body. The metabolism rate is going crazy, that I'm losing weight in spite of everything, which is something that you might encounter even in tuberculosis, you might encounter in HIV. But with a guy with the neurological features, or a lady especially with neurological features like this, I'm saying lady because this is an autoimmune disorder. And then let's quickly also name the antibodies which are responsible. For Guillain-Barré syndrome, the antibody to be remembered is anti-GM1 antibody. For Miller-Fisher syndrome, the special antibody to be remembered is anti-GQ1 antibody. I mean, normally in CNS, we usually don't study what antibodies, but here we are. And for neuromyelitis optica spectrum disease, the antibody that we have to remember is called as anti-aquaporin 4 antibody. Once we have remembered the clinical profile of each one of them, the antibodies responsible, last we'll just squeeze in the drugs for each one of them. For Guillain-Barré syndrome, the drug of choice is intravenous immunoglobulins. For transverse myelitis, where bladder bubble involvement will be seen, it is methylprednisolone. If it says what is the treatment of Miller-Fisher syndrome, it is again intravenous immunoglobulins followed by plasmapheresis. And for neuromyelitis optica spectrum disease, it would again be given as methylprednisolone in the patient. Before I end this slide, I also want you to remember a term that is called as CIDP, that is chronic inflammatory demyelinating polyneuropathy. One of the common variants of Guillain-Barré syndrome is called as acute inflammatory demyelinating polyneuropathy. CIDP is chronic inflammatory demyelinating neuropathy. In Guillain-Barré syndrome, the spectrum of the disease or the progression is over 4 weeks. That is, over 28 days the disease symptoms can progress. Then they will obviously hit a nadir and recovery will occur. CIDP will be manifestations that would be like GBS. So I'm writing GBS mimic because it is going to be identical to GBS, but the progression here will be more than 9 weeks. Why I'm highlighting this is because if you get a question that looks like standard Guillain-Barré syndrome, always remember from the Brighton criteria, the progression of the disease should be over a duration of 28 days. If you get a question that looks like GBS, paralysis of legs, trunk, arms, then even facial paralysis in a patient, but the duration of progression is more than 9 weeks, then the answer is CIDP. And for this also the treatment is methylprednisolone. So let's finally just put pointers over conditions where you will use methylprednisolone in the patient. NMOSD, that is neuromyelitis optica spectrum disease, transverse myelitis and CIDP are 3 conditions where we will be giving methylprednisolone to the patient. So we can just quickly revise that. Some aspects of drugs acting on central nervous system. For Huntington's disease or Huntington's chorea, I taught you a dopamine depleter. The dopamine depleter is tetrabenazine. Then for Wilson disease with neurological features, that is when the lenticular nucleus gets involved, the neurological features, the drug of choice for Wilson with neurological features was tetrathiomolybdate. Then I'm introducing one more drug that begins with T, that is drug-induced Parkinsonism, where you would be having dopamine deficiency and acetylcholine excess in the patient. For drug-induced Parkinsonism in a patient, the main answer to be given in multiple choice question would be trihexyphenidyl. This is gonna be a anticholinergic drug which will reduce the manifestations in the patient. Then we have to remember regarding GBS, which is intravenous immunoglobulins. Kawasaki disease is also intravenous immunoglobulins. Acute ITP is also intravenous immunoglobulins. Chronic ITP is splenectomy and steroids. Then for transverse myelitis, for patients of CIDP and neuromyelitis optica spectrum disease, the drug of choice to be remembered is methylprednisolone. And for patients who are having multiple sclerosis, which would be a demyelinating disorder, which will also contribute to axonal damage, the drug of choice that will prevent the manifestations from developing again would be to be answered is beta interferon. If he says acute episode, then it's obviously methylprednisolone. First episode, obviously optic neuritis would set in. But if he says how do you prevent the episodes of multiple sclerosis in a patient, then for prevention purposes, it is beta interferon injections which would be given to these patients with glatiramer and other drugs like natalizumab that might be used in this condition in a last resort. But drugs acting on CNS are anyway important and have to be remembered for multiple choice questions. Also remember the fact that if he is gonna write before you simply the fact that what is the first line drug for Parkinson disease, then the first line drug for Parkinson disease should be remembered as pramipexole or ropinirole. But if he gives you a transdermal patch to be answered, then the transdermal patch to be answered here would be given as rotigotine by you. So these are some aspects of drugs acting on CNS that you should be familiar with. Okay guys, the next topic that we will revise here will be characterized by a MRI head showing a cortical ribbon appearance. If I just zoom in, you can see a very characteristic ribbon kind of appearance in the brain parenchyma of the patient as shown represented here. So cortical ribboning is a feature that is seen with variant Creutzfeldt-Jakob disease or with VCJD, which would be a neurodegenerative disorder. This would be caused by prion particles. Prion particles are called so because they do not have a DNA or a RNA. Prion particles are, I would say, the smallest living infectious particles which are seen or known to mankind. They lack DNA, they lack RNA, so they are different from viruses which are either having DNA or RNA. The only thing this thing will have will be a protein coat. You see, from biology perspective, organism is the one which should be having DNA RNA. If not present, then we say that this is a infectious particle. It's smaller than viruses and it is resistant to heat. Most of the time at 121 degrees Celsius, that is the standard temperature of autoclaving, this organism will not die. But at 135 degrees for huge 4 hours, 135 for 4 hours, this particle would die. So remember my statement, resistant to heat at 121, sensitive at 135. And the main problem with this organism is that it can very easily cross the species barrier. So it could be a disease in animals and then is coming to human beings. What I'm talking about is what internet will refer as mad cow disease. Mad cow disease is also called as bovine spongiform encephalopathy, where the animal will be having involuntary movements in the body. This animal should obviously be killed and the carcass should be disposed of or should be burned in a humanely fashion, obviously. But the meat of this animal that is sold in the open market, I mean, some animal farmers would sell the meat of this dead animal in the open market, and the customer who will consume this beef will be acquiring prion particles via the GI tract. The prion particles via the GI tract will get access into the bloodstream of the patient, and because they're very small, they can easily cross the blood-brain barrier. I've used this word blood-brain barrier multiple times before you. So what it means is blood-brain barrier is composed up of food processes of astrocytes. Like we have food processes of podocytes in the kidney, we have food processes of astrocytes which regulate the blood-brain barrier, and in this case the prion particles via the GI tract have got access into the body of this particular individual. Now see what happens. The prion particles will now start multiplying in the cytoplasm of the neurons of this guy. This is like controlling the control center. This is, I would say, like hijacking the control center of the brain, because in the cytoplasm of the neurons you are having prion particles multiplying. This prion particle is referred in the cytoplasm neuron as PRPSC. They have asked what does SC stand for, so that stands for scrappy. That is one of the oldest prion diseases known to mankind, and once these prion particles would multiply, two things would happen. One, the neuron is obviously getting irritated, so there would be involuntary movements in his body, that is myoclonic jerks. Apart from myoclonic shock-like jerky movements, sudden jerky movements, myoclonic jerks in the patient, there would be neuronal death. So the neuronal death component could result in development of dementia in the patient. So though I've said this earlier, very casually, dementia with myoclonic jerks at 30 years of age is obviously not gonna be Alzheimer's disease, which presents at 80 years of age. This would be dementia with myoclonic jerks. That would be due to neurodegeneration due to prion disease, which came from the animals. The term that we use for this is called as VCJD, and now these prion particles will damage various parts of the brain. Like for example, cerebellum can be damaged, so person would be having gait ataxia, or patient could be having truncal ataxia. Gait ataxia develops due to damage to which part of the brain? So the term that is used to describe the part of the brain that regulates the gait part is paleocerebellum. That's one of the primitive parts of the cerebellum. So walking is related to paleocerebellum that has been damaged by the prion particles. Truncal ataxia occurs due to damage to, then the answer should be remembered as archicerebellum. That is the functional part of the cerebellum that I'm talking about. So patient will lose ability to mobilize himself. Most patients would become totally bedridden. In this bedridden patient, because even corticospinal pathways can be affected, even the pyramidal neurons in area 4 of the brain can be affected. So there could be brisk DTRs developing in the patient. There could be development of Babinski sign appearing in the patient, and then as insult to injury, because the patient has become incapacitated, he might develop something as simple as a bacterial pneumonia due to immobilization. Is lying on the bed, there is stasis of secretions in the lungs, his diaphragm is also affected, so he can't even cough properly. So end result would be incapacitation and pneumonia, which would contribute to mortality. For diagnosis of variant Creutzfeldt-Jakob disease, the investigation that you shall be doing in the patient would be two of them. One of the investigations to be remembered is a lumbar puncture finding, where the CSF of the patient will be showing presence of protein 14.3.3. Now this is itself a very surprising statement, protein 14.3.3. This is basically a term describing prion particles in the CSF of this guy. If MRI head in this is performed in this individual, the special finding would be called as cortical ribboning. Another thing to be remembered is hockey stick sign. Hockey stick sign on ECG, a related MCQ, is seen with digoxin, not toxicity. Toxicity causes ventricular bigeminy. Hockey stick sign on echocardiography is mitral stenosis. So there are three MCQs on hockey stick sign that you basically need to remember, and the hockey stick sign for MRI head would be obviously a feature of variant Creutzfeldt-Jakob disease. In these patients, if you will be doing a EEG, the EEG might be showing a background rhythm with these high voltage bursts coming in between on a periodic basis every 1 second. If you monitor the patient by CCTV camera, you will notice that whenever there's a myoclonic jerk, simultaneously in the EEG of the patient, you would be noticing a high voltage burst occurring. So this is a characteristic feature and is called as periodic sharp wave complexes, or PSWC. That would help you narrow down to the diagnosis of this particular case. There's obviously no treatment for this neurodegenerative disorder, but it is mainly for these very characteristic features that I have highlighted this topic before you. And I would say that this is a disease of the 21st century, because maximum cases have been reported after year 2000. So when it comes to the topic of prion diseases, prior to the year 2000 also, we used to have similar manifestation, which was called as classical Creutzfeldt-Jakob disease. Now, when they used to say classical Creutzfeldt-Jakob disease, this was related to dura mater transplantation. Apart from this, another cause for same presentation, the presentation was dementia with myoclonus. It was called as classical Creutzfeldt-Jakob disease before year 2000. It was seen after corneal transplantation, dura mater transplantation, and it was seen with the growth hormone injections. You see, earlier we did not have DNA recombinant technology. So they used to manufacture growth hormone using cadaveric pituitary, and this cadaveric growth hormone injections, when given to a person, used to result in person developing classical Creutzfeldt. This is not reported anymore because, one, we have stopped using cadaveric growth hormone, we have started using DNA recombinant technology, and for dura mater and corneal transplantation, they've ensured that the sterilization of instruments occurs at 135 for 4 degrees for 4 hours. So the sterilization criteria have also been changed to ensure that prion diseases do not occur currently. Then one of the oldest prion diseases apart from scrapie is Kuru. You would have read, sometimes on Discovery Channel they will say tribes in Andaman Nicobar which are hostile and they have not been in contact with the human world, and lot of these tribes in Andaman Nicobar are actually cannibals, that they would be killing another human being and would be consuming the remains of the human being. So Kuru is something that is reported mostly from those areas where I would say tribal population and the practice of cannibalism would be there. And in fact, you see, Kuru last case was reported medically documented in 1950. But even today it is there in the MCQ books, or it is there in medicine textbook even in 2019. That is because of this very peculiar thing. Cannibalism is the route of transmission for Kuru. Therefore, you can see that prion diseases can be having animal to human transmission for Kuru. Classical crude flood is again human to human transmission. And then I am describing two prion diseases to you, where I'm saying that there is a genetic basis behind it. One of them is called as familial fatal insomnia, and the second one is called as Gerstmann-Schranker syndrome or Gerstmann-Schranker disease. So I want you to remember these terminologies that I've highlighted before you for prion, with the last two ones having a genetic basis. The chromosome involved here is chromosome number 20. So today I've described a very peculiar disease to you, which is having animal to animal transmission, animal to human transmission, human to human transmission, and genetic basis. I mean, normally when you study a disease, no, it will have one method of transmission only, but so many varieties of transmission is for proteinaceous infectious particles which are responsible for this manifestation, and cortical ribboning is where it all started from. We shall now be studying regarding a neurocutaneous disorder. We'll be revising a neurocutaneous disorder now, and this is one of the important neurocutaneous disorders which you can see on the screen, and I think you can already identify the ash leaf macule in this case. The ash leaf macule which is present in this case is a representative finding that is encountered in patients of tuberous sclerosis. Neurocutaneous disorder to be remembered is tuberous sclerosis. This would be a genetically acquired disorder. The genes involved are TSC1 and TSC2 genes respectively. That would be TSC1 gene for chromosome 16, TSC2 gene for chromosome 9. Once you remember the genes aspect, then I want you to remember that in this particular disorder, there would be two things. One is neuro, second is cutaneous. So let's quickly remember the cutaneous manifestations. The cutaneous manifestation that would be encountered would be by the name of ash leaf macules. Well, these are hypopigmented macules that could be seen in the trunk of this individual, and the importance of studying this would be that if a father is having it, son would be having it. Since the pattern of inheritance of disease is autosomal dominant, so father and son both are epileptic, right? Father and son both are epileptic and both are having similar cutaneous manifestations. On the skin of this person, you would be having a manifestation that is called as Sjagren's patch. If you run your finger on the Sjagren's patch, it would be having a classical what we call as orange peel consistency. The orange peel consistency, normally we read about Peau d'orange, right? In carcinoma breast, I'm talking about orange peel consistency over the skin that is called as Sjagren's patch. Then is a very classical manifestation which would be seen in a butterfly distribution over the nose of this particular individual. In fact, this was an image-based question in the exam. He said father is epileptic, son is epileptic, and both are having identical manifestations on the skin, on the face, that is adenoma sebaceum in a butterfly distribution. When you read this information that there is adenoma sebaceum in a butterfly distribution, then this is obviously a very important cutaneous parameter that is to be remembered for tuberous sclerosis. Then in these patients, in the foot of the patient, if you look at the nail per se, if I can just redraw this before you, like suppose the big toe is given, you will notice the big toe might look cracked and broken like a fungal infection, and then there is a tumorous mass originating from below the nail. This tumorous mass that is originating below the nail is called as Koinen tumor. This Koinen tumor is also technically called as subungual fibroma. This would be originating from below the nail of the patient. All these are cutaneous manifestations that would be developing in this patient, with one of the earliest cutaneous manifestation to develop in tuberous sclerosis is ash leaf macules. In these patients, now we will talk about neurological manifestations. The neurological manifestations would be starting right from the first year of life, which explains the fact that these patients, when they grow up, they would be mentally retarded, because we are talking about epilepsy, recurrent seizures right from the time when the child is born. So infantile spasms would be a presentation. I have taught you the fact that for infantile spasms we use primarily ACTH, but in this case we will be using vigabatrin for the patient. Apart from the infantile spasm part, the same patient when he is a little older, that is after 1 year of age, focal seizures would be present in this patient. Carbamazepine would be the drug, and the treatment in this condition will continue lifelong. Since in these patients we are having a neurodegeneration, in case we do a MRI head in these patients or a CT head in the patient, a peculiar finding can be anticipated. If this is the representation of the lateral ventricle, symbolically the third ventricle, that may or may not be seen in all sections, you will notice that in this condition, the appearance will be like that of small potatoes, because tuber means potato. It's like a potato growing in the brain. This would again be a periventricular lesion that would be developing in a patient, and they have in fact asked that what is the lesion present in this. So this would be called as subependymal. Why? Because the lining here is called as ependymal lining. So this would be called as subependymal astrocytoma. This is the one which is responsible for the manifestations in the patient. Subependymal astrocytoma is the manifestation that would be developing in these patients significantly. Remember the fact that we have discussed multiple periventricular lesions today, so we can have a quick recap of that. If they give you periventricular lesions which are in the form of fingers, then these periventricular lesions which are in the form of fingers are called as Dawson fingers, would be a feature of multiple sclerosis. Another could be a hypomyelinating syndrome or a leukodystrophy. Leuko means white, dystrophy, malformation, hypomyelination. That would be starting from the periphery and coming towards inside. That is, periventricular lesions are having a presence of hypomyelination, which is radiating from outside to inside, lateral to medially. That is the tigroid appearance I'm talking about. That would be Pelizaeus-Merzbacher syndrome or Pelizaeus-Merzbacher disease. And just now I taught you subependymal astrocytomas, SEA. These would be found in patients having tuberous sclerosis. So I'll just mention the names so that this becomes a permanent memory for you. Multiple sclerosis, tuberous sclerosis, right? Overlapping terms, so please be clear. And this would be, okay, I'll write it for the completion's sake. That is Pelizaeus-Merzbacher disease. These are a couple of periventricular lesions that I have tried to explain to you, and also you need to remember regarding the cortical involvement of neurocysticercosis. Obviously, one of another important neurocutaneous disorder that has now been brought to your notice is by the name of Sturge-Weber syndrome. In this particular patient, the CT head of the patient is showing what is called as a tram track appearance. Traditionally, we read about tram track appearance on a CT chest in bronchiectasis, but tram track appearance on a MRI head or a CT head, this is definitely a feature that is seen with Sturge-Weber. It may also be called as railroad calcification. In these patients, you will also be having a presence of a cutaneous manifestation, which is by the name of Port-Weinstein. The combination of the two, that is a cutaneous manifestation on the face and a neurological manifestation of a cavernous angioma, which results in a tram track appearance, is called as Sturge-Weber. Okay, let's quickly remember and revise manifestations of Sturge-Weber. What are the important parameters to be remembered? Alphabet S would stand for seizures developing in these patients. These would obviously be focal seizures, and the reason for these focal seizures is based on the fact that this condition would be having a cavernous angioma. This cavernous angioma might subsequently be having a visible calcification that can be seen on a CT head or even a MRI, obviously. T would stand for in the trigeminal nerve distribution of this particular chap. You can see a vascular malformation coming up. The vascular malformation that is present here is the one that is called as a Port-Weinstein. Then U would stand for obviously unilateral weakness in this patient, because the cavernous angioma will contribute to pressure on the corticospinal pathway. So contralateral weakness would develop in the patient. R would stand for mental retardation. Why? Because there is gonna be a malformation in the brain that will trigger recurrent episodes of seizures. So recurrent episodes of focal seizures could be present in the patient. In fact, I can say that, in your OPDs, you would have seen patients who are having a vascular malformations and are epileptic, with one side of the face having vascular malformation, same side most of the time the malformation of the brain is also present. So mental retardation. G would stand for ophthalmic complication of this patient, that is glaucoma, and if this condition is present since birth, then it would be a eye manifestation that could be written in MCQs as buphthalmos in the patient. So these are manifestations of Sturge-Weber syndrome, and this is also a neurocutaneous disorder. It's also called as phacomatosis, which could result in combination of skin and neurological features. Let me just make you revise the term that I said here. The term I said here was phacomatosis. In fact, when you read the term phacomatosis, first time it looks like you are reading something related to opthal, because in ophthalmology you read about aphakia or pseudophakia, and now you're reading phacomatosis. One of the phacomatosis is neurofibromatosis 1 and 2, which is again an autosomal dominant disorder. Neurofibromatosis 1 is important one from the exam perspective because of its association with pheochromocytoma, which would be characterized by PHD, that is palpitations, headache, and diaphoresis. Headache obviously because of the hypertension component. Neurofibromatosis 1 is also important because today we are talking about a neurological manifestation of this one, that is optic glioma. For neurofibromatosis 2, the tumor that is associated is acoustic neuroma. Other manifestations in this particular disease are very characteristic. That would be cafe-au-lait macules. Cafe-au-lait macules would be like when you pour, I would say, milk into black coffee. You go to barista, you order a jet black coffee, pour milk into it. The brownish color that comes is cafe-au-lait macules, and there should be at least 5 cafe-au-lait macules to be present to consider the diagnosis of neurofibromatosis in the patient. Then there would be axillary freckling. Then in these patients, there could be a very peculiar manifestation that could be written in the form of pulsating proptosis. Why there is a pulsating proptosis, you can go to the original lecture of epilepsy where I've tried to give an explanation for this. But at the moment, I'm just going to say sphenoid bone is very thin. So therefore, the pulsations of the carotid artery will be transmitted to the eyeball. And when you put your hand on the eyeball of the patient, you can feel the pulsations of the carotid artery, which normally normal person would not be there. So neurofibromatosis 1 is asked because one, there is a skin manifestation in the patient, and then there is a neurological manifestation in the form of optic glioma. The next one to be remembered is tuberous sclerosis, which is having ash leaf macules and other allied aspects. Then is Sturge-Weber, which would be having a railroad or a tram track calcification, having a port wine stain. Another one to be remembered is ataxia telangiectasia. This is to be remembered because of very characteristic manifestation that when you look at the white of the eye of this individual, I mean, like while you're watching this video, you can obviously appreciate my eye, but you cannot see the blood vessels in the white of my eye. But in this chap, you will be noticing these fairly big dilated blood vessels in the white of the eye of the patient. That would be referred as telangiectasia. And the ataxia component in this patient is due to damage to the spinocerebellar pathways, which results in development of ataxia in the patient. So combination of these two is called as ataxia telangiectasia, and this condition is also associated with deficiency of immunoglobulin A. So these patients would also be having recurrent infections. Diseases of excess of immunoglobulin A, you all know, are Henoch-Schönlein purpura and Burgess disease. And disease of IgA deficiency that I've just highlighted before you is ataxia telangiectasia. The next one to be remembered is von Hippel-Lindau syndrome. VHL von Hippel-Lindau syndrome is asked because of one, the fact that this would be VHL gene on chromosome 3, which is associated with renal cell carcinoma, that is clear cell cancer. But from the neurological perspective, I want you to remember for these patients a very characteristic feature that is by the name of cerebellar hemangioblastoma. Now, why are you being made to remember cerebellar hemangioblastoma is because in cerebellar hemangioblastoma, the tumor which is present is not originating from the cells of the cerebellum. The tumor is originating from the blood vessels which are present. So this actually is a tumor of the pericytes. Pericytes are the cells of the capillaries, cells lining the capillaries. So cerebellar hemangioblastoma and retinal hemangioblastoma that you read here is not originating from the cells of the retina. There are 10 layers of the retina. There are various cells in the cerebellum. You have Golgi cells, basket cell, Purkinje cells, granular cells. You don't have tumor of the Purkinje cell per se, or of the Golgi cell or cerebellar cell. A tumor of the capillaries of the cerebellum is why this is asked. Cerebellar hemangioblastoma is found in, retinal hemangioblastoma is found on, and even spinal cord hemangioblastoma. In fact, remember, vascular tumor of the spinal cord. Vascular tumor of the spinal cord is spinal hemangioblastoma. Overall, if he says what is the most common tumor of the spinal cord, the overall most common tumor of the spinal cord can be remembered as metastasis. Spine tumor to be remembered overall is METs. Where would these METs come from? Then one would be breast cancer, and another one can be lung cancer, and then can be prostate cancer. So these are three cancers that can cause metastasis to the spine. Primary tumor of the spinal cord is obviously glioma. Benign tumor of the spinal cord will obviously be meningioma. If he says vascular tumor of the spinal cord, then I told you a spinal cord hemangioblastoma, which could be an association for VHL. So this slide is dedicated to a very peculiar name, that is phacomatosis, which is a neurocutaneous disorder. And these are a couple of phacomatosis that I would like you to revise for today. Moving ahead, we will now talk about some aspects of the peripheral nervous system, where we will talk about muscular involvement due to either a myopathy or of a neuropathy. You see, neuropathies will usually result in muscle wasting. Even myopathies will cause muscle wasting, but we usually have a pseudo appearance of big muscles. First, if you look at the image for the right hand side, this particular individual is having contractures in the feet, which tells me the fact that probably nerves are involved. Why? Because contractures are seen when there is wasting of muscles. You can notice very thin and spindly legs of this particular patient. There is wasting of the leg muscles of this individual. This wasting of the leg muscles of this individual is also technically represented as stork leg appearance. This would be called as stork leg appearance. When it comes to stork leg appearance, this is a feature that is encountered in CMT, that is Charcot-Marie Tooth disease. This is a peripheral neuropathy. It is a congenital neuropathy. Normally we study regarding presence of neuropathies which are acquired like in diabetes mellitus or porphyria or hepatic encephalopathy or toxins, but congenital neuropathy, CMT, it is also called as Charcot-Marie Tooth disease, is also called as HSMN, that is hereditary sensory motor neuropathy. The characteristic feature of this particular disease would be stork leg appearance, contractures, and obviously difficulty in mobilization of the patient. Most of these patients will have recurrent falls and difficulty in walking. In this condition, if you do a nerve biopsy, the nerve biopsy of this patient will reveal a classical finding of onion skinning. Normally, onion skinning is read by us in pathology in, let me say, malignant hypertension, or you read onion skinning of bile ducts in primary sclerosing cholangitis, but onion skinning appearance for nerves is gonna be Charcot-Marie Tooth disease, and difficulty in mobility would be seen. On the left hand side, I'm describing a patient who will become wheelchair bound very soon. Most children by 10 to 12 years of age will start having requirement of wheelchair, and before 10 years of age, most of the time the child will be having requirement for braces. The child will not be able to stand because there is a weakness of the hip joint muscles. The disease that I'm describing here is very classical. You can see the pseudo hypertrophy of the calf muscles of the patient. The calf muscles of this patient looks like calf muscles of, let me say, a tennis player or a football player. Normally people who are into sports, they would be having these hypertrophied muscles, but if you touch this muscle, it's going to be flabby. There's no muscle, it's fat deposition with respect to muscles of the patient. So pseudo hypertrophy of the calf muscles. Pseudo hypertrophy of the calf muscles is a feature that is encountered in these patients with respect to Duchene's muscular dystrophy or DMD. The pattern of inheritance of this is X-linked recessive. So obviously boys will be suffering from the disease and girls would be carrier for this particular disorder. The highlight of this disease would be at 4 to 5 years of age, the child will be having a very peculiar gait that is called as waddling gait, and there would be a classical Gower sign. Now Gower sign is a piece of cake for you. I mean, had I started this by Gower sign, you would have said, sir, we know that, what's the big deal? But I wanted to remember that the mobilization of these patients is affected. Our related MCQ to be remembered is, if you read about Gower sign in a 25-year-old lady, then it cannot be Duchene's, because Duchene's is seen in boys and 25 is not the age of presentation of Duchene's. So if you read a question that says a lady at 25 is having a Gower sign, then you have to remember a connective tissue disorder which is by the name of dermatomyositis, which would be causing a development of weakness of the hip joint muscles, causing difficulty in climbing stairs, and the patient literally climbing on his own body while trying to get up. The two disorders which are causing difficulty in mobilization in this case are Duchene's muscular dystrophy and Becker's muscular dystrophy. Charcot-Marie is a neuropathy, and Becker's and Duchene's are obviously the muscle disorders. The protein which is defective in Becker's muscular dystrophy is to be remembered as dystrophin. This is a sarcolemmal protein which is deficient, so the calcium entry in the muscles is lesser, and therefore there is a definitive muscle weakness that would be manifested. The only difference is that in Becker's muscular dystrophy, the age of presentation is 10 years. In patients having Duchene's, they will require braces by 10 years and then will become wheelchair bound. Here presentation is at 10 years. The same patient by 25 years of age will become, I would say, wheelchair bound, and by 40 years of age, possible death in the patient will occur due to immobilization. If they always talk about death in neurological diseases due to immobilization, if like Alzheimer can make a patient immobilized, not because I would say that he is having some problems with mobility. Alzheimer is he doesn't realize that he has to get up and go to washroom. He's lying in the bed and urinating. So like our former Prime Minister Atal Bihari Vajpayee, he had Alzheimer's disease. Unfortunately, he died because of pneumonia. Muhammad Ali had Parkinsonism. He died because of pneumonia. So if there is death given in a question with respect to these neurological disorders that cause immobilization, then one of the important causes of death in these patients is development of lung infections. Moving ahead, we'll discuss some questions which have been asked recently so that we can get an orientation about especially the aspects that we have studied. Like for this one, the question mentioned regarding a diabetic patient and a hypertensive patient who was found unconscious in the morning. His heart rate is 120, BP is 160 by 100. So this tells me I don't need to go in for a CPR, or rather, I mean, there is no need for any cardiopulmonary resuscitation in the patient. Now, since patient is having neurological finding of bilateral extensors, he says, what is the next thing to be done? If this question was not mentioning a diabetic and a hypertensive patient, and he said, what will I do? I will think that he's probably had a stroke because there is at least bilateral extensors. I'll do a CT scan. But because he's mentioning a diabetic patient, so metabolic problems should obviously be ruled out first. So I will be checking blood sugar of the patient initially. If the blood sugar is lesser, I'll give him 50% dextrose. If it is elevated with ketones present, it is ketoacidosis. There could be lactic acidosis in a patient. There could be non-ketotic hyperosmolar coma in a patient. So three possibilities have to be kept when you're checking blood glucose of this patient. One is the standard hypoglycemia component. But some of these patients, if they're having elevated sugar, then two possibilities are further to be considered: ketoacidosis and non-ketotic hyperosmolar coma. And if these are ruled out in the patient, then obviously I'll be doing a CT scan in this individual. So the same question, if was given without diabetes, then obviously no issues. I would have taken care of a CT scan right away. If he mentioned only hypertension, I would have definitely like to check the BP of this guy, because he could be in hypertensive encephalopathy. In the next one, he says a guy with RTA presence in the casualty. He was moaning with inability to speak, but was able to understand what he wanted to speak. That is, he can at least understand what you are saying. He says which part of the brain is involved in this particular area or in this particular case. So the basic point is that the patient is having damage to the Broca's area. The damage to the Broca's area, which is in the frontal lobe of the patient, would result in this patient having inability to speak. So the main feature of this guy is motor aphasia. We are having a Wernicke's area, which is related to understanding. Wernicke's area is responsible for comprehension. So comprehension is normal in the patient, understanding is normal in the patient, but inability to speak is present. So the area in the inferior frontal gyrus, that is the Broca's area, is smashed in this guy. Area number A is the one that is related to gaze. That is gaze maintenance is with respect to the visual center, which is present in the frontal lobe of the brain. But for the question that is put up here, the answer would be given as choice number beta. Then we look at a 60-year-old female with left-sided weakness, which is present for more than 1 hour, and there's a left-sided facial weakness with blood pressure of 160/100 in the patient. He says CT scan is normal. What would you do? One thing is very clear: this patient is having a focal neurological deficit. It has been persisting for more than 1 hour. The patient is obviously a hypertensive patient. CT scan is normal in the patient. The diagnosis of the patient is not a TIA. It is acute ischemic stroke in a patient. Usually in TIA, the symptoms of the patient will tend to reduce over the first hour. But in this case, the symptoms have been persistent and CT scan is normal. We have ruled out the possibility of this guy having a hemorrhagic stroke. So we would be straight away starting thrombolysis in this particular patient. Give a loading dose of aspirin and clopidogrel here. The point is, guys, when you have to treat a guy with stroke, first thing to be done is start the patient on retaplase, that is RTPA, and after 24 hours then you will start the patient on aspirin. This is to prevent the redevelopment of stroke in a patient. Now this is slightly different from that first MI, because in a ST elevation MI we first give aspirin chewable to the patient, then we do thrombolysis, but in stroke cases the window period is very limited. So he says that straight away go in for thrombolysis in this particular case and then start aspirin in the patient. I would like to highlight the fact that CT scan is usually gonna identify ischemic stroke pretty late, and we are not gonna wait for the CT findings to appear, and that is the reason why most hospitals nowadays are investing into a diffusion weighted MRI in the patient. Once we have done these questions, then we'll revise some aspects of headache. Though I've taught you migraine earlier, now we will focus on the aspects of cluster headache and compare it with a short-lasting unilateral neurologiform headache with conjunctival injection and tearing, longish name, sunset, and then paroxysmal hemicrania, where the number of episodes per day would help you know what is the cause of headache in the patient. So let's go ahead with this trigeminal autonomic cephalgias. First and the foremost, I would like to remind you the fact that migraine can be easily picked up with what I discussed in the earlier part today, that is POUND. Pulsating headache, one-day illness, unilateral nausea, disabling character, 4 out of 5 to be present, and at least 5 attacks per year is sufficient for clinical diagnosis of migraine in a patient. In migraine, the patient will usually be having, in some cases, obviously a presence of an aura, which may or may not be there. That's one thing that's very sure. And then when it comes to migraine in a patient, I want you guys to remember the fact that patients of migraine, they will be having like attacks which are recurrent in nature, and these attacks can be triggered by like lack of breakfast, standing in the sunlight, picking up heavy duty weight, like person had to shift hostel room, so patient had to do a lot of physical activity which a normal person is not accustomed to, so therefore headache aspect could develop in a patient. But migraine will always be having a unilateral headache, and most patients will like describe like whole of the half of the head. Some patients might put their hand in the back also to say a bit of neck stiffness present, not exactly a nuchal rigidity, but he'll say I feel heaviness in my neck muscles, and the attack will definitely respond to painkillers and to sumatriptan. Now today evening, let me say I have a patient who has come to my OPD and is making a lot of noise while I was attending to a patient. So I went outside, I said, who's this guy creating a ruckus? And I found a young male, and he was keeping his one hand on his eye and he was saying, I want to see the doctor right now. So I asked him, man, what's the rush? And this guy, when he removed his hand, I noticed that he was in distress. Obviously, he was saying, the doctor, I feel as if somebody is drilling a hole in my eye with a drill machine, and the pain might be going to the temple in this particular individual patient also. So stabbing and boring pain, like somebody drilling a hole in the eye, is the usual description for these patients. And I told him, can't you be patient? He says, no doctor, the pain is very terrible, I just can't tolerate it. And in these patients, when you take the history, you will notice the fact that in these patients the duration of pain will be something in the range of 15 minutes to 180 minutes, that is up to 3 hours the duration of episode can occur. Why do you call cluster headache as cluster headache? Is because they could be multiple episodes per day. It could be starting from something as simple as one episode every alternate day to up to 8 attacks per day. So he says, I wake up in morning, stabbing pain for 2 hours, goes away with medication, again a stabbing pain, and he says, doc, I am ready for enucleation. I mean, look at the words of the patient. He says, doc, I'm ready for enucleation, take out my eyeball, but I just can't stand the pain present in this guy. Please remember that when it comes to migraine in a patient, in migraine the duration of pain is something in the range of at least minimum 4 hours, goes up to 24 hours in a patient. If a migraine attack lasts for more than 72 hours, if an attack of migraine will last for more than 72 hours, then we call it status migrainosus, which is actually a psychotic state for which you don't need to give a painkiller, but you would be starting the patient on prochlorperazine. So one, I want you to remember the fact that status migrainosus would be duration of pain more than 72 hours. It's a psychotic state perceived by the patient. And then when it comes to cluster headache in a patient, the duration of pain is about 3 hours. It's gonna be multiple attacks per day, in contrast to a single attack in case of migraine. Migraine, you see, most patients, they'll say, I take a painkiller and sleep. When I wake up, I'm fresh, I can do my job, and then the attack comes again. Here it's like morning, afternoon, evening. If you ask a patient of cluster headache to maintain a pain diary, you will notice multiple episodes of headache appearing in this particular patient, and autonomic features could be present in the patient in the form of bulbar congestion. So redness in the eyes can definitely be noticed. Tearing from the eyes could also be present in the patient. And for this guy, the first line management is oxygen inhalation. We give oxygen at a rate of 12 liters per minute for these patients. How oxygen works is an enigma to medical science, but remember, like in normal hospital cases, no, we give oxygen at a rate of 6 liters per minute. You are giving oxygen at a rate of 12 liters per minute for this guy, and the DOC for this guy is obviously gonna be sumatriptan, and you can prevent this by using molecules like verapamil, lithium, because sometimes psychotic features will occur. He might try to, take a pointed object, hurt his eye. I mean, I'm saying a big thing, right, guys? Somebody trying to hurt his eye with a pen. He says pressure in the eye. He non-medical, right? He says pressure in the eye is more. It's hurting. I feel like poking it, and then I think I will be okay. Short-term prevention is steroids in this particular case. Now listen to my next words very carefully. In case I'm getting a case where I'm getting pain episodes, which are obviously periorbital pain, and the episodes are, look at the huge number of attacks per day, 20 attacks per day, and the attack duration is for seconds. Then the diagnosis of the patient would be given as SUNCT, that is a short lasting, I'll just mention it here. This would be a short-lasting unilateral neurology form headache. Okay, sometimes the terms are real bothersome. With conjunctival injection and tearing. There would be obviously a redness of the eye even in this case, and tearing present. What I want you to remember from the exam perspective is that if he's gonna give you something like, let me say, attacks per day in less than double digits, like 8 attacks per day, and there is presence of this deep-seated retroorbital pain, I'll think in terms of cluster headache. But if the attacks are going into double digits, maybe going up to triple digits, like 200 attacks per day, I mean, looks like you are kidding me, right? I mean, when you read that, the textbook says 200 attacks a day. I mean, look at the terrible situation this chap would be in, and the duration of attack is only for seconds. That is, then it is sunset, and for this case, we have to give lidocaine intravenously. Traditionally, we study lidocaine for post-MI ventricular tachycardia. We study lidocaine traditionally for post-MI VT, and today I'm teaching you lidocaine for management of sunset. And then is a term that is called as paroxysmal hemicrania, where there would be throbbing pain. Now, throbbing pain is a feature of migraine also, so there's a lot of overlap between migraine and paroxysmal hemicrania, and the treatment for this is again to give painkillers to the patient. This, I would say, is something which is very difficult to differentiate from migraine from clinical domain, in a sense that migraine will obviously have one attack. Here there would be multiple attacks per day. The duration will obviously be shorter. I mean, duration wise you can differentiate, no doubt about it, but most of the time physicians would be more comfortable writing the word migraine on the case file rather than writing the word paroxysmal hemicrania. I mean, you would have rarely seen this term written, but for the remaining two, yes, cluster headache and SUNCT should be remembered. And I want you guys to remember the fact that the pain can go to the temple in both cluster headache and paroxysmal hemicrania. So if you read a question on a temporal headache and it is mentioning regarding a geriatric population patient who's like 70 years of age, then you obviously have to think in terms of giant cell arteritis. But if you're reading about a young person with multiple attacks per day, the attacks could be something like over a couple of minutes, or it could be obviously sometimes going over, I would say, as long as 3 hours sometimes. Then there are two possibilities which are to be considered in the multiple choice question. One to be considered is what I said right initially, cluster headache, and second is paroxysmal hemicrania in a patient. So for the question of temporal headache, I've just opened up the options for you. Why I'm saying that is because the NEET exam, they mentioned regarding temporal headache in a patient, and it was a young person, not a old person. In those circumstances, it is not a giant cell arteritis. Plus, in giant cell arteritis, there has to be pointers which I'll discuss subsequently also, like ESR should be very high. There should be a cord-like structure palpable at the TM joint of the patient. So if you don't get presentation of grossly elevated ESR, you don't have a cord-like structure at the TM joint, no history of jaw claudication, no visual deficit present in a patient, then you have to take into consideration the presence of pain with respect to cluster headache and paroxysmal hemicrania for the patient, where the duration of pain episodes will vary. I highlight once again, if in an exam he's highlighting pain in the eye and duration of episodes is something like 20 and duration is in seconds, then you have to answer in terms of SUNCT, sunset. But if it is going to be in minutes, then either of the two can be answered. Primary answer I would suggest you to answer is cluster headache. First line management for cluster headache, high flow oxygen, and then to start the patient on management with sumatriptan, which is the preferred molecule. Obviously this is migraine variant only, and for prevention it is verapamil and lithium, whereas for migraine the prophylaxis is propranolol. So these are a couple of aspects for headache that I've tried to highlight, and I've deliberately divided the discussion because initially we think in terms of migraine only, but when it comes to these aspects, then they also have to be kept in mind. Okay, coming to the next slide, guys, we will be revising aspects related to the cranial nerves, and one of the aspects related to cranial nerves that we have to study is called as Melkerson-Rosenthal syndrome. Now, as you can see, this would be having a very characteristic manifestation of seventh nerve palsy in a patient. Patient could be having a bilateral seventh nerve palsy or a unilateral seventh nerve palsy as well. Both could be present in a patient. In fact, one of the highlights of this disease is when you're asking the patient to close the eye. Like in this case, you can see that on one side she is able to close her eye normally, but on the contralateral side, when she is closing her eye, you can definitely notice that the black of the eye is rolling upwards. You can see that this image is showing a very characteristic feature that is called as Bell sign, and Bell sign is obviously a feature of Bell's palsy. What is Bell sign? It is uprolling of the eyeball on forcible closure of the eye. So this particular characteristic feature would help you identify seventh nerve palsy in the patient. I repeat my statement: forcible closure of the eye. You asking the patient, close your eye, and person will be trying, and they would be up-rolling the eyeball of the patient. Then another feature that you can notice is swelling of the lips of the patient. You can also notice a slight asymmetry of the face, which is very obvious with respect to the lips being deviated to one side. And then the third feature of this patient would be the appearance of the tongue of the patient, which will be showing a fissured tongue, and this is referred as lingua plicata. So there are three features that I want you to remember for this particular idiopathic neurological disorder, which is one characterized by swelling of the lips. There is a facial paralysis, which can be unilateral or can be bilateral, and there would be a fissured tongue present in this patient. The condition is called as Melkerson-Rosenthal and is related to seventh nerve palsy in a patient. Coming to the next image related to the cranial nerve palsy, you will notice that the uvula of the patient is not central, but the uvula is deviated to one side, and you will also notice that there is inability to lower the palatal arches on one side. If you compare on one side, that is where I'm putting the star mark, this is the normal side of the patient. Why I'm saying normal? Because the palatal arch is definitely lowered as compared to the contralateral one, and there is a deviation of the uvula to the normal side. So the diagnosis of this image would be given as a vagus nerve palsy. Usually a high vagal nerve lesion results in a profile like this. There is a uvula deviation. Traditionally, you read in ENT uvula deviation with quinsy or with paratonsillar abscess, but in this case, the tonsils look pretty decent. As you can see, the light reflecting on the tonsils from the back. There is no purulent discharge seen on the surface of the tonsils, and they're not even enlarged. So this is definitely a neurological case. This is left side and this is right side. So there is a uvula deviation occurring to the normal side, that is to the left side in the patient. Also in this case, there is a development of inability to lower the palatal arches on the affected side in the patient. So the diagnosis is pretty clear. Whenever there is a vagus nerve involvement in a patient, there can also be symptoms in the form of palpitations, and in fact even the gag reflex can be affected in the patient. So there could be aspiration pneumonia developing in a patient. Coming to this particular slide, you will notice the fact that there is a facial deviation of the patient, because this would be the normal side of the patient and this is the side on which there is a muscle weakness. There is a hypotonia in the patient. So I have just once again shown the slide to you to highlight the fact that facial deviation to normal side is a feature of seventh nerve palsy. Like if this is the left and this is the right side of the patient, so this particular patient is having a right seventh nerve palsy, which could be related to Ramsay Hunt, or it could be related to reactivation of herpes zoster in a patient. One of the special features for cranial nerves that I definitely want you to remember is the rule of 4. The rule of the 4 states the fact that there are 4 cranial nerves nuclei in the medulla, 4 in the pons and 4 above the pons of the patient. So let's just look at which are the nuclei above the pons. That is 1, 2, 3, 4. That is optic nerve, olfactory nerve, then the oculomotor and the trochlear nerve. These are the 4 cranial nerves that would be located above the pons in the patient. Whereas when it comes to 5, 6, 7 and 8, because I would say that it is at the pontomedullary junction, so we can call it in the pons. And then below the pons of the patient, the cranial nerves would be 9, 10, 11 and 12. So a rule of 4 will basically divide the cranial nerve positions as follows. Then you have to remember that the cranial nerves which are gonna be numbered 3, 4, 6 and 12, I mean these are numbers that can divide 12 number. I mean mathematically, if you look at 12, then 3 is a multiple of 12, 4 is a multiple of 12, 6 and 12, they are all multiples of 12. So all the cranial nerve nuclei which can divide number 12, they are medially located. 12th nerve nucleus is medially located. 6th nerve nucleus is medially located, 4th nerve nucleus and 3rd nerve nucleus are medially located, and the remaining are laterally located. Then is a very interesting finding which you can see here, that in the brainstem of the patient, motor nerve nucleus is obviously medially located. That would be the numbers that I mentioned before you, that is 3, 4, 6 and 12. I'll just write the numbers there. And then there is a motor pathway, that is the corticospinal pathway. And the corticospinal pathway will always cross over to the contralateral side. Now, because the corticospinal pathway will cross over to the contralateral side in the patient, therefore, cross over to the contralateral side. Therefore, the implications for you to remember is that if there's a lesion occurring in the patient with respect to these cranial nuclei, there would be contralateral hemiplegia. Like for example, if you listen to the routine lectures, I've talked about Weber syndrome, which is characterized by third nerve palsy, and there is a contralateral hemiplegia in the patient. So you can see from the anatomical arrangement here, why do you get a crossed manifestation in the patient? Crossed manifestations are always involving are features of brainstem stroke, that is crossed hemiplegia. Similarly, when it comes to Millard-Gubler, then sixth is obviously involved. Foville syndrome also sixth is involved. So again, in patients of Millard-Gubler syndrome, you would be having sixth, though seventh is also involved, but the basic point is sixth is medially located and there is a contralateral hemiplegia in the patient. The blood vessel involved in Weber syndrome is P1 part of PCA. In Millard-Gubler, it is the basilar artery, and then is medial medullary syndrome. In medial medullary syndrome, it would be 12th nerve nucleus that is involved, along with contralateral hemiplegia. The blood vessel that supplies the medial part of the medulla is anterior spinal artery. The involvement of this results in development of ipsilateral 12th nerve palsy with a contralateral hemiplegia in the patient. The next thing to be remembered is a medial structure by the name of medial longitudinal fasciculus. The involvement of this can contribute to gaze palsy in a patient. So you will notice that people with brainstem stroke, they usually look away from the lesion, and people who are having cortical stroke, they will usually look towards the side of the stroke. This is a basic dictum of medical science that you have to remember, that patient looks towards the side of the lesion in cortical stroke and looks away from the side of the lesion if it is a brainstem stroke in a patient, and involvement of the MLF involves this. Medial lemniscus can explain the sensory involvements of the patient. And now let's look at the lateral structures. The lateral structures are sympathetic pathway. Involvement of this can cause Horner syndrome, like I have described that in lateral medullary syndrome, that there can be Horner syndrome. Spinothalamic pathway will be causing or it is responsible for transporting pain and temperature. So involvement of this would cause loss of pain and temperature on the contralateral side because it would anyway cross over. The basic points are even spinocerebellar pathway is laterally located, so involvement of that will cause ataxia. So neurological features of lateral part of the brainstem syndrome can be easily understood from the structures that begin with alphabet S, and the structures that are medially located are having alphabet M: motor nucleus, motor pathway, medial longitudinal fasciculus, medial lemniscus. These are all medially located structures, and laterally would be sympathetic pathways, spinocerebellar pathways, spinothalamic pathways. So we can try and understand and remember the features of lateral brainstem versus medial brainstem involvement in a particular patient. The most important point to be remembered here is that the cranial nerve nuclei, which are gonna be dividable nerve mathematical numbers 3, 4, 6, 12, they are multiples of 12. I mean 3 4s are 12, 4 3s are 12, like that. So these are medially located and the remaining nuclei would be laterally located, and this is technically called as rule of 4, or even if you don't remember the rule of 4, the basic point is this arrangement would help you remember aspects related to stroke which have been discussed in routine literature. Then a point worth noting here is, I'll explain that slightly in detail. You see, Weber syndrome is presence of third nerve palsy with hemiplegia. Why? Because there is a involvement of the corticospinal pathway. Whereas when you study regarding Nonthangel syndrome, you see spelling might be different in different books. So some people point out, sir, the spelling that you are using is different from what's on the internet. I agree, you know, amoxicillin is AMOXY and AMOXI also. So small variations can be there. Then could be Nonthangel, which is third nerve palsy with a contralateral ataxia. The reason for the contralateral ataxia would be damage to the spinocerebellar pathways. Then can be Benedict syndrome. Benedict begins with B. In this case, basal ganglia are involved. So it would be third nerve palsy with a chorea in a patient, ethiotosis in a patient, because basal ganglia are getting involved in the patient. Now, if you have a combination of the two, Non-Thangel plus Benedict, we are going to call it Claude syndrome. In this, you will be having third with contralateral ataxia. Everything is contralateral only till I mention it. So there would be a contralateral ataxia also given in the question, and chorea also. So if you get such a surprising question where there's a third nerve palsy with both features of cerebellar disease, and along with cerebellar disease also manifestations of basal ganglia involvement, then you will call it Claude syndrome in a patient. These are features of midbrain stroke in a patient. Then is Millard-Gubler, which would be characterized by involvement of 6+7 and a hemiplegia. That is also called as alternating hemiplegia, because face of one side and body of the contralateral side would be paralyzed. Seventh nerve is motor to the face, so facial paralysis of one side, and body of the opposite side would be involved in the patient. So I'm just gonna put a cross like this one to symbolically show the involvement in this patient of the face and the opposite side of the body versus non-involved part of the face. So this is referred as alternating hemiplegia. Very classical term. Alternating hemiplegia is a feature of Millard-Gubler syndrome. Then to be remembered is lateral medullary syndrome, which is also called as Wallenberg syndrome. In Wallenberg syndrome, there is no hemiplegia. The nerves involved are 5, 7, 8, 9, 10. These are the usual nerves that would be involved in the patient, and 11th, but 12th is not involved. 12th involvement is seen in medial medullary syndrome in a patient. When it comes to medial medullary syndrome in a patient, it would be 12th nerve palsy in the patient with a presence of a contralateral hemiplegia. This is a quick revision of the various brainstem strokes that I have taught you. The blood vessels involved are P1 PCA, basilar artery. For Wallenberg syndrome, it is pica, and for medial medullary is anterior spinal artery. The topic that we have done a quick revision and some aspects of cranial nerves that we have studied is brainstem stroke. A very peculiar lesion of the 7th that I've taught you is also Melkerson-Rosenthal, which could be having this fissured tongue, lingua plicaita, with presence of lip swelling, which would be idiopathic. In the next image that I'm showing to you, I have shown you an image grab of a person whom I've asked to grab my fingers, and I'm noticing a paroxysmal contraction of the muscles of the patient and then a slow relaxation. This paroxysmal contraction, this sudden fast contraction of the muscles, followed by development of a relatively slow relaxation, is what is called as myotonia and is not to be confused with myoclonus. Remember that myoclonus would be a shock-like. It's a sudden shock-like jerky movement that could be involving few muscle groups in the patient. To explain myoclonus, I can say that if you are feeling very sleepy, there's a possibility that, like face value, you're very sleepy, you're trying to sleep, and suddenly you might get an impression as if you might fall. That sudden sensation that you might get when you were trying to sleep and it looks as if your leg had jerked involuntarily is called as hypnagogic hallucinations. So myoclonus can be appreciated even in a normal individual when he is sleepy, and there might be an impression as if he tries to fall, so the leg might jerk involuntarily. Hypnagogic hallucination. Hypnagogy means at the onset of sleep. Myoclonus is always abnormal. There can also be a term by the name of negative myoclonus, which means that some muscle groups may not fire at the time it is desired, and therefore this negative myoclonus might result in a flapping tremor in the patient. And flapping tremor, like an hepatic encephalopathy, asks the patient to outstretch his hand, dorsiflex the hand, let it go, and because of decrease in the tone of the muscle, suddenly there might be a flap. So hepatic flap or negative myoclonus is asterixis, which can be seen in metabolic encephalopathy. Then myoclonus can be seen in various diseases like West syndrome, that is before 1 year of age, Subacute sclerosing panencephalitis at usually 8 years of age, which is a neurodegenerative complication of measles. Then can be invariant Creutzfeldt-Jakob disease at adult age group and juvenile myoclonic epilepsy at 10 to 19 years of age. These are the usual ages of presentation of myoclonus in various medical disorders. It is a shock-like jerky movement which is to be differentiated from myotonia. Now, what are the diseases where you read myotonia? So, one is obviously a disease by the name of myotonic dystrophy, which is a congenital disorder. One of the highlights of myotonic dystrophy variant is that this could be associated with the diabetes mellitus and heart disease. The diabetes mellitus and association with heart disease could be the ones that are to be remembered for myotonic dystrophy. And in these patients, EMG of the patient, electromyography, might be showing what is called as a dive bomber effect. That's a EMG finding for this disease. This is a congenital disorder. Then myotonia can also be seen in a channelopathy. The channelopathy with which myotonia is encountered is called as hyperkalemic periodic paralysis. You know the fact that hyperkalemic periodic paralysis is actually not a potassium channel defect, but it is actually a sodium channel defect. It is a SCN4A defect. There is a gain of function present here. And a third cause for myotonia is again a pediatric presentation and is a variant of hyperkalemic periodic paralysis. The disease is called as paramyotonia congenita. So I have today taught you a couple of causes for myotonia, which is a sudden contraction followed by slow relaxation of muscles. That is myotonic dystrophy, hyperkalemic periodic paralysis, and paramyotonia congenita. Both are sodium channel defects, SCN4A. I hope you recall that SCN5A is the one that we have discussed in cardiology, that is Brugada syndrome, which will be having a cove pattern of ST segment elevation and is a channelopathy related to the heart per se. So two aspects have been highlighted here, myotonia versus myoclonus. Coming to the next slide, we will revise regarding a disease by the name of amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is also called as motor neuron disease. Let us study what is the cause of this. Though there are multiple causes ascribed to it, we will look at the common ones which MCQ wise you should be knowing. Motor neuron disease is related genetically to hexanucleotide repeats. Like traditionally you read about trinucleotide repeat disorders like Huntington's chorea, and you read about Fragile X syndrome or myotonic dystrophy, but motor neuron disease is related to hexanucleotide repeats. Now let us see what happens. In this condition, the enzyme by the name of superoxide dismutase activity is significantly reduced. The function of superoxide dismutase is that it is able to neutralize the activity of the free radicals which are continuously produced in our body, and because now the activity of the enzyme is reduced, the free radicals are free to cause damage to the spinal cord and pyramidal neurons. In this particular disease, what's going to happen is that the free radicals would be causing damage to the anterior horn cell. This is the representation of muscle spindle, nerves going into the spinal cord, completing the circuit here. What I am saying is, in this particular disease, there is damage to the anterior horn cell. Like this cell that I am marking now is the anterior horn cell. This is the one that is damaged. Because of the damage to this particular cell, the entire normal circuit will be affected and the current will obviously not be able to flow in the circuit, which explains that the anterior horn cell damage in the patient will contribute to manifestations of rather I would say lower motor neuron manifestations to develop in the patient. Therefore, in patients of motor neuron disease, one of the manifestations that always occurs is called as SMA, that is spinomuscular atrophy. The Clinical profile will be that of gradual onset weakness of the arms and the legs of the patient. You can see the extreme emaciation of the patient. You can see the wasting of the muscles present in the patient. If you are using a abdominal binder in this patient, maybe for feeding, why? Because these persons are even having a bulbar palsy, and you can see the visible distress with accessory muscles working overtime to maintain the ventilatory function, because a lot of these patients have diaphragmatic paralysis and they die within 2 years of diagnosis due to respiratory involvement. Spinomuscular atrophy is a term that will be a variant of motor neuron disease, which will be having manifestations of lower motor neuron lesion. The patient will always be having a gradual onset weakness in arms and legs. This weakness will be asymmetrical and it will take months and years to manifest. Unlike Guillain-Barré syndrome and transverse myelitis, which will progress very fulminantly, here the progression of the disease is very slow. There can also be a possibility that in this disease, the pyramidal neurons in area of 4 of the brain can be affected, due to which upper motor neuron lesion will develop in the patient. Therefore, you will notice that now the question will mention that the patient is having a spastic weakness with breast DTR, and there might be Babinski sign given in the question. There could also be a possibility that in this disease, both pyramidal neurons and the anterior horn cell for SMA and pyramidal neurons in the area 4 of the brain, both can be affected. If both are affected in the patient, then the disease profile is called as amyotrophic lateral sclerosis. This was the disease that Stephen Hawking was suffering from. Stephen Hawking was having a combination of lower motor as well as upper motor neuron features, and he was totally wheelchair bound. If you look at his picture before he actually died, you can notice a very emaciated person with muscle wasting. This person would be having fasciculations of the tongue. You can notice the tongue fasciculations, twitching occurring in the patient, extreme emaciation, muscle wasting occurring in a patient. Tube feeding might be required for this particular patient. So for Stephen Hawking, I would like to say that the gray matter of the brain was functioning normally, so cognition was still normal and he could still read from his laptop right till the very end. So gray matter is normal in this condition, and the person is having paralysis of whole of his body muscles. The eye muscles in this condition are normal, unlike in myasthenia gravis where eye muscles are involved, and the personal hygiene of the person is maintained in a sense that bladder and bowel function of the patient remain normal till the end. So the hygiene part is maintained in the patient. Except for these three, I would say that the whole body is totally wasted. The person is wheelchair bound, patient cannot do his own task, and diaphragmatic paralysis would set up in a patient. And you might get a question in which he might describe that the patient is having a Babinski sign with areflexia. Now this is very, very surprising because Babinski sign has to be associated with development of breast DTR. But if you treat Babinski sign with areflexia, that is combination of lower motor, upper motor in a single patient, the disease is MND, which is to be remembered, which is due to less superoxide dismutase activity secondary to genetic reasons. Most patients of motor neuron disease will die due to respiratory paralysis. There is no treatment available for this condition at the moment. Stephen Hawking, the scientist, however, he was instrumental in ensuring that we are able to do drug treatment for the patient. In fact, Stephen Hawking was the longest surviving, I would say, person with motor neuron disease. He was told way back in 1975, you will die within 2 years of diagnosis, and he died in 2018. So the drug that we use for this particular condition are two. One of them is riluzole. And within 1 month of his dying, he died in April 2018, and May 2018 there was a question that the new drug which has been allowed for this condition is edaveron. So these are two new drugs which are to be remembered for this medical condition, riluzole and edaveron. The topic was motor neuron disease. I highlight once again the gray matter function of this patient is perfectly normal, and you will better appreciate this disease if I compare this with Alzheimer's disease 4As. In Alzheimer's disease, you will notice that the muscle mass of the body is preserved, but he can't use it. Why? Because there is obviously a amnesia, a forgetfulness. He does not even know his own address and cell phone number. He will not be able to even tell you his cell phone number if you ask him, because there is a atrophy of the dominant parietal lobe, aphasia. If you ask him to write down his mobile phone number or key in the mobile phone number in your cell phone, he can't do it. Apraxia. They cannot understand the numbers and the sequence that you and me can understand. And for this guy, he would be urinating at the area where he's eating food, or in fact food is in front of him, he doesn't know how to eat, and he will urinate in that area. So anosognosia implies inability to appreciate a neurological illness. I repeat again, inability to appreciate something wrong in his body in patients of Alzheimer's disease. If you check for the deep tendon reflexes in the patient, it is normal. The tone of the muscles in the patient is perfectly normal. Yeah, due to inactivity, muscle wasting will set up in the patient. Due to inactivity in the patient in the later stages, pneumonia will also occur in the patient and will contribute to death. But look at the two contrasting disorders. In one, you are finding that the patient can use his body the way he wants, but then the gray matter is gone. And in motor neuron disease, it is rather that the patient's gray matter is functioning fine. He can do reading. He can work from a laptop. His eye muscles, eye coordination movements are there, but look at the emaciated appearance of the patient. Look at the tongue fasciculations, which are a very characteristic feature of lower motor neuron lesion, which are present in the patient. Most patients die within 2 years of diagnosis, but Stephen Hawking survived fairly long. That's one, because obviously in America medical care is good, plus obviously these drugs would have been used in him. For Alzheimer's disease, if they ask you what is the screening test, the screening test to be remembered is MMSE score, that is mini mental score examination. In MMSE or mini mental score examination, there would be 30 items tasks that would be given to the patient. If he scores less than 24, it is dementia. Definition of dementia is mini mental score examination value of less than 20. 21 to 24 is mild dementia. 10 to 20 is moderate dementia, and less than 10 would obviously be severe dementia. In severe dementia, patient will be so unhygienic that even his family members might talk to you, the doctor, I think my father has Alzheimer's disease. The investigation choice for this condition, however, is functional MRI. For treatment of this condition, the drug of choice is donepezil. There are other drugs which are also used in this condition like rivastatin and galantamine, but the DOC part is to be answered as donepezil. In Alzheimer's disease, the protein that will accumulate inside the neurons is called as tau protein. The pathological correlate to be remembered is Hirona bodies. Remember that in this condition, the chromosome that could be responsible for Alzheimer's disease could be chromosome 1, 14, 19 and 21. The genes which are related to these are presenilin 2 for chromosome 1. It could be presenilin 1 for chromosome 14. For chromosome 19, you have to remember regarding ApoE4. That's very surprising. Apolipoprotein E4. Normally, apolipoproteins are related to heart disease, but ApoE4 for CNS manifestation Alzheimer, and amyloid precursor protein, APP amyloid precursor protein for chromosome number 21. So remember that in patients of Alzheimer's disease, there are some classical manifestations which are to be remembered, and this disease will affect mainly the gray matter, whereas motor neuron disease will not affect the gray matter but would contribute to physical wasting due to damage to the pyramidal neurons or in the anterior horn cells in the spinal cord of the patient. Okay guys, coming to the next aspect in endocrinology, you can notice a very characteristic feature of enlargement in the size of the hands of this patient. The image here is highlighting that the patient is having presence of spade-like hands, and this is a very characteristic feature that is encountered in patients of acromegaly. Now you know that acromegaly would be having a pituitary adenoma that would be causing excess production of growth hormone. So the question was one asked as what is the screening test to be done for this condition, and then they've asked the best test to confirm the diagnosis. For screening of these patients, you would be checking for somatomedian levels, that is insulin like growth factor 1 levels, which would be hiked or elevated in this patient. Somatomedian will promote the somatic growth. But if the question is asked about the investigational choice for this condition, then the test to be answered is glucose challenge test, which looks very surprising initially because I have not described glucose challenge test for diabetes mellitus where I've said HbA1c, but glucose challenge test for acromegaly. Why? Because the basic function of growth hormone is that it increases the value of growth hormone increases the value of glucose in our body, and glucose exhibits a negative feedback on the release of growth hormone, which is the fact that if you give glucose challenge to a person, the growth hormone levels can be suppressed in a normal patient. But here when you administer glucose, you will notice that there will be a failure to suppress growth hormone because obviously a pituitary tumor will not respect physiology. So glucose administration in this particular case will be exhibiting a failure to suppress growth hormone production. Traditionally, you can suppress growth hormone levels to less than 1 nanogram per liter or lesser, but here you would be having failure to reduce it to less than 1 nanogram. The values would remain persistently elevated. So that's the statement that I want you to remember. Failure to suppress growth hormone levels, the values would always be in excess because the tumor is obviously not going to respect I would say the physiology component. So the IOC for this patient is glucose challenge test. To shrink the pituitary of this patient, you will have to use octreotide, and you will even have to use lanreotide for these patients. That is a long acting format of octreotide which is given subcutaneously, but this will only shrink the pituitary. The main treatment for this guy, because anyway the pituitary tumor can be causing a bitemporal hemianopia, would be to go in for a transfemoral surgery. And because in this condition recurrence can occur, so for recurrence you could be using multiple drugs, but one of the important drugs to be remembered is pegvisomant. Why? Because this will block the effect of the growth hormone. It is a growth hormone receptor blocker. Though when you block the action of the receptor, the values of growth hormone will tend to increase, but the point is it will still not be able to act because you have blocked the receptor per se. This is however only to be answered if there is a recurrence of the tumor in the patient. So the treatment protocol for gigantism and treatment protocol for acromegaly would remain the same. There's a pituitary adenoma, and for both of them the IOC is glucose challenge test, and the screening test happens to be IGF-1 levels. In fact, in endocrine system, all that matters mainly, I would say like this, is that are you able to remember the aspects of investigational choice. I'll just show you one more image for acromegaly, and then we'll remember the IOC for each one of them. You can notice that the jaw line of the patient as compared to earlier has become more prominent. So one of the very characteristic features that you will notice in these patients would be development of prognathism. The hands of the patient, the feet of the patient will also become big. So there would be increase in the thickness of the finger of the patient. So if the person is using a ring in the hand, then the ring might get impacted. The toes of the patient will increase in size. Then the size of the foot of the patient will increase. Foot size will also increase in the patient. So the bottom line is that in patients of acromegaly, peripheral parts of the body will increase, and this person will be having very long gorilla-like arms, I would say. Then one of the very good parameters to monitor the growth of these patients is what I've just shown before you, that is heel pad thickness. This heel pad thickness indicates somatic growth. So to monitor growth in patients of gigantism, you can obviously be using the height of an individual. Because gigantism, the child will increase in height very fast, but to monitor growth in acromegaly, you cannot monitor size of hands and feet, because that is different for everybody, race wise, gender wise, etc. So to monitor growth in a case of acromegaly, it is not the value of the growth hormone that is to be remembered, but it is heel pad thickness which is to be remembered for the patient. And any values of heel pad thickness in excess of, I would say, 20 23 millimeter going up to 30 millimeter, that would be suggestive, obviously not diagnostic, but would be suggestive of more than 23 I said, would be suggestive of presence of acromegaly in a patient. So let us quickly revise the investigational choice for the various endocrine tests. One of the questions that is usually asked is investigational choice for various endocrine tests, and if you know that, I would say like this, that you know the topic of endocrinology, so that's why I'm gonna just make you practice this. So let me just quickly jot down the routine endocrinological conditions, and meanwhile in your mind you can revise the IOC for these, because I'll start writing them right away. Then the comparisons should also be remembered, because pheochromocytoma is usually compared with the chromophenoma, that is carcinoid syndrome. So diabetes mellitus, then acromegaly, gigantism, prolactinoma are some of the conditions where they can ask you how would you diagnose the condition. So let's have a list here and then we can keep on adding. For diabetes insipidus, the investigational choice is water deprivation test, and the counterpart of that would be called as water loading test with respect to SIADH. The interpretations would be that in a patient of diabetes insipidus, when you do a water deprivation, normal person, the osmolality of the plasma should increase. But in diabetes insipidus, you will have no change in the urine osmolality. That would be because the antidiuretic hormone is either not there or is not able to act primarily. Then for Conn syndrome, the investigational choice would be called as saline infusion test. This is relatively safer than a salt loading test. So it's not that salt loading test is not to be done, it is also done, but the sudden rise of blood pressure can sometimes be a headache for you to manage. So saline infusion is a safer one as compared to salt loading test. For Addison's disease, the test to be done is ACTH stimulation. Since most doctors are able to answer this, you will notice that in questions he might say the word cosentropin test. Pheochromocytoma, it is a plasma fractionated metanephrine levels. So do not answer vanillyl mandelic acid. I highlight that again. Vanillyl mandelic acid levels in the urine are to be done for evaluation of neuroblastoma and not for pheochromocytoma. For carcinoid syndrome, however, you would be checking in the urine for 5-HIAA, that is hydroxyindole acetic acid, and for atypical carcinoid, hydroxytryptamine. So HTP is hydroxytryptamine, HIAA is hydroxyindole acetic acid for carcinoid syndrome. This would be serotonin end products. Diabetes mellitus is obviously standard HbA1c for long-term control, and if he says what test is done for determining short-term control in diabetes mellitus, the answer should be given as serum fructosamine, short-term control. Long-term control is HbA1c, severity is HbA1c. For acromegaly and gigantism, it will be a glucose challenge test. For screening purposes, however, you will be checking the values of IGF-1, that is insulin-like growth factor 1. For prolactinoma, you will obviously check for serum prolactin levels, and you will also do a MRI head to locate the tumor, which could be a micro or a macroadenoma, and then a proportional treatment can be done for the patient. So these are a couple of conditions which you basically need to remember, and the IOC part is obviously something that is to be remembered. For thyroid, it's obviously thyroid function test, so the aspects of thyroid I'll be discussing separately with you. Moving on, when it comes to diabetes mellitus in a patient, you have to remember that the types of diabetes mellitus can be type 1 diabetes, then could be type 1.5 diabetes mellitus, then could be type 2 diabetes mellitus, and MODY. There are 4 types of diabetes mellitus that you encounter. MODY itself is of 6 varieties that are represented as MODY 1, 2, 3, 4, 5, 6, out of which the most common variety that is seen is MODY 3. When it comes to type 1 diabetes mellitus, if you check the radio immunoassay insulin levels in a patient, there is insulinopenia, and the reason for this insulinopenia would be that the beta cell mass of the individual is reduced. And why is the beta cell mass reduced in the patient is primarily due to either autoimmunity, and after autoimmunity, the important cause to be remembered MCQ wise is fulminant diabetes. The fulminant diabetes would be caused by a virus by the name of Coxsackie B. So Coxsackie B virus is responsible for development of fulminant diabetes in a patient, and presentation would be child. 1.5 diabetes also, the radioimmunoinsulin levels will show a reduction. The beta cell mass in this patient can again be reduced, and the leading cause for this would be autoimmunity again, that is anti-glutamic acid decarboxylase antibody and islet cell antibody. Type 1.5 diabetes is adult onset, so type 2 is also found in adults, 1.5 is also seen in adults, but in type 2 there would be a weight gain, type 1 will be having a weight loss. In type 2 diabetes, in the early part of the disease, because the receptor is defective, the beta cell mass is normal in the patient, but because of the defect of the receptor in the patient, which is due to genetic reasons, the pattern of inheritance of type 2 diabetes is polygenetic, so there is a receptor resistance, so the values will increase. But in the later part of the disease, type 2 diabetes mellitus is characterized by beta cell exhaustion. Therefore, you will notice that the drugs like sulfonylureas will stop working. In the later part of the disease, even type 2 will be having insulinopenia because of the beta cell exhaustion in the patient, and therefore the sulfonylureas will stop working and you will have to start giving insulin to the patient. You would have noticed in type 2, late part you give insulin. Earlier, a patient is educated one, suppose. He might ask you, the doctor, you told me my receptors are defective, then how is insulin working? So you have to explain to him that in the later part of type 2, insulin works because the receptors of the patient are anyway malfunctioning, but beta cells are exhausted. There is a insulinopenia, so we have to make up for the deficient hormone, and the results are not very good because receptors are anyway malfunctioning. For Moody, you have to remember that the levels of radioimmunoassay in the patient can be lesser, but the beta cell mass is reduced in the patient. One of the highlights of Moody is that the gene responsible for production of insulin, that is CTG gene, that is significantly affected. So since in the patient the insulin producing gene is not working properly, the levels of insulin is lesser, but autoimmunity wise there is no problem. The reason for this is autosomal dominant. It has a polygenic modality of inheritance. The most common variety of MODY is MODY 3. Overall, if he says which is the most common subtype of diabetes, it is type 2 diabetes. And if he says which is the rarest type of diabetes, then it is MODY. And if he says that amyloid deposits can be found in beta cells in which of the following, then amyloid deposits can be found in type 2 diabetes. Amyloid deposits, normally we read about amyloid deposits in multiple myeloma, AL variety, but amyloid deposits can be found in beta cells of pancreas in patients of type 2 diabetes mellitus in a patient. Once you remember the various varieties of diabetes, with the most important question here being fulminant diabetes, which is caused by Coxsackie-B, we have to remember the sites of insulin administration, and the insulin administration would obviously be the periumbilical area, the anterabdominal wall, anterolateral aspects of the thigh, anterolateral parts of the arms can be used in the patient, buttocks can be used, but then obviously I would say the fact that fat absorption would fats in the buttock will interfere with the absorption part, but dorsum of hand is not used, as was the standard question. If he says what is the best method of delivery of insulin, like you will inject at the following sites, but the delivery is continuous subcutaneous insulin infusion. Continuous subcutaneous insulin infusion is a microprocessor based device that is called as insulin pump. And where do you put the insulin pump? On the anterabdominal wall. The hardware can be the patch is put on the anterabdominal wall, and the computer can be kept in the pocket of the patient. Patient can keep on monitoring the device, and obviously when a person can wear this device round the clock, and it will deliver a basal as well as a bolus insulin. Apart from this, another method of delivery of insulin can be an insulin pen also. So insulin pen can be used like the one that I've used here. The image here shows an insulin pen. Look at the needle, right? Very fine needle. This is 31G, and it is such a fine needle that it is a painless and a bloodless delivery of insulin. So therefore, even children can be using this insulin pen, and it's easy to use because it has a digital display. You can see the markings there. So the amount of insulin can be very strictly and very, I would say, accurately regulated. Or you can put the insulin, I would say the insulin pump. This looks like a pager, is is worn on the jeans of an individual, clothes of an individual, and the patch on the inter-abdominal wall will continuously deliver insulin, basal as well as bolus for the patient. Now, once you know regarding the deliveries of insulin which are subcutaneous, then you should know regarding the types of insulin also. And one of the important type of insulins which are to be remembered and are asked are glargine and detemir. Though if they ask you that which is the longest acting insulin, then the longest acting insulin to be remembered is degludec. This one injection will work for a huge 42 hours. But glargine and detemir are called as peakless insulins. The advantage of peakless insulins would be something like this, that when you give the injection, the medicine would be working for a longer duration, unlike others where when you give, they'll have a spike like this, then the effect would go down. So you will require multiple shots with short acting insulin. But peakless insulins are like glargine, detemir, which will ensure that the results are better. And the advantage is that you can give them once a day, bedtime. The disadvantage is can't mix them. Then we obviously have these other pre-mixed forms which are available, and most of the time in our practice we are using the pre-mixed 70-30 or 75-25 parameters that are being used. One of the big disadvantages of giving insulin to any individual is hypoglycemia. The second side effect after hypoglycemia would be weight gain in a patient. You would have seen that people who regularly use insulin will always come back to you and tell you regarding the weight gain component. Hypoglycemic attacks can make a person feel very nervous and fidgety and angry. The cutoff for hypoglycemia is 54 mg/cent, and this can include sympathomimetic symptoms like palpitations and tremors. So don't give beta blockers. Beta blockers are contraindicated in patients of diabetes mellitus because they can mask the symptoms of hypoglycemia. And suppose a diabetic is not taking beta blockers and he is having the sympathomimetic symptoms which are persisting in spite of sugar intake. Like let me say, he gives you a scenario. He says person is having hypoglycemic attack which is persistent. That is, palpitation, tremors are persistent in spite of sugar intake. He ate a brownie, he ate a chocolate, he took an eclair, he had sweetened milk, and still the symptoms are persistent. Then you have to rule out the possibility of silent myocardial infarction in a patient, because a lot of these patients could be having diabetic neuropathy coexistent and may not perceive the chest pain. So you have to be a little careful. Then there's a table that I mentioned here before you, which I would like to say is a must for you because they can obviously ask you the pharmacological aspect of it. Rapid acting insulin is Lispro. That is the brand name that we use as Humalog, or Novolog is Aspart. These injections will start working within 15 minutes. So they have to be usually taken around 15 to 20 minutes before breakfast, lunch and dinner. And the total duration of action would be something in the range of about 3 to 5 hours. So the advantage of these molecules is that they will counteract the postprandial spikes. When you eat food, whatever food is containing carbohydrate, that carbohydrate can be neutralized. The postprandial spikes can be neutralized by rapid acting insulin. When it comes to short acting insulin, the short acting insulin like Actropate, the advantage is that it can be given intravenously also, and because intravenous format is available for these, so emergencies like ketoacidosis, emergencies like acute hyperkalemia, and emergencies like non-ketotic hyperosmolar coma, you could be using these molecules. Then NPH and Lente, they can be combined with short-acting insulin, but long-acting they obviously cannot be combined, but they will give you advantage of long duration. In fact, like I mentioned, though in this table degludec is not given, but degludec will be working as long as 42 hours. Pre-mixed forms are commonly used. In fact, most of these patients who come to you would be using the 70-30 or 75-25 combination, and that is pretty decent enough for giving to your patients, which have to be taken half an hour before the meal, Humalog 15 minutes before the meal. And the advantage of this would be good glycemic control. The objective, I mean, what do you mean by good control is poor control in diabetes mellitus implies HbA1c of the patient is less than 7% is good control and more than 7% is bad control. The cutoff for HbA1c is 6.5, and if he says how much is normal HbA1c, then the normal values would obviously be less than 5.6%. Types of insulin to be remembered: delivery of insulin to be known. Complications of diabetes mellitus could be in the form of a diabetic retinopathy. A diabetic patient will be having 25 times higher chances of going blind as compared to a non-diabetic person. In type 1 diabetes mellitus, it will take approximately 5 years, and in type 2 diabetes mellitus, it will take approximately 15 to 20 years for the patient to develop findings. Because of the fact that in type 1 it takes 5 years, so the fundus examination of a type 1 diabetic is not to be scheduled immediately, but for type 2 should be scheduled immediately because of an indolent course. Not all patients will be having retinopathy. Those who are having HbA1c of more than 7%, then it will take 5 years in type 1 and it will take 20 years in type 2 for the retinopathy manifestations to appear in a patient. There can be two possibilities in a patient. One can obviously be development of a non-proliferative NPDR, that is non-proliferative diabetic retinopathy, and second could obviously be proliferative. In non-proliferative, you could be having these dot blot hemorrhages, like you know that when it comes to hypertension it is flame shunt hemorrhages, and for diabetes it is dot blot hemorrhages. There could be hard exudates present in a patient. Earliest manifestation, however, is microaneurysm formation. Microaneurysm formation in a diabetic is the earliest manifestation, and the layer of the retina that is usually involved is the inner nuclear layer. It is usually the outer plexiform and the inner nuclear layers that are usually involved in diabetic retinopathy. Then if it is proliferative retinopathy, you can very well see the new vascularization which is occurring, and this is a disaster because this is definitely going to contribute to a retinal detachment in the patient. The problems in this patient now would be: one, a high risk of development of vitreous hemorrhage. And the second problem that can be anticipated in this particular individual would be a retinal detachment. And because you know the fact that retinal detachment can occur and blindness will occur, so our objective would be to prevent this blindness from occurring. So now let us look at what will you be doing to prevent this blindness from occurring in a diabetic patient. To prevent blindness, your answer would be given as obviously a good sugar control is mandatory, but that never happened, right? I mean, there is no point crying over a spilled milk. Ideally, if HbA1c was less than 7%, this would have not occurred in the patient. Since the patient did not listen to you, you have to fire a laser beam panretinal photocoagulation. The heat of the laser beam will seal the bleed. It will destroy the abnormal blood vessels and would help in preventing blindness. Plus, we will be giving intravitreal shots. These intravitreal shots will be given of bevacizumab, and this injection intravitreal will prevent the development of new blood vessels in the retina of the patient. So these are approaches to prevent diabetic retinopathy, and the progression of retinopathy mirrors that of nephropathy, because retinopathy and nephropathy progress with the same speed. Therefore, I would like to say the fact that you have to be monitoring both retinopathy and nephropathy simultaneously. One of the parameters to monitor both of them simultaneously would be to go in for serum creatinine, but then the problem is that serum creatinine takes a long time to rise. So they have asked that what test can be done to monitor the retinopathy of the patient. So one of the tests that can be done to monitor the retinopathy of the patient is homocysteine levels. Elevated homocysteine levels will be definitely useful to monitor the progression of retinopathy. Then would obviously be creatinine clearance of the patient, because as the creatinine clearance will begin to reduce and as the serum creatinine will begin to rise, the retinopathy of the patient will also be progressive. For the nephropathy part, however, if he says like if this is what is happening in the patient, then for the nephropathy perspective, you will have to one, evaluate the patient by UAC, that is urinary albumin creatinine ratio. UAC is urinary albumin divided by urinary creatinine ratio. The urinary albumin or creatinine ratio, if it is in excess of 300 milligram per gram of creatinine, it tells you the fact that the kidneys are already damaged in the patient. The current Harrison does not use the word microalbuminuria, but instead of using microalbuminuria is using the word UAC, that is urinary albumin creatinine ratio, and higher is the value, obviously more is the damage in the kidney. And I mean, the patient is saying, sir, my creatinine is borderline, you telling me my kidneys are damaged. So you would tell him that well, serum creatinine is the most specific test for diagnosing kidney damage, but creatinine takes time to rise, so I'm not gonna wait that long. I'm gonna give low dose ACE inhibitor to the patient, and this will reduce the progression of the damage to the kidney of the patient. So usually we will start the patient on, like for example, a 2.5 milligram tablet of ramipril cardase, and this will reduce the progression of diabetic nephropathy in a person who's simultaneously having a retinopathy as well, because both progress with the same speed. If he says what is the screening test for nephropathy, the answer is UAC, urinary albumin creatinine ratio. Higher is the value, more is the damage to the kidney, and initiate treatment ASAP in the patient. Why? Because you want to slow the progression or damage to the kidney of the patient. Then they have given a manifestation of diabetes which is very easy to identify, the hyperpigmentation that you can notice at the back of the neck of this guy. This would be called as acanthosis nigricans. You know the fact that acanthosis nigricans can also be encountered in women with PCOD. It is obviously encountered with patients of type 2 diabetes mellitus, and Steve Jobs, the Apple guy, the Apple founder, he also started having this manifestation of blackening of the skin. White guy having blackening of skin was very prominent, and his physician on a priority basis got a CT abdomen. He had advanced pancreatic cancer, he died because of it. So pancreatic cancer, colon cancer, they are also having acanthosis nigricans. So this can also be remembered as a cutaneous manifestation of internal malignancy, though internal malignancies can result in various skin manifestations, but this is one of them that I want you to remember, that pancreatic cancer, colon cancer can cause acanthosis nigricans in a patient. A related MCQ to be remembered is a skin manifestation that is asked with respect to glucagonoma. That would be also having a very high blood sugar, glucagon tumor. That would be necrolytic migratory erythema. So I have today taught you two conditions where blood sugar will be high, that is diabetes and glucagonoma, and the skin manifestations of the two is different. Coming to this slide, guys, even if the history is not given, you can notice the orange discoloration as well as a patch appearing on the pretibial area. The diagnosis of this patient is pretibial myxedema. Even if in the question heat intolerance, palpitations, tremors, sympathomimetic symptoms, hypertension is not given in the question, you should definitely be able to pick it up, because this lesion would be found in patients having thyrotoxicosis, especially patients of Graves' disease would be having pretibial myxedema. You all know that myxedema is not only seen in hypothyroidism but in hyper also. Then you will notice a lesion which has been given for a diabetic patient again, in which you can notice the central clearing. The lesion is present on the shin of the patient, but you are noticing there is a central clearing present in the patient. The lesion would be called as necrobiosis lipidoica diabeticorum. You see, if I begin the question by saying necrobiosis lipidoica diabeticorum is encountered in, obviously you will answer diabetes mellitus, and mostly it is type 1. Young females of type 1 can be having it. But what I am saying is that he might give you a lesion like this on the shin of a patient, mention that the person is diabetic, the lesion is necrobiosis lipidoica, whereas the lesion shown on the back of the neck was obviously acanthosis nigricans. For the last image, I want you to remember that this is a patient of inflammatory bowel disease, and you can notice a lesion on the shin. Horrible looking ulcer kind of lesion, no? So this would be called as pyoderma gangrionosum. For today, I have explained to you 3 lesions related to the shin of an individual. That would be pretibial myxedema or orange discoloration versus a lesion with the central clearing, and necrobiosis lipidoica diabeticorum for diabetes. He will mention diabetes for this question, and then a very horrible looking ulcer on the shin, that is pyoderma gangrenosum. So ulcers are definitely asked in the exam. So traditional ulcers that you read are obviously venous ulcer or arterial ulcer. You know the fact that venous ulcer is obviously present on medial malleolus, and usually the cause of this would be varicose veins. He can give you an example of a neurosurgeon. He can give you a traffic policeman, prolonged standing, which is responsible for this manifestation. Arterial ulcer is found on the dorsum of the foot where the dorsalis pedis artery is. So most of the time the peeling of the skin or the blackening of the skin would not only be of the toes, but there would be ulcer on the dorsum of the foot of the patient, most of the time at the site of the dorsalis pedis artery, and this would be a patient of thromboangiitis obliterans. Then there could also be a neuropathic ulcer. Neuropathic ulcer could be present in hands of a patient. That would be a patient of syringomelia, where there is loss of pain and temperature sensation, so non-healing ulcer can develop in the hands. But if he gives you a picture of the sole of the foot, especially either on the heel or on the metatarsal heads of a patient, then the ulcer that develops in the patient would be obviously in diabetes mellitus. Then if he gives you a lesion of shin of an individual and the ulcer is on the shin in a heart disease patient, we call it Martorell ulcer. This would be found in patients of coronary artery disease with hyperlipidemia. Then you could be having a lesion on the shin by the name of pyoderma gangrenosum, which would be the most horrible of them to look like, right? So the yellowish appearance would be purulent, so pyoderma. This would be in ulcerative colitis and Crohn's disease in a patient, again on the shin of the patient. And then you could be having a lesion on the shin that I just explained to you, two of them more. One of them is pretibial myxedema and another one is necrobiosis lipidoica diabeticorum. I'm just writing necrobiosis diabeticorum for you to remember. These are again lesions on the shin of the individual. The inferior three are lesions located to the shin, and the superior are obviously present on the medial malleolus or on the dorsum of the foot or on the hands of an individual versus sole of. Once you have remembered this information, then we will look at the next disease, which is again very characteristic, and you can notice the fact that the patient is having hyperpigmentation of the tongue. The tongue is turning black. You can also notice that patient is having hyperpigmentation of the palmar and the sole creases. The moment you read this information, hyperpigmentation of the palm and the sole creases, the moment you read about hyperpigmentation of the tongue of the patient, the thing that comes to your mind is that patient is having Addison disease. The diagnosis of this patient would be kept as primary Addison disease. One of the most important reasons for primary Addison disease in any particular individual would be autoimmunity or autoimmune destruction of the glands. From the infection perspective, it is HIV. For India, it is obviously tuberculosis, but if they ask you global infection, then Harrison 20th update is that now he has mentioned HIV is exceeding TB on global basis. For India, obviously tuberculosis, there is no doubt about it, but on global perspective, it is HIV more than TB. Overall, the most important cause is autoimmunity. Overall, the most common infectious cause is HIV. For primary Addison disease in a patient, you will always be noticing a very characteristic manifestation of postural hypotension. We have studied hypertension systemic, that is 140 by 90. AHA guidelines 2017 was 130 by 80, but that has been rejected. So hypertension is 140 by 90. Pulmonary artery hypertension is 25 millimeter at rest and 30 on exercise. And postural hypotension is defined as that you will first check the BP of the patient in supine position, then check the BP of the patient in standing position, and you will give a time lag of 3 minutes in between for the compensatory mechanisms to act. If on change of position from supine to standing, if you notice that the systolic blood pressure of the patient is falling more than 20 millimeter and the diastolic blood pressure of the patient is falling more than 10 millimeter, you are going to call it postural hypotension, and appropriate management of the patient is to be done. Postural hypotension can be seen due to multiple reasons. One of the important causes of postural hypotension can be Stokes-Adam syndrome or third degree heart block. So cardiovascular cause to be remembered is Stokes-Adam syndrome. But postural hypotension can also be encountered in diabetes mellitus, that is due to diabetic autonomic neuropathy. And then an endocrine cause again where postural hypotension is encountered is Addison disease due to deficiency of aldosterone in the patient. If he says ideally what is the test to be done, then the test to be done is called as tilt table test. Actually, we don't let the patient stand. In government hospital, you make the patient stand. He can fall down also, injuries can occur, and poor patient can't say anything. But in Western countries or in corporate setup, there's a proper bed that has to be elevated, ensuring patient does not fall. And the patient is restrained, and the moment you turn the patient, he becomes unconscious. So tilt table test in the patient is the ideal way to identify postural hypotension. 3 important causes to be remembered are third degree heart block, diabetes mellitus, and Addison disease in a patient, and along with this they would also be having hypoglycemia. How would you identify primary Addison disease in a patient? You will be doing a screening test for the patient, the screening test for Addison disease. While I write it, I give you an opportunity to pause and think, what is the screening test? The answer would be given as ARR, that is a plasma aldosterone renin ratio. In this particular condition, when you will check for the plasma aldosterone and the plasma renin ratio in the patient, so if they ask you what is the investigation choice for this condition, the investigation choice for this condition is co-syntropin test or ACTH stimulation test, where ACTH will fail to stimulate the gland because the gland has been destroyed by tuberculosis or other causes that I have mentioned. Once you identified the condition, if he says what is the drug of choice for Addison disease, the answer is given as hydrocortisone. Yes, initially for management of hypotension, I will give fludrocortisone. For hypoglycemia component, I will be giving dexamethasone for the patient, but DOC is hydrocortisone. If it slightly twists the MCQ as secondary Addison disease or as tertiary Addison disease, then remember that in secondary Addison disease, we are calling it secondary because problem is in the pituitary. In secondary Addison disease, the manifestations will be only of hypoglycemia because ACTH stimulates the second layer of the gland, and therefore the second layer of the gland is not working properly. So therefore hypoglycemia will ensure in the patient. For management of secondary Addison disease, the drug of choice to be given to the patient is dexamethasone. And tertiary Addison disease will damage the hypothalamus. So what's going to happen is CRH will be less, ACTH will also be less. ACTH stimulates the second layer of the gland, so cortisol will also be less. Due to deficiency of cortisol, therefore hypoglycemia will be the main manifestation. The learning is that if the question begins by saying what is the treatment for primary Addison disease, then for primary Addison disease it is hydrocortisone. But if the question mentions secondary or tertiary Addison disease, then the answer should be given as dexamethasone. And for crisis, obviously, if it is Waterhouse-Fridson syndrome, then intravenous hydrocortisone will be administered to the patient. You cannot have a hyperpigmentation in secondary and tertiary variety of Addison disease, because in secondary Addison disease, example can be like Sheehan syndrome. So ACTH will be less, so you can't have a hyperpigmentation. And tertiary Addison, again ACTH less, so you can't have a hyperpigmentation. I hope you recall the fact that ACTH in the body behaves like MSH. A part of this hormone that is produced behaves like MSH and causes hyperpigmentation. That is why you are having this hyperpigmentation of the palmar and the sole creases, which is a characteristic feature of Addison disease. You can notice the hyperpigmentation of the tongue. You can see the palmar creases, sole creases turning black in the patient. This is only seen in primary Addison disease and is not seen with secondary and tertiary Addison disease. Let us quickly compare this disease with the Conn syndrome, which is an adrenal adenoma. If you compare the two diseases, you will notice the fact that in patients having Addison, all the three hormones will become lesser. That is, aldosterone will also become lesser, cortisol will also become lesser, and DHEAS, that is sex steroids, will also become lesser. But in Conn syndrome, there is a tumor or a bilateral, either it is BAH, bilateral adrenal hyperplasia, or it is a tumor in one of the adrenal glands, and the hormone that will increase in this condition will only be aldosterone. So remember the fact that autoimmunity causes damage to all the three layers of the gland, resulting in a decrease in the perspective values, and aldosterone is very high in Conn syndrome. Now Conn syndrome will obviously present with hypertension, and there will be a urinary loss of potassium and hydrogen, so there would be a hypokalemic alkalosis developing in a patient. though pedal edema is usually not encountered in patients of Conn syndrome. This is because of the salt escape. In Addison disease, however, you will be having a feature of salt wasting, salt craving, and postural hypotension to be occurring in the patient since aldosterone values are significantly reduced. In Addison disease, you will also notice the fact that the patient would be having hyperkalemia. The acidosis component may be neutralized by the buffer base. The bicarbonate in the body might be neutralizing the hydrogen ions, but hyperkalemia definitely will be noticed. And then you will notice that these patients will also start having features of hypoglycemic attacks, which is primarily because of deficiency of cortisol. By feedback mechanism in the patient, the ACTH will increase, so there will be hyperpigmentation, which I had just shown to you. And there would be loss of pubic hair, loss of axillary hair. This loss of pubic and loss of axillary hair is secondary to the deficiency of, I would say, DHEAS in the patient. Now let us look at what are the tests to be done for this condition. For the left hand side, for Conn syndrome, the screening test to be done should be remembered by you as aldosterone-renin ratio, ARR. You will notice the fact that in Conn syndrome, the aldosterone-renin ratio will be significantly elevated. Why? Because the tumor is a endogenous source of production of aldosterone in the body of this patient. So the values of aldosterone will be very high. Renin will obviously be low in this condition by feedback mechanism because the BP is very high. So this condition is a cause of low renin hypertension. The screening test to be answered for Conn syndrome should be answered as aldosterone-renin ratio. To confirm the diagnosis of Conn syndrome, obviously you would be doing a test that is called as saline infusion test, or another one is salt loading test in the patient. Medical management of the patient will revolve around spironolactone. You would be able to effectively manage the patient medically, and then surgical treatment has to be done. For Addison disease, it is co-syntropin test which is mainly to be answered. You will obviously be doing a CT scan which will tell you that there is a tumor in Conn syndrome and there is a destruction of the bilateral glands in Addison disease. Since this is a quick comparison, for Addison disease, the drug of choice for primary variety is hydrocortisone, but if we specify secondary where MRI pituitary would be required, it would be dexamethasone for the patient. Then in questions, he might even make you compare Conn syndrome with Liddle syndrome. Liddle syndrome is characterized by overactivity of epithelial sodium channel. So more salt and more water will come in the body, and there will also be an increased corresponding loss of potassium and hydrogen. So you can see the fact that patient will be having hypertension, patient will be having hypokalemic alkalosis. The reason for this being that there is a urinary loss of potassium, there is a urinary loss of hydrogen. You can see the green arrow, there is a urinary loss of potassium hydrogen, same as that in Conn syndrome. Even in this condition, because of hypertension, there will be a negative feedback to the RAS system. So you will notice that the value of renin in this condition will be less. Surprising, no? Renin is less in a hypertensive case. Aldosterone will also be less in this particular individual. That low aldosterone is basically explained by the feedback that is operating, because this disease is due to channel overactivity. There is a gain of function of the epithelial sodium channel in this particular individual. Therefore, for management of this guy, you will have to block this overactive channel, and the DOC for Liddle syndrome should be answered as amiloride, whereas the drug of choice for management of Conn syndrome would be spironolactone or aldosterone antagonist. Please appreciate why here you are not using spironolactone is because aldosterone is already less, so spironolactone will not be useful, and you will have to neutralize the action of the increased channel, that is ENaC. This channel that I'm talking about is epithelial sodium channel. This is on which the aldosterone acts on. It is present in the cortical part of the collecting duct. So you have to neutralize the overactivity of the channel by giving amiloride to the patient. Coming to the next slide, guys, we shall be talking about a thyroid scan. And whenever they ask you in a thyroid scan, they'll one ask you which radioactive dye would be used. That is 123, whereas 131 is for ablation. If you look at the first image here, that is for a cold nodule. You can notice the fact that the cold nodule indicates the fact that there is a decreased uptake, obviously, but you have to remember that cold nodule could be suggestive of presence of a malignancy. So a workup for papillary cancer or follicular cancer should be done. One of the easiest slide that you can get is either a diffuse uptake in both the sides of the gland, that is Graves' disease, or they can give you an image in which there is a significantly reduced diffuse uptake. So these are among the two easiest ones to identify, because a significantly reduced diffuse uptake is a feature of Hashimoto's thyroiditis, whereas when it comes to a significantly increased uptake, it would be the patient of Graves' disease. Toxic multinodal goiter will be having a combination of hot and cold nodules, that is overactive and the underactive nodules. But the commonest error that you can get is between a hot nodule and an autonomous nodule. So what are you gonna look? In a hot nodule, you can see that the remaining of the gland is still visualized. But when it comes to the image which is on the right side of this, you cannot notice the remaining part of the gland. There is suppression of the remainder part of the gland. So the term that is to be used by you if there is a suppression of the remaining part of the gland is autonomous nodule, and if the gland is visualized, then it is a hot nodule. What I'm saying again is that there would be two black spots available. If the gland tissue is totally suppressed, remaining gland tissue, then you call it autonomous, and if with the black spot at least some of the gland is visualized, you call it a hot nodule. So that is an interpretation of thyroid scan that you should be aware of. In the next image, I have highlighted before you a patient having a retrosternal goiter. The biggest problem with patients of retrosternal goiter will be compression of the contents of the mediastinal cavity, especially the superior mediastinum. So retrosternal goiter, the superior vena cava of the patient is compressed. So in this case, you are seeing that when you are asking the patient to raise his hands like this, what's going to happen is that the enlarged gland, it's not actually enlarging in the neck, it is enlarging in the chest cavity of the patient. So it will press on the superior vena cava, and pressure on the superior vena cava would result in extreme facial congestion. So you can notice the fact that the face of the patient is becoming totally tomato red, like I have shown here, a tomato red appearance of the face of the patient. So the term that is used to describe this is technically called as Pemberton sign, and Pemberton sign is a classical feature of retrosternal goiter. So the image here is showing a Pemberton sign which is suggestive of retrosternal goiter. Coming to the next image, which is very classical for Graves' ophthalmopathy, one, you can notice the stare sign in this lady. You can see the upper part of the cornea of the patient being visualized. That is because there is a retraction of the Muller's muscle. So if they ask you that what is the early presentation of Graves' ophthalmopathy, obviously initially there are no signs and symptoms, then signs will appear. So basic point is first signs will appear, then symptoms start appearing in the patient subsequently. And what I mean by sign appearing is there would be a lid retraction. If this is the upper eyelid, then upper 2 millimeter of the cornea, is visualized or is covered by the upper eyelid. But now I'm going to show you the retraction of the upper eyelid of the patient. So maybe the upper part of the cornea as well as some part of the sclera is visualized in the patient. If you look at the representation in this case, you can see the upper part of the cornea seen. So what I'm saying is that the Muller's muscle has contracted, and therefore there is a retraction of the upper eyelid of the patient. Then there would be soft tissue involvement causing a periorbital edema, which will make the eyeball obviously look very prominent. So stare sign. Then can be proptosis in a patient. You can understand the proptosis in the following sense. Like here I have shown before you is the extraocular muscles of the patient. These are the eye muscles. So what I'm saying is that there would be a swelling of the eye muscles of the patient, and due to the swelling of the eye muscles of the patient, what's going to happen is that the eyeball of the patient will be pushed anteriorly, and when the eyeball of the patient is pushed anteriorly, that would result in proptosis. So in Graves, the LATS antibody contributes to swelling of the extraocular muscles, which is going to push the eyeball anteriorly. So that's why proptosis would be encountered in the patient. Then one of the important muscles that is involved in the patient is inferior rectus, and due to the involvement of the inferior rectus, the next thing will develop in the patient, that is diplopia. So symptom is appearing later and sign is appearing earlier. So even if you don't remember the mnemonic, the basic concept is that first you have lid lag or a lid retraction in fact, and then a lid lag, because person cannot be following the object from top to bottom. There would be periorbital edema and a proptosis, the eyeball looking more prominent. So when the person will blink, then the upper eyelid will not be able to wash the whole cornea. So there would be drying of the cornea of the patient also, because I'll put it like this: if you see these patients, they sleep with their eyes open, they can't close their eyes because the eyeball is so prominent. And then there would be a double vision due to inferior rectus involvement. Corneal involvement is obviously, as I said, drying of the cornea, so artificial tears or methyl cellulose would be required. And last but not the least, in this condition, what can happen is that even the optic nerve of the patient can be affected. There could be a retrobulbar neuritis in the patient, and due to the retrobulbar neuritis in these patients can become blind. In diabetes mellitus, the reason for blindness in the patient is gonna be mainly diabetic retinopathy contributing to retinal detachment. But here the blindness would be that the optic nerve of the patient is getting affected by the muscles which are present here. So there is a retrobulbar neuritis affecting the exoplasmic flow to the optic nerve, and therefore blindness of the patient can appear. These are eye manifestations for which methylprednisolone would be required. Then I'll just show you two very classical presentations which I've just mentioned before you, because we were talking about appearance of the face of the patient. One, you can notice this wrinkled appearance of the face of the patient. The appearance is the one that is technically called as leonine facies. One of the characteristic feature of leonine faces will also be loss of the eyebrows and eyelashes of the patient. Like in this particular chap, you can notice that there is madarosis present. There is also saddle nose present in a patient. So leonine faces, madarosis, and then a saddle nose has been represented here. I have just shown this image here because I wanted to tell you the fact that since they're giving this appearance of the face of the patient, there's no rash, no SLE. So just a related appearance can be remembered from this image.